Good evening, everyone. Hopefully, I'm audible to all of you. Please let me know if the audio visuals are clear. For those who don't know me, I'm Dr. Omkar Sonone, and today we'll be starting with the last session of our surgery review. So, once we start the revision session, we'll be first of all covering with GIT. Then I'll be talking about the hepatobiliary system. Then I'll be talking about urology. Then we'll be concluding. Okay. So, as we need to cover a lot of topics today, we'll be on our toes. Okay, thoda bahut we will be faster. I'll be using both the languages. Don't worry about that. Okay. If you have any doubts, you can ask me as well. Hopefully, those who are new to also watch the previous two videos, so it will be more beneficial for all of you to understand. Hello. Let's start now without any further delay. It will be covered. Don't worry about that. I have just started with stomach, right? Great. Now starting with stomach, guys. If I talk about stomach, the first question to you, all of you, is a 4-week-old male newborn was brought with complaints of projectile non-bilious vomiting. On feeding, peristalsis is visible and an olive-shaped mass is felt in the epigastrium. Mother had taken which drug during pregnancy? First of all, to solve these type of questions which are complex and which are indirect, first of all, you need to pick up keywords. And what are keywords in this question? The ones that I've highlighted. It is a 4-week-old and a male neonate who has presented to you. Second keyword is there is projectile non-bilious kind of a vomiting in this child. Okay, non-bilious kind of a vomiting. On feeding, there is peristalsis which is visible, and also a olive-shaped mass is felt in the epigastrium. So these are the keywords. Okay, so what is your provisional diagnosis based on this keywords? What is your provisional diagnosis based on these keywords? I hope all of you are able to answer this. What is your provisional diagnosis? Hopefully I'm audible to all of you. Provisional diagnosis in this condition, please remember, it is a case of CHPS. What do I mean by CHPS? CHPS is nothing else but congenital hypertrophic pyloric stenosis, also known as idiopathic hypertrophic pyloric stenosis. Okay, so very good. So what has happened over here? So this is what is your stomach, for example. Okay, and we know this is the, there are various parts of the stomach. Okay, so this is the fundus of the stomach, the body of the stomach, the antrum of the stomach, and this one is your pyloric canal. So what has happened? There is hypertrophy of the muscles at the level of pyloric canal, and due to that there is narrowing at the pyloric canal. That is what is called as pyloric stenosis. Okay, so congenital or idiopathic hypertrophic pyloric stenosis. No issues with this. Now, mother taking which drug during pregnancy can lead to an increased risk of CHPS in the fetus? So the mother has taken a drug, and that is called as, this was a previous year question. Please remember, the mother has taken a drug that is called as erythromycin. So if a mother takes erythromycin during pregnancy, that increases the risk of CHPS in the fetus or in the neonate. That's important to be remembered. Okay. Important is over here, in cases of CHPS, when the child is going to present to you, as it is congenital, that means it is present since birth. But please remember, the child will not immediately present to us at birth. Over here, the child will present to us usually after 2 to 3 weeks of life. Okay, the child will present to me after 2 to 3 weeks of life, definitely, and it is more common in male neonates. Okay, that too in the first male child of the family, it is very much common. Important. What will be the complaints of the child? So we know the clinical features of the child over here. The child will have, as we have discussed already, here the child has a non-bilious kind of a vomiting. Why? Because here, as we can see, there is narrowing at the level of stomach itself. Therefore, the food or the breast milk, whichever is there, will come directly. It will have a reflux from the stomach itself. So that is the reason why definitely the bile will not mix with it. And that's the reason why there will be a non-bilious kind of a vomiting in this child. It will be a projectile non-bilious vomiting in this patient. Okay, along with that, when the mother feeds this child, there will be a visible peristalsis which is seen. Okay, so एक visible peristalsis दिखेगा इसके epigastrium में, and then when we will palpate, okay, this hypertrophied pylorus can be felt as a olive shaped lump or olive shaped mass in the epigastrium. Okay, so that's the very characteristic feature that you need to remember. Now, as the child is having chronic vomiting, so what can happen? Due to chronic vomiting, there can be a metabolic abnormality in the patient. And what is that metabolic abnormality? So that metabolic abnormality is, please remember, there would be hypochloremic, hypokalemic. Okay, so hypokalemic. Even in the initial stages, there is hyponatremia, that is decreased sodium values. Okay, hyponatremic, metabolic alkalosis. As the acid from the stomach is lost, therefore there will be metabolic alkalosis with paradoxical aciduria. Okay, and that is a very important question. So please remember, what is the metabolic abnormality in a case of CHPS? That has been commonly asked in your exam, and that you need to remember, it is this one. Okay, so that is nothing else but hypochloremic, hypokalemic, hyponatremic, metabolic alkalosis with paradoxical aciduria. That is what you need to remember properly in this patient. Okay, now usually if I investigate this child, what will be seen on investigation? If I do a x-ray, my first line investigation will be x-ray abdomen, and when I get a x-ray abdomen done, you can see I can only see one bubble in the abdomen. Okay, this is what is called as a single bubble sign. So definitely on x-ray abdomen, I'll be able to see a single bubble sign. Then if I do a barium meal of this patient, why? Because when the barium sulfate is in the stomach, then the contrast study is called as a barium meal. और जब मैं barium meal करूंगा इस patient की, then definitely I'll be able to see these important signs. What is the first sign over here? The first sign over here, you can see it is the mushroom sign. Okay, so first one we can see is the mushroom sign. Second one that you can see is known as the string sign, also called as the trolley track sign or the double track sign. Okay, second one is known as the string sign or the trolley track or double track sign. Okay, whereas this one over here which is seen, okay, this one over here, this is what is called as the shoulder sign. This one is known as the shoulder sign that you need to remember properly. No issues with this. So there are three important signs seen on a barium meal in a case of CHPS. One is mushroom sign, second is a string or a double track sign, and the third one is a shoulder sign that you need to remember properly. Okay, so these are the important signs. Then if I talk about investigation of choice, yes, x-ray we have done barium meal also, but none of them is the investigation of choice. The investigation of choice usually in a case of CHPS is nothing else but a ultrasound abdomen. Okay, so investigation of choice in a case of CHPS is nothing else but a ultrasound abdomen that you need to remember. And what will be the treatment in this child? If I talk about the treatment, please remember, सबसे पहले तो what we need to do? सबसे पहले, as the child is coming to us with a metabolic abnormality, the child is in metabolic alkalosis with all of these hypochloremia, hypokalemia, hyponatremia. Okay, so all of these features. So first of all, I need to go for correction of these metabolic abnormality, and for that they have asked you in the previous year exam, what is the best fluid for correction of these metabolic abnormalities in a case of CHPS. So please remember, what did I tell you? Initially the body suffers from hyponatremia, that is decreased serum sodium levels, but later on when the RAS system is activated, that is renin angiotensin aldosterone system, when that RAS system is activated, then the body retains a lot of sodium inside. Okay, बहुत ज़्यादा sodium body के अंदर रह जाता है, and that causes hypernatremia. That is the reason why if they ask you the best fluid, it is not the normal saline. Why? Because normal saline contains high amount of salt usually, or high amount of sodium. That's the reason why we will give half of the normal saline, and half of normal saline will be how much? The normal saline is 0.9% NaCl. So half normal saline will be 0.45% NaCl. Okay, so it is 0.45% normal saline or half normal saline. Along with that, definitely we will give what? Definitely, as the child is having chronic vomiting, he will not be able to have a lot of proper nutrition. Therefore, we will give dextrose along with it. And along with dextrose, definitely as the patient is also having hypokalemia, that is decreased serum potassium levels, so we will also give potassium from outside, and that is KCl, potassium chloride. So this is the best fluid. If this is not an option, okay, then you need to answer it as ringer lactate. Okay, otherwise the best fluid is half normal saline plus dextrose plus KCl. That was a previous year question. If that is not an option, go for ringer lactate as your best answer. But if they ask you what is the treatment of choice now, what is the surgery of choice, then definitely what we need to do, as there is a lot of hypertrophy of the pyloric muscles. We are giving a lot of incisions over the pyloric muscle. So if we give multiple incisions over the pyloric muscle, what will happen? There will be relaxation of this pyloric muscles and the food can easily pass now via the pyloric canal. तो याद रख लो, अगर अब क्या हो रहा है, बहुत ज्यादा हाइपरट्रॉफिड पाइलोरिक मसल्स है, तो उसकी वजह से क्या करना है अपने को, बहुत सारे इंसिजन देने पाइलोरिक मसल्स पे, तो उसकी वजह से क्या होगा, पाइलोरिक कैनाल जो होगी तुम्हारी या पाइलोरिक मसल जो होंगे वो रिलैक्स हो जाएंगे और खाना इजीली पास हो पाएगा. And this procedure, the surgery which is there, is known as Ramsted's pyloromyotomy. Okay, so this surgery which is there is known as Ramsted's pyloromyotomy. Please remember that. Okay, so it is known as Ramsted's pyloromyotomy. That you need to remember properly. Okay, Ramsted's pyloromyotomy. Then moving further, okay, pylorectomy nahi, nikalते नहीं हो तुम. You just give multiple incisions over it. Okay, so it is pyloromyotomy. Next important condition that I'm about to discuss is what is called as PUD. A very important condition. PUD means all of us are quite aware. PUD is nothing else but peptic ulcer disease. Okay, so PUD is nothing else but peptic ulcer disease. Now peptic ulcers can be of two sides, right? First one, it can be a gastric ulcer, or second one, it can be a duodenal ulcer. I've already told you more common ones are the duodenal ulcers. More common ones are definitely the duodenal ulcers. If they ask you which is the most common site of a gastric ulcer and which is the most common site of a duodenal ulcer, so both of us are quite aware that, please remember, the most common site of a gastric ulcer is usually this part. What is this part called as over here? This is known as the lesser curvature of stomach. Okay, so please remember the most common site for gastric ulcer is the lesser curvature of the stomach, but that for a duodenal ulcer is the first part of duodenum, that is D1. Okay, so most common site for a duodenal ulcer will be D1, that is the first part of your duodenum. If I talk about pain, okay, so that is a differentiating feature. In both the conditions there will be epigastric pain. Okay, in both the conditions the patient will have epigastric pain, whether it is a gastric or a duodenal ulcer. But important is, in cases of gastric ulcer, the patient will have pain immediately after food. That means within 30 minutes of food intake. 30 मिनट के अंदर अंदर खाना खाने के बाद पेशेंट को पेन होगा. Okay, so please remember usually immediately after food. Okay, immediately after food, definitely. Okay, so the important thing is, if I wait for that much time, I'll not be able to cover a lot of topics. Then I need to skip topics, and that I don't want. Okay, so that's the reason. So immediately after food, definitely, if you have pain, epigastric pain, that is suggestive of a gastric ulcer. But important is, in case of duodenal ulcer, you will have epigastric pain usually 2 to 3 hours after food. Okay, so 2 to 3 hours after food intake, if you are having epigastric pain, then definitely that is what is suggestive of duodenal ulcer. Important. Okay. Next, if I talk about the patient, as we are quite aware, what is the most common cause of upper GI hemorrhage or upper GI bleeding? That is hematemesis. We have discussed it yesterday. It is nothing else but PUD itself, peptic ulcer disease. So important is, bleeding is the most common complication of peptic ulcer disease, right? So bleeding is the most common complications in cases of peptic ulcer disease. Now, which ulcers bleed more commonly? We know the duodenal ulcers bleed more commonly. That we have discussed yesterday. The duodenal ulcers bleed more commonly. Please remember, okay? So that's important. And if I talk about which is the artery that bleeds in cases of duodenal ulcer, so we know it is the gastroduodenal artery which bleeds commonly in a case of duodenal ulcer. Yaad rakhna, important is, it is not only the most common artery bleeding in duodenal ulcer, but it is also the most common artery to bleed in peptic ulcer overall as well. Okay, it is the most common artery to bleed in peptic ulcer overall. Whereas if I talk about the gastric ulcer mein bleeding is a less common complication, but definitely if it occurs, it will be from the left gastric artery. Okay, it will be from, very good, the left gastric artery. And definitely we have discussed yesterday that left gastric artery bleeding is not only seen in cases of gastric ulcer, it can also be seen in cases of Mallory-Weiss tear. Very good. Okay, so that's important. You need to remember that properly. Okay, important is, yes, somebody mentioned that in cases of gastric ulcer, the patient will have pain after taking food. Therefore, the patient will avoid food or the patient will try to vomit. And that's the reason why a patient of gastric ulcer will have weight loss. But on the other hand, in cases of duodenal ulcer, the patient will have pain relief on eating more food. And that's the reason why a case of duodenal ulcer keeps on eating a lot of food, and therefore the patient will have weight gain in cases of duodenal ulcer. Now, if I talk about another complication of peptic ulcer disease, that is what is known as perforation. If I talk about perforation, important thing is, please remember, perforation is more commonly seen in gastric ulcer. Perforation is more commonly seen in gastric ulcer. Okay, so that's important. Perforation is more common in gastric ulcer as well, whereas less common in cases of duodenal ulcer. If there is perforation in gastric ulcer or duodenal ulcer, the one important thing that you need to remember is it is usually anterior. Bleeding is generally posterior. Bleeding occurs from the posterior surface, but perforation commonly occurs on the anterior surface. And if there is a perforation on the anterior surface, definitely there will be a very high risk of developing peritonitis in the patient. So there's a very high risk of developing peritonitis in the patient as well. No issues with this, anybody? So that's the important thing. And we have discussed about this condition. As I've told you, a patient who was having a peptic ulcer is eating a lot of taking a lot of NSAIDs, and due to which there's a high risk of perforation. There is a hollow viscous perforation. Either the stomach or the intestines will perforate, and that will land up the patient into peritonitis as well. Okay? That's important. Then if I talk about the treatment, very good, cupula sign, yeah. Then if I talk about the treatment, usually if I talk about the first line management, in a case of peptic ulcer, if I talk about the management in cases of peptic ulcer, please remember the first line management. If they ask you guys, okay, if they ask you the first line management, what will be your first line management? Important is, okay, the first line management is always lifestyle modification. And what can be lifestyle changes or lifestyle modifications which will happen? So please remember, you need to ask the patient to reduce the weight, okay, because obesity is an important risk factor. So you will ask the patient to reduce the weight, definitely. Okay, so definitely, apart from that, you will ask the patient to avoid any kind of tea, coffee, carbonated beverages. Okay, you will ask the patient to take meals usually 2 hours before sleep, and all of these things should be properly done. Okay, so that is the first line management in cases of peptic ulcer disease. Now, if that fails, definitely you will go for the medical management. And what is the drug of choice that we have discussed yesterday also? The drug of choice is always PPI, that is proton pump inhibitors, usually the prazole group of drugs. Okay, omeprazole, lansoprazole, pantoprazole, all of these drugs should be given. And if that fails, then definitely we will go for a surgical management. If that fails, we will definitely go for a surgical management now. Please remember, if we give first line therapy, definitely lifestyle modification should be done. Drug of choice is PPI. But after the PPI therapy fails, then definitely we'll go for the investigation of choice. Okay, we can start lifestyle modifications of PPI directly, just based on the clinical diagnosis. Okay, but when the PPI also fails, then we need to go for investigation of choice. And that investigation of choice, you need to remember, is a upper GI endoscopy. Okay, that investigation of choice usually is a upper GI endoscopy. And to rule out any cancer, we also might need a biopsy as well. Okay, we might need a biopsy as well, because one of the complications of peptic ulcer disease can also be a gastric adenocarcinoma as well. Okay, it can also develop a gastric cancer. That's the important thing. And if I perform a barium meal, okay, if I perform a barium meal in a case of gastric ulcers, you can see these kind of effects. And what are this? As I've told you yesterday also, wherever the barium sulfate or the contrast will not be taken up, these are called as filling defects. So you can see there will be filling defects wherever there are ulcers. Okay, so on a barium meal, we can see a filling defects at multiple sites at the site of ulcers. Now, if I talk about the surgery in the patient, if a patient is having gastric ulcer, then the surgeries that we can perform is either a Billroth 1 surgery or a Billroth 2 surgery. Okay, Billroth 1 surgery or a Billroth 2 surgery. What is done in Billroth 1 and Billroth 2? So you can see, as the antrum is the most commonly affected site. Okay, in cases of peptic ulcer disease, as I've told you, it is a lesser curvature of the stomach, mainly at the antrum. Okay, so therefore we perform a antrectomy. What is antrectomy? Removal of the antrum. Okay, so that is what is done. And once we remove the part of the stomach which is having the ulcer, then we will either connect the stomach to the duodenum. That is what is called as gastroduodenostomy. Okay, when we are connecting two organs, what is that called as? Connection is called as anastomosis or stomy. So here it is a gastroduodenostomy or a gastroduodenal anastomosis. That is a Billroth 1 surgery. Whereas in Billroth 2, what is done? As you can see, here we had to resect, or here we had to cut a major part of the stomach. Not only the antrum, but in the second one, we had to cut major part of the stomach because there might be many ulcers in the stomach, or there was a very huge or a giant ulcer in the stomach. Therefore, we had to cut a major part of the stomach. और अगर तुमने ज़्यादा हिस्सा stomach का cut कर दिया, now in this condition, what we need to do? Definitely, we cannot pull up the duodenum. Why? Because duodenum is a fixed structure. Okay, it is a fixed structure. We cannot pull it. Okay, the one structure which can be pulled is, एक बात याद रखनी है, तुम्हारा जो दोस्त होता है जो हर जगह चलने के लिए तैयार हो तुम्हारे साथ, ओके, वेला होता है जो, ठीक है, दूध लाने के लिए भी तैयार होता है, यूएस जाने के लिए भी तैयार होता है, वो वेला दोस्त जो है स्टमक में, वो तुम्हारा जेजुनम है. ओके, सो दैट्स यू नीड टू रिमेंबर, वेरेवर यू नीड एनीथिंग you can pull up the jejunum just, okay, you can just pull up the jejunum. So here we are pulling up the jejunum and connecting it to the stomach. We are pulling up the jejunum and we are connecting it to the stomach. This is what is called as gastrojejunostomy. This is what is known as gastrojejunostomy or a gastrojejunal connection, that is anastomosis. That is what is Billroth 2 surgery. So these are the two important surgeries which are performed in a case of gastric ulcer. But if a patient is having duodenal ulcer, now what is the important risk factor for duodenal ulcer? The important risk factor for duodenal ulcer is excess of acid. Yes, acid hypersecretion is an important risk factor for duodenal ulcer. And the second important reason is H. pylori. Okay, the second important reason for duodenal ulcer is H. pylori. What is H. pylori? A bacteria known as Helicobacter pylori. Okay, so these are the two important reasons. Now, important is, if there is acid hypersecretion, what we will give? We will give PPIs definitely. But why we are performing surgery? We are performing surgery because the PPIs have failed in this patient. And that's the reason why if the PPI fail in a case of duodenal ulcer, we will go for the surgery, and that is what is called as vagotomy. Okay, that is what is called as vagotomy. Nowadays, we do not perform vagotomy commonly because PPIs are very better. Okay, PPIs are definitely way better as compared to any surgery. So if I talk about vagotomy, if we perform vagotomy in a case of duodenal ulcer, what will be done? Now, I hope all of you are quite aware, the one nerve, the one cranial nerve which gives parasympathetic nerve supply or which gives parasympathetic innervation to the GIT is what is your 10th cranial nerve or your vagus nerve. Okay, so if you cut the vagus nerve, definitely what will happen? The stomach will not get a stimulus, and if the stomach is not able to get a stimulus, the parietal cells in the stomach will not be producing HCl or acid. Okay, once I'll explain in Hindi. So please remember, अगर पेशेंट का तुम वेगस नर्व कट कर देते हो, वेगस नर्व किसको सप्लाई करती है? जीआईटी को. कैसा सप्लाई देती है जीआईटी में? वो पैरासिम्पैथेटिक सप्लाई. और पैरासिम्पैथेटिक सप्लाई की वजह से क्या होता है? एसिड सिक्रीशन होता है. तो इफ यू आर कटिंग द वेगस नर्व, उसकी वजह से क्या होगा? द स्टमक विल नॉट रिसीव एनी स्टिमुलस. स्टमक को कोई स्टिमुलस ही नहीं मिलेगा, और जब तक उसको स्टिमुलस नहीं मिलेगा, वो एसिड सिक्रीट करेगा क्या? नहीं करेगा. And that's how the acid secretion goes down after this vagotomy surgery. ठीक है, so that is what is done. For vagotomy surgery, we have three types. If we are cutting the main trunk of the vagus, if we are cutting the main trunk of the vagus, not branches, the main trunk of the vagus, that is called as truncal vagotomy. But in truncal vagotomy, what you can see, the branch which was supplying the pylorus is also cut over here. The branch which was supplying the pylorus is also cut. And if the branch supplying the pylorus is cut, what will happen? The pylorus will not have any peristalsis. And if there is no peristalsis or there is no motility at the level of pylorus, the pylorus will not be able to drain the food. And as the pylorus is not able to drain the food, we also need to perform a drainage operation. Otherwise, what will happen? All the food will be collected over here in the stomach itself. Okay, that's the reason why we perform a drainage operation, and that drainage operation will straighten up the pylorus, where we will straighten up the pylorus. As we are repairing the pylorus, that is called as pyloro. Repair is known as plasty. Therefore, along with truncal vagotomy, the another surgery that we always need to perform is known as pyloroplasty or a drainage operation. Okay. Then next one is definitely a highly selective vagotomy. Highly selective vagotomy mein you can see we are not cutting the main branch of the vagus, or we are not cutting the main trunk of the vagus. So what we are cutting? We are only cutting the branches which are supplying the body of the stomach. Okay, we are only cutting the branches which are supplying the body of the stomach or which are supplying the parietal cells. Why? Because if these branches are cut, parietal cells will not receive a stimulus, and if parietal cells will not receive a stimulus, HCl will not be produced as well. Okay, so that is what is done. Here you can see that we are not cutting the branch which was supplying the we are not cutting the branch which was supplying the pylorus. Therefore, a drainage operation or a pyloroplasty is not required if we are performing a highly selective vagotomy. Okay, so it is not required. A pyloroplasty is not required if you are performing a highly selective egotomy. So these are the two common ones which are done nowadays. Okay, otherwise PPIs are better definitely. Okay, PPIs will be the first line. And if H. pylori has been identified as a cause, if H. pylori you will feel it has been identified as a cause. Okay, so what is the investigation that we do for H. pylori? So please remember, for H. pylori the investigations which can be done, you might have studied it as well. Important is we will perform either a urea breath test. Either we will go for a rapid test known as urea breath test. Okay, when urea or ammonia will be detected in the breath of the patient. Or second, we can go for a rapid urease test. But important is rapid urease test, also known as the CLO test. Okay, rapid urease test or CLO test, it is always performed on the biopsy. So we'll perform upper J endoscopy, take a biopsy, and on that biopsy we'll perform a rapid urease test or a CLO test that will help you make a diagnosis of H. pylori. And from patho, all of you will be able to recall. Please let me know now, what is the stain used for Helicobacter pylori and what is the culture media for Helicobacter pylori? That let me know in the comment box. Then the treatment for Helicobacter pylori is either a triple therapy. Okay, it is either a triple therapy or a quadruple therapy. Sorry, in triple therapy, what is given? Definitely we give one PPI. Okay, one proton pump inhibitor is given. Along with that, we need to give two antibiotics. Okay, along with that, we need to give two antibiotics usually. Okay, so the mnemonic can be CAP. You can remember C goes for clarithromycin, A goes for amoxicillin or ampicillin, and P usually goes for the PPI. Okay, but important is you can also use another groups as well. Please remember, one of the groups can definitely be the macrolides, whereas the other group, please remember, the other group which can be used is tetracyclines also. Okay, very good. The culture media is Quiroz culture media, but the stain is not Giemsa stain. The stain is Warden Starry silver stain. Okay, the stain which is used is known as Warden Starry silver stain. Okay. Apart from this, the second therapy that we can generally give to this patient is a quadruple therapy. Okay, we can also give quadruple therapy to the patient. And important is, in cases of quadruple therapy, please remember, in cases of quadruple therapy, we give this triple therapy. Along with that, we add a agent. Which agent is added? Now you know, in stomach there's a lot of acid which is there. Now, the stomach mucosa can also be damaged due to the acid, right? The stomach mucosa can also be damaged due to this acid. Therefore, in stomach, we normally have this mucus layer. Okay, therefore in the stomach we normally have this protective layer. Okay, so in cases of ulcer, what happens to this layer? In cases of ulcer, this protective layer is damaged, and due to that the patient develops an ulcer. Due to that the patient develops an ulcer. Okay, and that protective layer is damaged. That is the reason why patient develops an ulcer. Therefore, in cases of triple therapy, we will give a mucosa protecting agent. And what is that mucosa protecting agent? That is known as bismuth. Okay, that is known as bismuth subcitrate or bismuth subsalicylate. Okay, so the agent that we give is usually bismuth subcitrate or bismuth subsalicylate. That will protect the mucosa from the excess amount of acid which is secreted. Okay, okay? No issues with this, anybody? Chalo. So that is important. If I talk about the complications of these surgeries, if I talk about the complications of the surgeries, now one complication, as you can see here, a patient after a post-gastric reconstruction surgery or after a Billroth surgery usually, okay, definitely this patient is coming to you. Okay, after a Billroth surgery, the patient is coming to you with complaints of, patient A is there who is coming to me with complaints of epigastric pain and bloating sensation. Okay, patient number A is coming to me with complaints of epigastric pain and bloating sensation. So he is having epigastric pain, there is epigastric fullness, there is bloating, there is nausea, there is vomiting. ये है मेरा patient number A. Patient B, who is coming to me with complaints of sweating, tachycardia. Okay, so patient number B has complaints of sweating, tachycardia, headache, dizziness, all of these features. Okay, now usually in a case of patient A, the symptoms of this patient have started within 10 minutes of food intake. Okay, so the symptoms of patient A have started within 10 minutes of food intake, whereas the symptoms of patient B have started 45 minutes to 1 hour after the food intake. Okay, symptoms of patient B have started 45 minutes to 1 hour after the food intake. Now please let me know, what is your diagnosis in both the conditions? What is your diagnosis in both the conditions? Please let me know that. Okay, both of these are complications of the surgery. And with surgery, the gastric reconstruction surgery, that is nothing else but your Billroth surgery, Billroth 1 or Billroth 2. That is gastroduodenostomy or a gastrojejunostomy surgery. Please let me know, patient A का diagnosis क्या होगा, patient B का क्या होगा. ठीक है? Okay, so I'm just explaining it to you. Now, previously you can see the food was, okay, when the stomach was there, stomach was present. The food was present in the stomach for a longer duration of time, and then it was released in small amounts. Okay, then it was released in small amounts into the intestine. So the intestines are used to receive only small amounts of food. Intestines को आदत है कि इतना ज़्यादा food एक साथ आने की नहीं है. तो intestines को बहुत छोटे छोटे हाँ boluses मिलते हैं food के definitely normally. But here what is happening now, as you have cut the stomach, definitely all the food is rapidly going into the intestine. All the food, okay, a lot of food is rapidly going into the intestine. And which kind of food? Definitely sugar rich food. Okay, so highly concentrated or sugar rich food, and a lot of food is immediately going into the intestine, and the intestines are not used to this. So therefore what happens, usually within 10 minutes, okay, usually within 10 minutes, due to this excess of sugar rich food which is going into the intestine, due to this excess of sugar rich food in the intestine which is there, what happens, to dilute this food, a lot of fluid comes into the intestine. To dilute this food, because it is a highly concentrated food now, therefore to dilute this, a lot of fluid comes into the intestine. That causes epigastric fullness, nausea, vomiting or pain in the patient, and this is a case of early dumping syndrome. This is what is a case of early dumping syndrome. Please remember. Now, as we know, this patient has eaten a lot of sugar-rich food after surgery. As this patient is eating a lot of sugar-rich food after surgery, and that sugar-rich food is immediately coming into the intestine. So initially what happens? A lot of insulin is released. Why? Because as there is a lot of sugar-rich food, to normalize the blood sugar levels, a lot of insulin is released. But what happens? Will this sugar-rich food be able to stay in the intestine for a longer time? No. This sugar-rich food is not able to stay in the intestine for a longer duration of time. Why? Because all this fluid which is coming, this fluid will wash out the food. Okay, जो fluid आ रहा है ना, वो अपने साथ इसको fluid, इस food को जो है वो जल्दी से बाहर ले जा रहा है. That's the reason why this excess of insulin which is secreted, after some time, after usually 45 minutes to 1 hour, now it will start dropping the blood sugar levels, and that causes hypoglycemia in the patient. Okay, so usually after 45 minutes to 1 hour after food intake, the patient starts having symptoms of hypoglycemia, and that is what is sweating, dizziness, tachycardia, palpitations, okay, headache. So this is what is a case of late dumping syndrome. That's important. Okay, important is, please remember what is done for treatment or prevention. So for treatment or prevention, ask the patient to avoid any sugar rich foods. Okay, ask the patient to avoid any sugar rich foods. Okay, important is that. And second, ask the patient after surgery to take small frequent meals. Don't ask the patient to take a lot of meals all at the same time. Ask the patient to take small frequent meals. Okay, bar khao, but thoda khao, definitely. Okay, so that is what is asked after a Billroth surgery in a patient to prevent any kind of dumping syndrome, whether it is early dumping or late dumping syndrome. That's important. Next important is this one. What is seen over here? Okay, so here I have a young female who was brought to me with hair loss. So she was having alopecia as well. Okay, she was having hair loss or alopecia. And second, she was having abdominal pain. And when she was having abdominal pain, okay, we investigated and we operated this patient. On operation, definitely, I've got this kind of a structure in her stomach. What is this? You can see, definitely you can see this kind of a structure which is there in the stomach. Okay, this kind of a structure. It is nothing but the hairs which are present in the stomach. Yes, hairs are present in the stomach, definitely. Okay, so what is a collection of some substance in the stomach called as? Collection of some substance in the stomach is called as a bezoar. Okay, collection of some substance in the stomach is known as a bezoar. Now, which kind of bezoar it is? It is collection of hair, and hairs are what are called as tricho. So therefore, it is known as a trichobezoar. So it is a diagnosis of trichobezoar. It was a previous year question again. Please remember, so a young female coming to you with alopecia. Why there is alopecia? Because this young female is a psychiatric female. This young female is definitely a psychiatric female who is suffering from psychiatric disorder. And what is that psychiatric disorder? Where the patient is having an irresistible desire or an impulse to pull out her hair. Okay, so she pulls out her hair. अपनी बाल खींचती है और खा जाती है. That is known as trichotillomania. So this patient is suffering from a psychiatric disorder known as trichotillomania, after which she plucks out her hair, she pulls out her hair and eats those hairs. Okay, and that causes collection of hair in the stomach, and that is what is known as trichobezoar. And the question was, what is done for treatment of this patient? So we know we are going to remove the bezoar from our stomach, and definitely the patient will be sent for psychiatric consultation. The patient will be sent for psychiatric consultation. No issues with this. That's important to be remembered now. Next one, if I talk about, okay, so somebody was interested in bariatric surgery. So these are the bariatric surgeries. Important is, what is a bariatric surgery? So please remember, bariatric surgery is also known as metabolic surgery. Okay, so bariatric surgery is also known as metabolic surgery. And why a bariatric or a metabolic surgery is done? The bariatric or a metabolic surgery is done when a patient is morbidly obese. Okay, so in cases of morbid obesity, okay, a lot of obesity, we will go for bariatric or a metabolic surgery definitely. Okay, so please remember that. No issues with this. So bariatric surgery or metabolic surgery is done in cases of morbid obesity. What is an indication? Okay, when a patient is having a BMI, when a patient is having a BMI of more than 40, when a patient is having a BMI of more than 40 with or without any comorbidities. What is comorbidity? Any other disorder like diabetes mellitus, hypertension, hyperlipidemia, okay, any other comorbidity. So if the BMI is more than 40 with or without any comorbidity, or if the BMI is more than 35 with comorbidities, or if the BMI is more than 35 with comorbidities, that is an indication of bariatric surgery. Not all obese patients will undergo bariatric surgery. Only those patients who are not able to lose weight with some lifestyle modifications or with some medical management, those are the patients who should undergo a bariatric or a metabolic surgery. Now in bariatric or metabolic surgery, we have three techniques. First one is actually a LAGB. What is a LAGB? It is nothing but a laparoscopic adjustable gastric banding. The first procedure is known as laparoscopic adjustable gastric banding, where a band is applied over a stomach. Okay, so this band will act as a compression. Okay, this band will act as a compression. तो ये क्या करता है? Stomach को compress करता रहता है. Okay, so it will not let the stomach relax, and if the stomach is not able to relax, we will not be able to eat a lot of food. Okay, so that is what is done with this laparoscopic adjustable gastric banding, and this port, the access port which is there, it is placed at the level of the umbilicus, with which you can control this adjustable band definitely. The next surgery which is there, it is this one. It is Roux and Y gastric bypass surgery. And important to be remembered is, it is the most effective bariatric surgery. So if they ask you a question, which is the most effective bariatric or metabolic surgery, now you know the answer. It is Roux and Y gastric bypass surgery. So now what is done over here? We will bypass the stomach. Okay, so we will make a new route for the food. Okay, we will make a new route for the food. हम एक नया रास्ता बनाएंगे खाने के लिए जहां हम stomach को bypass कर देते हैं. So now you can see over here. Here, this is the esophagus. Then we are cutting the stomach. We are only leaving behind a pouch of the stomach. We are only leaving behind a small pouch of stomach, and then we will pull up that vela friend of yours. What was that friend? Jejunum. So we are pulling up the jejunum, and we are directly attaching your jejunum over here. So now we are attaching the jejunum to a small gastric pouch. Therefore, this will be called as gastrojejunostomy. Okay, so we are performing a gastrojejunostomy definitely. And in this procedure, what are we bypassing? We are bypassing your stomach and duodenum. We are directly bypassing your stomach and duodenum. Now all of us are quite aware definitely what is the role of stomach. So stomach is nothing but a sac or a bag which is responsible for storing food. Okay, but now what you have done over here, you have bypassed the stomach only, so the food could not be stored, and as the food is not able to store, definitely you will not be able to eat a lot of food now. Okay, so we'll say, sir, why this second anastomosis is done over here? Why the second connection is required between duodenum and between jejunum? This is required because the bile duct or the pancreatic duct, okay, the bile or the pancreatic duct open at the second part of the duodenum. And for absorption of food, we definitely require the pancreatic juices as well as the bile as well. Therefore, for mixing of the bile and pancreatic juices with the food, we perform this second anastomosis between duodenum and jejunum. So first was gastrojejunostomy that we did, and this is what is duodenojejunostomy that we will do. Okay, duodenojejunostomy. So Roux and Y gastric bypass surgery is the most effective technique for metabolic surgery. But if they ask you, is it the most common one? No. So which is the most common one done nowadays? The most common bariatric surgery performed nowadays is known as sleeve gastrectomy. Okay, the most common bariatric surgery performed nowadays is known as sleeve gastrectomy. What we are doing over here, you can see, we are actually stapling the stomach. We are actually stapling the stomach along the greater curvature. Okay, so we are actually trying to staple the stomach around the greater curvature. So what has happened over here? As we staple the stomach around the greater curvature, definitely we are decreasing the size of the stomach. And as we know, if the size of the stomach is decreased, you will not be able to eat a lot of food. Definitely your appetite will go down and you will lose a lot of weight as well. Okay, so this is what is called as sleeve gastrectomy. Gastrectomy is what? Gastrectomy is removal of the stomach. Okay, and why it is called a sleeve gastrectomy? Because we are removing majority of the stomach and we are only leaving behind a sleeve of the stomach. We are only leaving behind a sleeve of a stomach. Okay, so that is the most commonly performed bariatric surgery. So that was all about your bariatric surgery. Remember these important things. Now next, if I talk about gastric cancer in a patient, if I talk about gastric cancer in a patient, please remember, okay, the most common type of gastric cancer. One important thing that you need to remember, okay, in GIT, the oral cavity, the esophagus and the anal canal. The oral cavity, the esophagus and the anal canal are lined by squamous epithelium. These three sites are lined by squamous epithelium. So therefore, the cancer in these three organs will more commonly be a squamous cell carcinoma. Apart from these three organs, oral cavity, esophagus and anal canal, apart from these three organs, throughout the GIT, we have a columnar epithelium. And that's the reason why the most common type of GIT cancer, apart from these three organs, will be a adenocarcinoma. So gastric cancer is also a type of adenocarcinoma itself. Important risk factor that you need to remember, it is usually a preservative rich food or a smoked food. Why? Because that contains a carcinogen known as nitrosamines, and therefore this preservative rich or smoked food was commonly eaten in Japan. Therefore, in Japan, there was a very high risk of gastric cancer in the patient. But the question was, which has been previously asked, which type of cancer, the incidence of which cancer has gone down with advent of refrigerator. Okay, so as refrigerator came into action, when the refrigerator came into picture, we stopped using a lot of preservatives in the food. We stopped using a lot of preservatives in the food, and that was the reason why gastric cancer incidence came down. Okay, so if they ask you again, which cancer came down due to the advent of refrigerator, answer is gastric cancer, because preservative rich food nowadays is avoided. If they ask you what is the classification used for a gastric cancer, so please remember the classification used for gastric cancer, okay, it is known as the Borman's classification. It is a pathological classification. So please remember the classification which is used for gastric cancer is known as a Borman's classification. There are 4 grades. Okay, there are 4 grades according to the Borman's, but at least you need to remember the grade 4. And what was that grade 4 of Borman's? So the grade 4 of Borman's classification, when the malignancy or when the cancer spreads throughout the stomach wall, पूरे stomach wall में cancer भर जाता है, that is what is called as Linitis plastica, and that has been asked. Okay, so grade 4 of Borman's is known as Linitis plastica. It is also known as leather bottle stomach. Okay, so the stomach wall becomes so thick like a leather bottle, therefore it is known as a leather bottle stomach. Okay, so grade 4 Borman's is Linitis plastica or leather bottle stomach. That has been a previous year question. No issues with this, anybody? Now if I talk about the complaints in a case of gastric cancer, definitely if I talk about the complaints, a patient of gastric cancer, if there is a cancer in the stomach, definitely the patient will not be able to eat a lot of food. So that is the reason why patient will have early postprandial fullness. Okay, he will have fullness, early fullness will be there. Okay, पहले वो 4 रोटी खाता था, अब 1 रोटी खा पा रहा है. Okay, earlier he used to eat 4 rotis, now he's only able to eat 1 roti. Okay, so that is early postprandial fullness. Due to that, the patient will have a lot of weight loss. Okay, so 2 cancers where there is a very high amount of weight loss is the esophageal cancer, and second is the stomach cancer in a patient. Okay, apart from this, in cases of stomach cancer, there can also be metastasis to other sites. So first image that you can see there is enlargement of the lymph nodes in the left supraclavicular fossa. So which lymph nodes are enlarged over here? You can see it is the left supraclavicular lymph nodes which are enlarged in this condition. Okay, so if there is metastasis from the gastric cancer, so this left supraclavicular lymph nodes, these are known as which nodes? So these are what are called as your Virchow's nodes, also known as, okay, these are also known as your Virchow's node, or it is classically known as the Troisier site. It is known as the Virchow's nodes, or it is known as the Troisier site. Please remember this. Okay, so that's important, very important to be remembered. The next metastasis from a gastric cancer can occur in the periumbilical region. Around the umbilicus of the patient, there can also be a metastasis. And if the metastasis occurs in the periumbilical region, then it is classically called as which nodules? The nodules which you can see over here. These are known as Sister Mary Joseph nodules. These are classically known as the Sister Mary Joseph nodules. Okay, important. And the third important site from metastasis from gastric cancer. The third important site. Now this I will ask you to answer. If there is metastasis to bilateral ovaries, if there is a bilateral ovarian metastasis from a gastric cancer, what is that classically known as? If there is a bilateral ovarian metastasis from a gastric cancer, what is that known as? Till that time, I'll tell you about the other sites of metastasis. If there is metastasis in the axillary group of lymph nodes from a gastric cancer, that is called as the Irish nodes. That is known as the Irish nodes. Then if there is metastasis, please remember, if there is metastasis in the pouch of Douglas or the pelvis, pouch of Douglas, then it is known as the Blummer's shelf. Then it is known as the Blummer's shelf. Okay, so very good, Sai Sudha. So that's important. Please remember, it is known as the Krukenberg's tumor. Very good. If there is a bilateral ovarian metastasis from a gastric cancer, it is known as the Krukenberg's tumor. And when we will take a biopsy of this Krukenberg's tumor, you will be able to see the signet ring cells. Okay, you will be able to see that classical signet ring cell appearance. No issues with this, anybody? That's important. Very good, all of you. So that is important. Next, if I talk about the investigation in a case of gastric cancer. So the investigation of choice in a case of gastric cancer is usually a upper GI endoscopy plus biopsy. Investigation of choice is definitely a upper GI endoscopy plus biopsy. If they ask you which is the most common site of metastasis in gastric cancer, please remember the most common site of distant metastasis in esophageal cancer, in gastric cancer, in colorectal cancer, rather in all the GIT cancers. Okay, please remember the most common site of metastasis in most of the GIT cancers is definitely the liver itself. Okay, the most common site of distant metastasis in most of the GIT cancers is the liver itself. Okay, it is the liver. And if they ask you what is the most common site of gastric cancer in the Western world, so please remember, if they ask you what is the most common site of gastric cancer in the Western world, then your answer should be the proximal part of the stomach, the cardia or the fundus. Okay, the most common site definitely for gastric cancer in the Western world is the proximal part of the stomach. But if they ask you which is the most common site of gastric cancer in the world or in India, okay, if they ask you the most common site for gastric cancer worldwide or in India, then your answer is right. Very good, Mohit. It is known as antrum. Then it will be called as the antrum. No issues with this, anybody? That's important. Now, once you have made a case, okay, once you have made a diagnosis of gastric cancer, now you will stage it now. So it's not important to remember the staging, but please remember for T and N staging, just like esophageal cancer, for T and N staging, here also the investigation of choice in cases of gastric cancer is an endoscopic ultrasound. Okay, here also the investigation of choice for T and N staging or for assessing the depth of invasion, कितना deep है ये cancer, वो देखने के लिए the investigation of choice is endoscopic ultrasound. Now, according to the staging, we will classify the cancer as an early gastric cancer or an advanced gastric cancer. Okay, as an early gastric cancer or an advanced gastric cancer. If I go for an early gastric cancer, that means the cancer is very small, only less than 3 centimeters in size, and it is only involving the mucosa and submucosa. What do I mean by early gastric cancer? Cancer less than 3 centimeters in size and only involving the inner layers, mucosa and submucosa. Then I can only go for an endoscopic resection. Then I can, yes, only go for an endoscopic resection. Though it is a cancer, but as it is in the early stages, I can go for endoscopic resection. But if it is an advanced gastric cancer, then you need to see whether it is involving proximal part of the stomach or the distal part of the stomach. If it is involving the proximal part of the stomach, the cardia, the fundus or the body, then definitely you need to go for a total gastrectomy. Then definitely you need to go for a total gastrectomy, that is removal of the whole stomach. Total gastrectomy has to be done. And now what is left behind? Definitely the esophagus is left behind. And the new stomach which is there, it will be formed with the help of jejunum. So therefore we will perform a esophagojejunostomy. Then we will perform a esophagojejunostomy in this patient. Okay? Whereas if I see that the cancer is only involving the distal part of the stomach, just remove the distal part of the stomach and bring the jejunum and connect it to the stomach. That is what is called as distal gastrectomy should be done. Okay, distal gastrectomy, only remove the distal part of the stomach and perform a gastrojejunostomy, and then perform a gastrojejunostomy. Okay, no issues with this, anybody? That's important to be remembered. This was all about your gastric cancer. Now, if I talk about another type of gastric malignancy, and that is what is called as GIST. Okay, if I talk about gastric malignancy, that is what is called as GIST. What is GIST? Please remember, GIST is nothing but gastrointestinal stromal tumor. CVET classification is more important according to pathology. Okay, it is more important according to pathology than in surgery. Okay, so gastrointestinal stromal tumor, if I talk about. Now, please remember, this tumor is not only limited to the stomach, it can also occur in the intestine. But if they ask you, which is the most common site for a GIST? Which is the most common site for a GIST? Now, we can see that gastro comes first. That is how you can remember it easily. The most common site for a GIST is definitely the stomach. Most common site for a GIST is definitely a stomach. Important is, I would like you to answer my two questions. One, what is the origin of a GIST? From which cells of the stomach will the GIST arise? Okay, from which cells of the stomach will GIST arise? First thing. And second, what is the best tumor marker for GIST? What is the best tumor marker for GIST? The best or the most specific tumor marker for GIST? Okay, both of these answers. And important is, this GIST which is there, it does not grow into the lumen. Okay, unlike other gastric cancer, it does not grow into the lumen. Rather, it goes within the wall of the gastric. Okay, within the wall of the stomach. So please remember, GIST is a specialized type of a cancer or a tumor which grows within the wall. Okay, if they ask you what is the investigation of choice, important is, as it is a stromal tumor, definitely the investigation of choice will not be a biopsy. Reason is, because in cases of stromal tumors, there can also be a lot of blood vessels in the tumor. And if there are a lot of blood vessels in the tumor, definitely there can be a risk of bleeding. That is the reason why we will go for better as CECT abdomen. So CECT abdomen is the investigation of choice in cases of GIST, whereas biopsy is not recommended to make a diagnosis of GIST. Please remember that. Biopsy is not recommended to make a diagnosis of GIST. Very good all of you. So origination of GIST is definitely from the pacemaker cells of your stomach, and these pacemaker cells of your stomach are called as interstitial cells of Cajal. Very good. Okay, so these pacemaker cells of your stomach are what are called as your interstitial cells of Cajal. That is the important question that you need to remember. And second, all of you are right. Very good. The tumor marker which is used, the best tumor marker for GIST is definitely DOG1. Please remember the best tumor marker. No, a lot of people have answered it as CD117. No, the best tumor marker nowadays is DOG1. Please remember. Okay, so the most specific, okay, the most specific or the best tumor marker is definitely DOG1. But if I ask you the most common tumor marker used, if I ask you, my question will be, if I ask you the most common tumor marker used, then your answer definitely should be CD117. Then your answer is right, then it is CD117. But best or most specific answer should be DOG1. Please remember that. Okay, what should be the treatment in this condition? So definitely in this condition, the first line management is a surgery. Okay, so definitely we will go for a surgical resection. And how much centimeter margins are required? Usually 2 centimeter margins are taken. So we'll go for a surgical resection of the tumor with 2 centimeter margins. But if the GIST which is there, it is not resectable. Okay, if the GIST is not resectable, that means there is metastasis which has already occurred. Then definitely we give a drug. Okay, then we will definitely manage the patient with some medications. And what is that medication? Okay, what is that medication with which you can treat a case of GIST? It is usually a drug known as tyrosine kinase inhibitor. Please name the drug in the chat box. Please name the drug in the chat box. A tyrosine kinase inhibitor will be used to manage a case of GIST if it has metastasized to some other organ, if it is not resectable. Okay, please name that drug. It is also the drug of choice for your CML, chronic myeloid leukemia. Now, next question which is there, it says a patient presents to the emergency room with upper abdominal pain and retching episode. What is retching? The patient feels like vomiting, but there is no vomitus coming out. Okay, you are not able to insert, Ryle's tube or the nasogastric tube. What is your likely diagnosis? Very good all of you. The medication that is used to medically manage a case of GIST is a tyrosine kinase inhibitor known as imatinib. Okay, very good. It is known as imatinib. That's important. Chalo. Moving further, now please answer my next question. A patient presents to the emergency room with upper abdominal pain or epigastric pain. There is a retching episode and we are not able to insert the rise tube. This is a classical triad that you see. Upper abdominal pain, retching and inability to insert rise tube. This is a classical triad known as which triad and what is your diagnosis? Please answer both the questions. It is known as which triad and what is your likely diagnosis? Gastric outlet obstruction can be due to multiple causes, no? Gastric outlet obstruction can be due to multiple causes. And that was a previous year question as well. Please remember, gastric outlet obstruction ki most common cause is gastric cancer nowadays. Yes, most common cause of gastric outlet obstruction is gastric cancer nowadays. Most common cause of gastric outlet obstruction is gastric cancer. That was a previous year FMG question. What is your answer? Please remember, this is a classical Borchardt triad which is seen. This is the classical Borchardt triad which is seen. And I hope all of you are quite aware that Borchardt triad is usually seen in cases of gastric volvulus. So please remember, this Borchardt triad is usually seen in cases of gastric volvulus. Okay. So it is usually seen in cases of gastric volvulus. What is the volvulus now? If the organ undergoes a twisting or malrotation. If an organ undergoes twisting or malrotation, that is what is called as volvulus. Please remember, जब organ आधा टेढ़ा हो जाता है. For example, this is the organ which is undergone twisting. This is what is called as, okay, volvulus. Please remember, this is what is known as your volvulus, that you need to remember properly. Okay, so that is important to be remembered. That is what is the case of gastric volvulus. Chalo. So gastric volvulus is nothing but malrotation or twisting of the stomach, and in that condition we are able to see this Borchardt triad. What should be the treatment for this condition now? What should be the treatment? So as there is a gastric volvulus or twisting of stomach, what can happen? Please remember, due to this twisting of stomach, definitely the blood supply to some part of the stomach can be cut off, and that can lead to necrosis of the stomach as well. Okay, so if I talk about the treatment in this patient, if necrosis of stomach has occurred, if there is necrosis of the stomach, definitely I need to remove that part of the stomach which has undergone necrosis. जिस हिस्से में necrosis हुआ है वो हिस्सा मुझे काटना पड़ेगा. In that condition, I will perform gastrectomy according to the necrosis which is there. But if the patient is not having any necrosis, then I'll go for decompression. So if I perform a decompression, definitely, I'll aspirate all the gas which is there. Now, definitely the pressure will be released and the stomach will come into its original position. Okay, now the pressure will be released and the stomach will come into its original position. That is called as decompression. Now, after I perform a decompression or derotation, definitely I'll go for what? I'll go for a fixation of the stomach, and fixation is called as pexy. So it is known as gastropexy. Okay, so after decompression or derotation, I'll go for a gastropexy. That has to be done. So that was all about your gastric volvulus. If they ask you the investigation of choice, remember it is CECT abdomen. The investigation of choice is a CECT abdomen. Okay. Next, moving further, talking about this another condition. Please make a diagnosis now. A neonate has presented to you with bilious vomiting and birth. So here the child is not coming to you after 2 to 3 weeks of birth, and the child is not coming to you with non-bilious vomiting. So it is not a case of CHPS. So it is a differential diagnosis of CHPS where the child presents at birth itself and the child has a complaint of bilious vomiting. The X-ray has been given below, and the X-ray if I see, it does not show only one bubble. It rather shows two bubbles. One of the stomach, second of the duodenum. This is what is the classical double bubble sign. Okay. This is what is the classical double bubble sign. So all of these features are pointing towards the diagnosis of, very good. All of these features are pointing towards the diagnosis of duodenal atresia. Okay, so it is a case of duodenal atresia. It is a classical case of duodenal atresia in the patient. Please remember that. Okay. If I talk about duodenal atresia, what do I mean by this? Atresia का मतलब होता है absence. Okay, atresia means absence. So here some part of the duodenum is missing. Okay, some part of the duodenum is absent or some part of the duodenum is missing usually. That is what is the case of duodenal atresia. So if the duodenum is not connected properly, will the patient be able or will the child be able to drink anything, eat anything? No. because as the duodenum is not connected further to the intestine, everything which goes inside will come outside as well. That is what is called as vomiting. So the patient will have a lot of vomiting. But now we know here the bile is mixing, okay, the bile is mixing with the food and then the food is coming outside. Therefore the vomiting which will be there will be somewhat greenish in color, and that greenish color vomiting is known as bilious vomiting. Okay, so the vomitus will contain bile inside it because the problem is located at the level of the duodenum now. Therefore there is a bilious vomiting. Okay, so that's the important thing. If I talk about duodenal atresia, as I've told you how to differentiate it from CHPS, in CHPS patient comes to you after 2 to 3 weeks. Here the patient will come to you at birth itself. Next, in CHPS the patient will have non-bilious vomiting. Here the child will have bilious vomiting. Next, in case of CHPS, the first line investigation was X-ray abdomen, which was showing you the single bubble sign. But in cases of duodenal atresia, it classically shows you the double bubble sign definitely. If they ask you what is the investigation of choice over here, they ask you what is the investigation of choice. So the investigation of choice is a CECT abdomen, contrast enhanced CT scan of abdomen. Okay, it is a CECT abdomen. And if I talk about the treatment of choice is what? As if the esophagus was not completely attached, what we were doing, we were connecting one part of the esophagus to another part of the esophagus. Connection is what is called as anastomosis. So in esophageal atresia, we were performing anastomosis. Just like that, in duodenal atresia also, we will perform a anastomosis. And that is what is duodenal anastomosis or a duodenostomy. So that has to be done. Okay. So a duodenal anastomosis or a duodenostomy has to be done. If that is not possible, we can go for a duodenojejunostomy. But better one is always a duodenostomy. Okay. That has to be remembered. Yes, a double bubble sign on an X-ray abdomen is not only a feature of duodenal atresia, but it can also be seen in cases of annular pancreas. Okay. When there is a ring-like pancreatic tissue around the second part of duodenum. When there is a ring-like pancreatic tissue around second part of duodenum and that compresses the pancreas, that compresses the duodenum. That is known as annular pancreas. And the third condition where a double bubble sign can be seen, a third condition, it is known as the Lad's band. Okay, the third condition where it can be seen is known as the Lad's band. Okay, so that's important. Next, here you can see another X-ray abdomen which is showing you one bubble of the stomach, second bubble of the duodenum, third bubble of the jejunum. This is what is called as a triple bubble sign. Okay, this is what is known as the triple bubble sign. And you can see beyond the jejunum, you cannot see any air bubbles. Why? Because beyond the jejunum, the air is not able to pass. Why beyond jejunum, air is not able to pass? Because the jejunum is not formed properly. There is no connection between jejunum now. So triple bubble sign is a case of jejunal atresia. Okay, triple bubble sign on X-ray abdomen is seen in cases of jejunal atresia. Whereas if I talk about this condition, what is seen over here? Here you can see multiple bubbles now. Okay, you are able to see multiple bubbles. So if you are able to see multiple bubble sign, okay, multiple bubble sign is seen. So please remember, multiple bubble sign is a case of ileal atresia. Multiple bubble sign is a case of ileal atresia. That means the ileum is not formed now. Okay, it is a case of ileal atresia. Now if I talk about intestinal obstruction, guys, if I talk about intestinal obstruction, please remember it is the most common surgical emergency. Okay, when you are sitting in a surgery emergency, the most common and the usual emergency that comes to you is a case of intestinal obstruction. How the patient is going to present to you, what are the features of intestinal obstruction, and when you are going to suspect intestinal obstruction. So the patient will have abdominal colicky pain. Okay, so patient will have colicky abdominal pain. Along with that, if the intestine is obstructed, definitely all the food will come outside. That means the patient will have vomiting as well. There will be colicky abdominal pain, there will be vomiting. Along with that, the patient will not be able to pass stools. And if the patient is not able to pass feces or stools, that is called as constipation. Next, it can be so severe or a complete intestinal obstruction that the patient is not even able to pass flatus. What is flatus? Gas. So the patient is not even able to pass flatus or stools. That is what is called as obstipation. Obstipation is nothing but absolute constipation. So colicky abdominal pain, vomiting, constipation and obstipation are usual indicators of intestinal obstruction in a patient. Okay, they are the usual indicators. So definitely if a patient comes to you with intestinal obstruction, you need to see whether it is a case of dynamic intestinal obstruction or a adynamic intestinal obstruction. What do I mean by this? Basic difference. See, in dynamic intestinal obstruction, there is some physical obstruction to the flow of feces. That means the feces are not able to flow properly. Why? Because there is some physical obstruction in the intestine. Either it can be a stone, or it can be a tumor, it can be a polyp, or anything like that. ठीक है? तो कोई ना कोई अड़ंगा है बीच में. That is what is a dynamic intestinal obstruction. But if I talk about adynamic intestinal obstruction, here the intestines are not having any physical obstruction. Here the intestines are not having any kind of physical obstruction. So what is the problem then? So the problem is, here the intestine have lost its motility. The intestines which are there, they have lost its motility. What is the motility of intestine called as? Peristalsis. So the intestines are not having any kind of peristalsis. As there is no peristalsis in the intestine, the food cannot pass in the intestine. Okay, and that leads to intestinal obstruction in the patient. As there is no dynamic or a physical obstruction, this type of intestinal obstruction will be called as adynamic intestinal obstruction. Now if they ask you dynamic intestinal obstruction, please remember, usually as I've told you, it can be any condition which is causing a physical obstruction. It can be a fecalith, it can be a gallstone, it can be a tumor or a polyp, something like that, okay? Or a foreign body as well. Whereas adynamic intestinal obstruction is usually seen when the intestine have lost its motility. That means usually a case of paralytic ileus. What do I mean by paralytic ileus? That the intestines are paralyzed. They are not having any kind of motility. Okay, and paralytic ileus is commonly seen after surgery. Very good. Okay, so they are commonly seen post-surgery. When the patient comes out of anesthesia, what should happen? The intestine should regain its motility. Okay, but if the anesthesia influence is too long, definitely the patient is not able to regain the motility of the intestine, and that is what is called as paralytic ileus, which is an example of adynamic intestinal obstruction. What is the first line investigation in a case of intestinal obstruction? That's important. The first line investigation, whenever a patient of intestinal obstruction comes to you, the first line always should be a X-ray abdomen. The first line should always be a X-ray abdomen. X-ray abdomen will be two views now. Okay, the X-ray abdomen is taken in two views. The first view that you can see over here, okay, the first view that you can see over here is the erect view. Okay, when the patient is standing, and the erect view will tell you what? The erect view will tell you many air fluid levels. Okay, so the erect view can only tell you if the patient is having an obstruction or not. If the patient is having any obstruction or not. If there is an obstruction, what will be seen? Multiple air fluid levels are seen. Okay, multiple bubble sign भी बोल सकते हो, या फिर multiple air fluid levels are usually seen if a patient is suffering from intestinal obstruction. Okay, this is a very important question from your exam. Radio B covers it. Whereas the second view that we take is a supine view. लेटने के लिए बोलो patient को, दूसरा X-ray लो. Okay, the second view that we take is a supine view of the patient. Okay, of X-ray abdomen. And what is the supine view going to tell you about? Supine view is going to tell you about what is the site of obstruction or what is the location of obstruction. Important is how to identify it. So please remember, as you can see here, you can see the dilated bowel loops. Okay, so if there is an intestinal obstruction, definitely the proximal bowel loops which will be there. Okay, proximal to the obstruction, the bowel loops will be dilated or they will be distended. Okay, because the food cannot pass out, therefore the proximal bowel loops are dilated or distended. So they will be more prominent on an X-ray. Okay, so you can see if the dilated bowel loops which are there, if they are seen in the center, if the dilated bowel loops are seen in the center, then it is usually a obstruction in the small bowel or the small intestine. Then it is usually a obstruction in the small bowel or small intestine. If you are able to see such kind of feature, what is the feature seen over here? You can see that there are complete circular mucosal folds. These complete circular mucosal folds are only seen in which part of the small intestine? They are definitely seen in the jejunum. Okay, and these complete circular mucosal folds you might have studied in anatomy and physiology. These are called as valvulae conniventes or plicae circularis, and that was the previous year question. Okay, so valvulae conniventes or plicae circularis are an important feature of jejunum, and because jejunum have these continuous circular mucosal folds, you can see this type of a pattern in case of jejunal obstruction. And what is this type of a pattern called as? This is what is called as the step ladder pattern. So if you are able to see a step ladder pattern on an X-ray abdomen, that is what is suggestive of a jejunal obstruction. That is what is suggestive of a jejunal obstruction. Whereas if you can see the dilated bowel loops are lying in the center, but there is no specific feature as such. So these are featureless and characterless loops. Okay, the featureless and characterless loops which are there, the featureless and characterless loops are nothing but the ileum. Okay, so if the loops are not having any kind of special feature or any character, then these are usually the ideal obstruction. Okay? Whereas if you will say large bowel obstruction or colon obstruction, I hope all of you are quite aware, colon does not have complete folds, but colon have these kind of feature. And what are these features called as? Ostrations. So if there is obstruction in the colon, definitely you will see the dilated bowel loops in the periphery, not in the center. You will see the dilated bowel loops in the periphery, not in the center. And second, you will see this special feature known as ostrations. So that is what is suggestive of a colon or a large bowel obstruction. Please remember that. Okay? So that was your first line investigation, that is X-ray abdomen. But if they ask you what is the investigation of choice, so investigation of choice definitely should be a CECT abdomen again. Okay, so please remember, for intestinal obstruction, any cause of intestinal obstruction, where it is duodenal, atresia or anything else. Okay, so the best investigation is always a CECT abdomen, contrast enhanced CT scan of abdomen. Please remember. But in children, we can prefer a safer investigation like a ultrasound abdomen as well. Okay, in children, we can prefer a safer investigation like ultrasound. Okay, but better is always a CCT. Now, what should be the treatment in cases of intestinal obstruction? So please remember, as I've told you, usually, if it is a case of dynamic intestinal obstruction, when there were some physical obstruction. What is the most common cause of physical obstruction, guys? The most common cause of physical obstruction is usually adhesions. Okay, so चिपक जाता है intestine एक दूसरे से. That is what is adhesions. Usually adhesions are formed within the intestine. That causes a physical or a dynamic intestinal obstruction. The other cause can be strictures. There was inflammation of the intestine, and when it healed, definitely it caused a lot of strictures or fibrosis. Due to that, there is a physical obstruction in the intestine. So in both these conditions, definitely, in both these conditions, whether there is a adhesion or stricture, whether it is an adhesion or stricture, we will go for a surgical management. Okay, very good. In cases of adhesions, we will go for adhesiolysis. You will break the adhesions. And if it is a stricture, you will either go for resection and anastomosis. You will either go for resection and anastomosis. इतने हिस्से में stricture है ना? Okay, इतने हिस्से में stricture है. Just cut this part and anastomose. Yeah, connect the rest of the parts. That is called as resection and anastomosis. Or if there are multiple strictures, then you can go for a stricturoplasty. Okay, so that has to be done. Whereas if it is a case of, please remember, whereas it is a case of adynamic intestinal obstruction. Now, what did I tell you? Adynamic intestinal obstruction is usually paralytic ileus. And why does it happen? So usually it happens due to electrolyte abnormalities. It usually happens due to electrolyte imbalance. It usually happens due to electrolyte imbalance. And what is the most common electrolyte abnormality or the electrolyte imbalance which will cause paralytic ileus? The most common one which causes paralytic ileus is usually hypokalemia. The most common one, and that has been a question. The most common electrolyte abnormality which causes paralytic ileus or adynamic intestinal obstruction is hypokalemia. So here you will try to correct, okay, you will try to correct the electrolyte abnormalities. Okay, here you will try to correct the electrolyte abnormalities in the patient. If they ask you what is the first line management in a case of, what is the first line management? This was the definitive management. But when the patient is coming to you with intestinal obstruction, once you make a diagnosis, what should be your first line management? The first line management is not surgical always. Okay, first we'll try to manage the patient conservatively. And what is my conservative management? So please remember that wherever I say now, henceforth conservative management, you should remember these four things now. Henceforth, whenever I say conservative management, these four things should be remembered. And what are these four things? Keep the patient NPO, nil per oral. Don't give anything orally to the patient. Then give patients IV fluids. Okay, because you are keeping the patient nil per oral, you need to provide nutrition to the patient by IV fluids. Then to avoid any kind of infection, give IV antibiotics in the patient. Okay, IV antibiotics. And as the patient is having a lot of pain, give analgesics or painkillers as well. So these are the four things that we usually do in cases of intestinal obstruction for conservative management. That is always tried as the first line management. If that fails, then definitely we'll go for the definitive management. Okay, sure. Moving further, talking about another cause of intestinal obstruction. And what is this? So here the patient is coming to me with a severe, sudden, acute abdominal pain. Okay, and I have performed a plain X-ray abdomen of the patient. I have performed a plain X-ray abdomen of the patient. And on that X-ray abdomen, I'm able to see such kind of a sign. Then I have performed a barium enema also in the patient. And on performing the barium enema, I'm able to see such kind of appearance. What are these signs and what is your likely diagnosis? What are these signs and what is your likely diagnosis? What are these signs and what is your likely diagnosis? What are these signs and what is your likely diagnosis? Very good. Okay, so the plain X-ray abdomen, as you can see, it is showing me which sign? Definitely the plain X-ray abdomen is showing me the classical coffee bean sign. Okay, it is showing me the classical coffee bean sign. Very good. Whereas important is this barium enema which is there. You can see it is showing me a gradual narrowing. This barium enema which is there. This barium enema is classically showing me the bird beak appearance. So you will say it's a bird beak. Yes. Please remember, bird beak appearance on a barium swallow is a feature of atresia cardia. But bird beak appearance on a barium enema, when we will inject barium sulfate in the large intestine, then it is a case of bird beak appearance. It is also known as this. Bird beak appearance is also known as ace of spade sign. Okay, this bird beak appearance is also known as ace of spade sign. Yes, the coffee bean sign can also be called as omega sign or a bent inner tube sign as well. Okay, so this is a likely diagnosis. Both of these signs are usually seen in a case of sigmoid volvulus. Now I have already told you what is a volvulus. Volvulus is nothing but malrotation or twisting of an organ. Okay, so malrotation or twisting of an organ is what is called as a volvulus. And here, which organ has undergone volvulus? Definitely it is a part of large intestine that is known as the sigmoid colon. So the sigmoid colon which is there, it has undergone a volvulus. What is the direction of malrotation? So the sigmoid colon undergoes malrotation or twisting in the anti-clockwise direction. It undergoes twisting or malrotation in an anti-clockwise direction. Important is, the thing to be remembered is most common site of volvulus in the whole GIT. The most common site for volvulus in the whole GIT, answer is sigmoid colon. Okay, the most common site for volvulus in the whole GIT, answer should be sigmoid colon itself. Please remember that. Okay, volvulus का मतलब होता है malrotation है, twist हो गया है organ. ठीक है, so important is, if a patient comes to me with sigmoid volvulus, definitely all the features of intestinal obstruction will be present. That means a patient will have colicky abdominal pain. The patient will also have vomiting. Okay, the patient will also have obstipation and constipation as well. All of these features. So now what will be done? A first line investigation will be X-ray abdomen, and on this I have told you already the classical coffee bean sign will be seen. Then I can go for a barium enema, which is not routinely done. On that I will be seeing a classical bird beak appearance. And what is the investigation of choice? I have told you all cases of intestinal obstruction, investigation of choice is a CECT abdomen. Okay, so over here also the investigation of choice is a CECT abdomen. It is also a CECT abdomen. What is done for treatment in this condition? What is done for treatment in this condition? That's very important. Please remember, for treatment, what we did in gastric volvulus. In gastric volvulus, we decompressed. Okay, we removed all the gas or the feces which were present. Here also we will do the same thing. We will go for a decompression and then we will go for a derotation. Okay, जैसे ही तुम decompress कर दोगे, the organ will come to lie in its original position. Okay, as soon as you perform a decompression, the organ will derotate and come to lie in its original position. Okay, so that is what is called as derotation. And then we will fix the organ so that again this volvulus should not happen. Okay, again this volvulus should not happen. So that is what is called as. So please remember, for treatment, definitely I'll go for decompression of the sigmoid colon. Decompression should be done. And definitely after decompression, I'll go for fixation of the sigmoid colon. That is called a sigmoidopexy. But the problem is, with sigmoidopexy also, a lot of recurrence is seen. Okay, a lot of recurrence is seen usually. That's the reason why, please remember, that's the reason why. Okay, that's the reason why we prefer doing a sigmoidectomy commonly. Okay, that's the reason why we prefer doing a sigmoidectomy followed by sigmoidopexy. Okay, so if you need to answer the best treatment, so please remember, after decompression, the better treatment is sigmoidectomy followed by sigmoidopexy. Yes, because even if we perform sigmoidopexy, it has been seen there is a very high chance of recurrence. That's the reason why. Okay, we will go for a sigmoidopexy in the patient. No issues with this, anybody? So that is important to be remembered. Okay, another treatment which can be given in this patient is known as a Hartmann's procedure. Another treatment that is given in the patient when the patient is unstable is known as a Hartmann's procedure. And what is done in Hartmann's procedure? Usually we will remove the sigmoid colon and we will bring out the colon on the abdominal wall. Okay, we will remove the sigmoid colon and we will bring out, or we will make a new opening for the descending colon on the abdominal wall. When we make an opening for the descending colon of the abdominal wall is known as colostomy. So we are performing a colostomy. So Hartmann's procedure is nothing but removal of the sigmoid colon and performing a colostomy. That is what is known as the Hartmann's procedure. Okay, so that should be done as well. So you will say, sir, in this also we were performing a sigmoidectomy, but in this, once we have removed the sigmoid, we were connecting, please remember, we were connecting the sigmoid, once we have removed the sigmoid, we were connecting the descending colon with the rectum. Okay, we were performing an anastomosis. But in Hartmann's, we are not performing an anastomosis, we are just bringing out the colon. Here we are not performing an anastomosis, we are just bringing out the colon. That's the basic difference between the procedure mentioned above and between a Hartmann's procedure. Okay? Next condition is this one. What is this? Image-based diagnosis. A lot of times it has been asked in your exam. Sarkari question of your exam. Let me know the image-based diagnosis. What is your diagnosis? You can see this is the intestine. Okay, and this is the mesentery. I have told you usually. Okay, so on one side the intestine is attached to the mesentery, which will fix also and which will also give blood supply to the intestine. What is this a case of? Very good. This is a classical case of Meckel's diverticulum. So you can see there is a outpouching from the intestine. This outpouching from an organ, as I've told you, it is nothing else but a diverticulum. Okay, and a intestinal outpouching is known as a Meckel's diverticulum. So if I talk about Meckel's diverticulum, I hope all of you are quite aware about this. Sarkari question, very common question of your exam. So in cases of Meckel's diverticulum, guys, okay, Meckel's diverticulum, please remember it is the congenital diverticulum. What do I mean by the statement? That means it is present since birth. Okay, so it is present since birth. Definitely it is a true or false diverticulum. Definitely it is a true diverticulum. Why? Because it contains all the layers. It contains mucosa, submucosa, muscularis. Okay, all the layers are present in the diverticulum. Therefore it is a case of true diverticulum. Yes, it does follow a rule of 2. And what is the rule of 2 that is followed by Meckel's diverticulum? First of all, 2% of the population is affected. Okay, so 2% of population is affected definitely with Meckel's diverticulum. Next, please remember is it is 2 feet proximal. It is 2 feet proximal to which junction? So it is present in the terminal part of the ileum usually. Okay, it is present in the ileum, mainly in the terminal part of ileum. So it is 2 feet proximal to the ileocecal junction. Okay, it is 2 feet proximal to the ileocecal junction. It is 2 inches long. Okay, so please remember it is 2 inches long. Some books say it is 2 centimeters wide also. Okay, and important is 20% of the cases of Meckel's diverticulum. 20% cases of Meckel's diverticulum will have an ectopic mucosa. And this was the question, which is the most common ectopic mucosa present in Meckel's diverticulum. Okay, so usually it should have some intestinal mucosa because it is present or it is an outpouching from the intestine. But most of the Meckel's diverticulum or 20% of the Meckel's diverticulum will have an ectopic mucosa. And the question was, which is the most common ectopic mucosa present in a Meckel's diverticulum? Answer is a gastric mucosa followed by pancreatic mucosa. Okay, the most common ectopic mucosa is the gastric mucosa followed by pancreatic mucosa. Okay. Yes, now just I am explaining you important things. It will help you in anatomy also. Okay, a very common question. Please remember, during the fetal life, we have a midgut. Okay, during the fetal life, the midgut and the umbilicus. Okay, this is your umbilicus. So during the fetal life, the midgut and umbilicus have an abnormal connection. Okay, they have a connection in the fetal life. The midgut and umbilicus have a connection. This connection is called as vitellointestinal duct. This connection is known as vitellointestinal duct. It is also known as omphalomesenteric duct. Okay, now important, this is present over here. Okay, usually after birth, what happens? This connection disappears. After birth, this connection or this vitellointestinal duct will disappear. But in some patients, what happens? It does not disappear. It remains patent or it remains open. Even after birth, in some of the neonates, it will remain patent. What will happen now? Therefore, what will happen? What is present in the midgut? Feces. So therefore, feces will try to flow out. Okay, the feces start flowing out from this open vitellointestinal duct. And what is the diagnosis in this condition? That has been asked. So please remember that was a previous year question which was asked. A pediatrician is examining a patient in an ICU or neonate in an ICU and feces is coming out from the umbilicus. What is the likely diagnosis? So please remember here, what is the cause? The vitellointestinal duct has not disappeared even after birth. It is still open or it is still patent and it is having an abnormal connection, a two-way communication with the midgut and with the umbilicus. Therefore, This is what is the case of vitelline fistula. Two-way communication is known as fistula. So this is what is the case of vitelline fistula. But in another condition, okay, that is the case of vitelline fistula. But in another condition, what has happened? Now this vitreointestinal duct started disappearing. Okay, it started disappearing, but only some part was left behind. Okay, it started disappearing, but some part was still left behind. And this some part which was left behind, that is partially it was open. Okay, there was a partially patent vitreointestinal duct. And if it was partially open, that is what is called as a Meckel's diverticulum. So if there is a partial patency of the vitreointestinal duct, that is what leads to formation of a Meckel's diverticulum in a patient. Okay? So yaad rakhna, the question was Meckel's diverticulum is due to persistence of which embryological structure? Now you know Meckel's diverticulum is due to persistent and patency, partial patency of vitreointestinal duct. Next question which has been asked, a patient is a child is having urinary bladder, okay, in the fetal life. This urinary bladder also has a connection with the umbilicus. During fetal life, this urinary bladder also has a connection with the umbilicus, and that is called as allantois. Okay, that is also known as urachus. And the remnant of allantois is also known as urachus. And you can see if this allantois or urachus, it will disappear after birth. This allantois or urachus will disappear after birth. But if it does not disappear, what will happen? Definitely a lot of urine will start coming out from the umbilicus. A lot of urine will start coming out from the umbilicus. That was another previous year question. So if the urine is coming out from the umbilicus of a neonate, then what is the cause? The cause is that the allantois or the urachus which was there, it has not undergone obliteration. Okay, it is still open, it is still patent. So what is your likely diagnosis in this condition? Here there is an abnormal communication between the urinary bladder and the umbilicus. Therefore, it is a case of urachus fistula. Okay? So these are the important things that you need to remember. So, now coming back to Meckel's, as I've told you, it is due to partial patency of your vitreointestinal duct definitely, and it is present on which border? That is important. It is present on the anti-mesenteric border. Okay? And I've told you it is present usually in the ileum in a patient. Okay? Now here, what is the most common clinical presentation? Yaad rakhna, most of the cases of Meckel's diverticulum are asymptomatic. It is an incidental diagnosis. That means you're operating for appendicitis in a patient, and at that time when you examined his ileum, you found out a Meckel's diverticulum. So it is an incidental diagnosis. But sometimes the patient can have some clinical feature, and if they say the most common clinical presentation, then the answer is bleeding per rectum. Okay, that has been a question again. Bleeding PR, that is bleeding per rectum, is the most common clinical presentation in a case of Meckel's diverticulum. The patient can also have not red currant jelly stools. No, here the patient will also only have bleeding per rectum, that is hematochezia, fresh blood in stools. Okay, red currant jelly stools are seen in a case of intussusception that I'll discuss now. Okay, so that's the important thing over here. No issues with this, anybody? If they ask you what can be the complication, there can be inflammation of the Meckel's diverticulum. Why? Because if the neck of the Meckel's diverticulum is blocked, definitely there will be inflammation, that is called as Meckel's diverticulitis as well. Okay, the patient will have pain, fever, all of these features then. Or there can be perforation also. Okay, there can be perforation as well. If they ask you what is the investigation of choice, now for this I need an answer from all of you. What is the investigation of choice for Meckel's diverticulum? Has been a previous year question. What is the investigation of choice for Meckel's diverticulum? Till that I'll talk about the treatment. If I talk about the treatment, as I've told you, if it is having a wide mouth, definitely there are no chances of obstruction. So why to remove it? The patient is asymptomatic and the Meckel's diverticulum is having a wide mouth, then definitely leave it as it is. But if the Meckel's diverticulum definitely is having a narrow mouth, now there are high chances of obstruction, and that will lead to diverticulitis. So if there are high chances of obstruction, then better you need to perform a removal, that is called as diverticulectomy. Then you need to perform a diverticulectomy in the patient. Okay? And if there is perforation, as I've told you, one of the complications can be perforation also. If there is perforation, the part of the intestine which has perforated, definitely cut that part. Okay, cut that part and join the remaining parts. So now cutting the part is called as resection, and joining another parts is called as anastomosis. So in cases of perforation, go for a resection and anastomosis. Okay, so for perforation, go for resection and anastomosis in the patient. Very good, Mohit. Very good, Nat. Very good, Ravinder, Rashid, all of you. The investigation of choice is different over here. Yes, it is a nuclear scan called as technetium 99 per technete scan. It is known as the technetium 99 per technete scan. That has been a previous year question. Technetium 99 per technete scan is the investigation of choice. Very good. Okay? चलो आगे बढ़ते हैं. Now another case I am giving to you. Again a case of intestinal obstruction. Here the child is brought to me with, usually it is a child who is around 1.5 years of age. The child is brought to me with abdominal pain. Along with that, the child is having red currant jelly stools. What are red currant jelly stools? These are nothing but blood and mucus containing stools. These are nothing but blood and mucus containing stools. Okay. Along with that, when I palpate the abdomen of this patient, okay, I will be able to feel a sausage shaped lump. When I palpate the abdomen of this child, I am able to feel a sausage shaped lump. Okay, and when I see the right iliac fossa, the right iliac fossa appears to be empty. Okay, the right iliac fossa appears to be empty, known as the dance sign, known as the sign of dance or the dance sign. What is the likely diagnosis? Let me know. Let's say, okay, a child with complaints of abdominal pain along with red currant jelly stools, vomiting. On palpation, there's a sausage shaped lump and right iliac fossa appears to be empty, known as the sign of dance. What is the likely diagnosis? The likely diagnosis in this condition will be important. सरकारी क्वेश्चन ऑफ योर एग्जाम. मैकल्स के बाद या मैकल्स से भी ज्यादा कॉमन अगर कोई क्वेश्चन है तो इट इज दिस वन. व्हाट इज योर डायग्नोसिस? Very good. It is a case of intussusception. Very good. It is a case of intussusception. If I talk about intussusception, guys, please remember, if I talk about intussusception, okay, what is intussusception? When one part of the intestine goes into the adjacent part of intestine. So this is one part of the intestine which is a larger part, and this is another part of intestine which is smaller. So when one part of the intestine goes into another part, that is telescoping or invagination of one part of bowel into the adjacent bowel is what is called as intussusception. जब एक हिस्सा intestine का दूसरे हिस्से में घुस जाता है, that is intussusception, as you can see over here in this picture. This is what is the case of intussusception. ठीक है? So that's important over here. If I talk about intussusception, definitely it is more common in children between 6 months to 2 years of age. It is more common between 6 months to 2 years of age, definitely in the children. Okay, important is the patient or the child will have features of intestinal obstruction that I've already discussed. On examination, the patient will have a sausage shaped lump, that is a keyword, and the right iliac fossa will appear to be empty because the most common site of intussusception is what? The most common site of intussusception, as we discussed, it is more common in children. The most common site of intussusception is ileocolic, okay, or ileocecal. That means the ileum goes into the cecum. Okay, ileum is the last part of small intestine, cecum is the first part of large intestine. Okay, so therefore the ileum goes into cecum definitely. Okay, that is what is the ileocolic intussusception which occurs, and therefore as the ileum goes into the cecum, okay, therefore in the right iliac fossa you will not be able to feel any part of the intestine. Therefore the right iliac fossa appears to be empty. That is what is known as the sign of dance. Okay, so that's important. In adults, if they ask you the most common type of intussusception or the most common site of intussusception, in adults if they ask you the answer, then the answer should be colocolic. In adults if they ask you, then your answer should be colocolic. Okay, then along with these features, these characteristic features, if I go for the investigation, okay, if I go for the investigation, what is the investigation of choice in a case of intussusception? Please remember the investigation of choice in a case of intussusception will be what? Answer me this one. Okay, answer me. What is the investigation of choice in a case of intussusception? This is a classical question. This image. This is a case. This is the barium enema performed in a case of intussusception. This is a barium enema performed in a case of intussusception. You are able to see that this looks like a colonna. Therefore, this first sign, which is known as the claw sign, you will be able to see a claw sign, and you will also see a coiled spring sign. So the two signs which are seen on a barium enema in a case of intussusception are definitely the claw sign or the coiled spring sign. The claw sign and the coiled spring sign. That is important. Please remember that. No, not enema. No, not enema. Not even an X-ray. Investigation of choice. Investigation of choice, please remember, is the ultrasound abdomen. Investigation of choice in a case of intussusception is the ultrasound abdomen. And on ultrasound abdomen, I'll be able to see which sign, please remember. On ultrasound abdomen, I'll be able to see this classical target sign which is there. Okay, I am able to see this classical target sign. This target sign is also known as, anybody, the target sign, please remember, it is also known as the donut sign. The target sign is also known as the donut sign. Okay, so target sign or donut sign will be seen classically. That's important, please remember. Or we can also see a pseudo kidney sign. We can also see a pseudo kidney sign on ultrasound, please remember. Okay, so target or donut sign is usually seen, please remember that. Okay, so definitely ultrasound is usually the investigation of choice, but if ultrasound fails to pick up the diagnosis, you can go for a barium enema also or a CECT as well. Okay, that's important. If I talk about the treatment in a case of intussusception, we know the rule in cases of intussusception is never pull this. Okay, never pull the invaginating loop. Always try to push it outside. Always try to push it outside. So if you push it outside, definitely what will happen? There will be less chance of perforation. Okay, so that is important over here, and that is usually done by what? We are performing a barium enema in the patient. Okay, so we are performing a contrast enema. After we perform a contrast enema and we see this claw sign or coiled spring sign, what we will do? From the rectum of this patient, we will inject a lot of fluid. Okay, from the rectum of this patient, we will inject a lot of fluid, or we will inject a lot of air. Okay, and due to the pressure from the air or fluid, what will happen? The invaginated part or the part which has gone inside will come out easily. Okay, so that is what is done. This is known as enema. Contrast enema is done for treatment. Okay, contrast enema is done for treatment. So important is, contrast enema is not only diagnostic in cases of intussusception, it is also therapeutic, because it is not only making a diagnosis, it is also used for treatment as well. Okay, and which kind of reduction is performed? Either we can push water, that is hydrostatic, or we can push a lot of air, that is pneumostatic reduction is done. So hydrostatic or pneumostatic reduction with the help of a contrast enema, that has to be done. Please remember. Okay. Very good, very good. Okay, great. Next important is, let's move further after intussusception. If I talk about another condition, and what is this? Here you can see, okay, here you can see it is a case of diverticulosis of colon. What is diverticulosis? If there is one diverticula, we call it diverticulum. But if there are many diverticulae, then it is, this condition is called as diverticulosis. Okay, so here definitely we are talking about diverticulosis of colon. We are talking about diverticulosis of large intestine or the colon. Important is, what is the most common site of diverticulosis? Diverticulum can be seen in the ileum, that is Meckel's. It can be seen in the esophagus, but the most common site for diverticulosis is usually, please remember, the most common site for diverticulosis is usually the sigmoid colon. The most common site for diverticulosis. तो याद रखना, अगर कुछ नहीं आता तुम्हें, और अगर तुम्हें मोस्ट कॉमन साइट इंटेस्टाइन में कोई पूछी गई है, तुम्हें कुछ नहीं आ रहा, तो याद रखना, most of the cases, the most common site for intestinal pathologies is usually the rectosigmoid, either the rectum or the sigmoid. Mainly it is the sigmoid in most of the conditions. Okay, so it is a very safe answer if you do not know anything. Okay, if you know, better answer it properly. So next, if I talk about diverticulosis of colon is more common in which patient? So it is a case of an acquired diverticulae. So it is more common in the elderly patient. Okay, it is more common in elderly patient. The patient is usually asymptomatic. Okay, most of the cases of diverticulosis are asymptomatic, or the patient can have chronic constipation. The patient can have a chronic constipation. What is done for investigation? So please remember, for investigation, definitely the investigation of choice can be a barium enema. Okay, okay, if the patient is stable, we can just go for a barium enema, and on barium enema, this characteristic sign is seen. Please let me know what is the characteristic sign in cases of diverticulosis of colon seen on barium enema called as. Okay, if we perform a colonoscopy, which is not commonly done, you can see these outpouchings, multiple outpouchings from the intestine. Okay, there are multiple outpouchings from the intestine which are seen. Okay, that is what is the diverticulosis of colon. So important is, please remember, if the patient is stable, definitely the investigation of choice is a barium enema. And what sign is seen? Let me know that. But if the patient is unstable, definitely I'll go for a, this unstable patient does not mean that the patient is having low BP. यहाँ पे unstable patient means either the patient is having perforation or the patient is having inflammation, that is diverticulitis. Okay, that is what is an unstable patient. So definitely in that condition, the investigation of choice is a CCT. Okay, that is a, नहीं तो otherwise you will say sir trauma में तो कल आपने बोला था definitely unstable patient में CCT नहीं करते. So that was hemodynamically unstable. This is an unstable patient according to the intestinal problems. Very good. It is the sawtooth appearance seen on barium enema. This appearance which is seen looks like Ari ke daat, like teeth of the saw. Therefore, this is classically known as the sawtooth appearance. So, sawtooth appearance on barium enema is definitely a feature of diverticulosis of colon. Okay, very good. Now, if I talk about the treatment, guys, if I talk about the treatment, definitely what should be done? Okay, if I talk about the treatment, sorry, what should be done? Important is in cases of diverticulosis of colon, we will go for resection and anastomosis. Okay, we will cut the part of the diverticula. Okay, the part of the intestine which is having a lot of diverticulae, we will definitely cut that part and definitely will go for a resection and anastomosis. We will go for a resection and anastomosis. Okay, we will go for a resection and anastomosis. That's important. Okay, and if there was a perforation, definitely you know now, if there is a perforation, it will cause peritonitis. Therefore, we need to go for an exploratory laparotomy along with cleaning of the peritoneum called as peritoneal lavage. And then definitely if there is less infection, you can repair it immediately. But if there is a lot of infection, then leave a drain over there and repair it after a while. Okay, so that's important. Yes, very good. To avoid any constipation, definitely a high fiber diet is recommended. Okay, that is important. Moving further, talking about IBD. And what is IBD? So please remember, IBD is nothing but inflammatory bowel disease. Okay, IBD is nothing but inflammatory bowel disease where there is inflammation of the colon or the intestine of the patient. Okay, and they are of two types. Inflammatory bowel disease can be either Crohn's disease or it can be ulcerative colitis. It can be either Crohn's or ulcerative colitis. If they ask you which is the most common part affected, so please remember, in a case of Crohn's disease, any part of the GIT can be affected. Yes, any part of the GIT can be affected except the rectum. Any part of the GIT can be affected except the rectum. Please remember. Okay. Whereas if they ask you the most common part, then definitely the answer is terminal ileum. If they ask you the most common part in Crohn's disease, then answer is terminal ileum. If they ask you the most common site or the most common part affected in ulcerative colitis, then answer is rectosigmoid. What do I mean by this? The rectum and the sigmoid colon. The most common part affected in ulcerative colitis is the distal part of the colon, that is rectosigmoid. If they ask you about features, what will be the clinical features or complaints of a patient? In Crohn's disease, the patient has colicky abdominal pain. In a case of Crohn's disease, patient has colicky abdominal pain. Along with that, patient has diarrhea. So the patient will have painful diarrhea. Okay, the patient will have painful diarrhea. But important is in cases of ulcerative colitis, please remember, here the patient has a painless bloody diarrhea. Here the patient has a painless bloody diarrhea. Here the patient has a painless bloody diarrhea. Okay. Next important is involvement now. Okay. So what kind of lesions you will see in a case of Crohn's disease and in a case of ulcerative colitis. So please remember, in cases of Crohn's disease, you will not see continuous lesions. Rather, you will see some lesions like this. What are these called as? These are known as the skip lesions. Okay. So you will see skip lesions in cases of Crohn's disease. But every skip lesion which is there, it involves all the layer of the wall. It involves all the layer of the wall. And that is what is called as transmural involvement. Okay. That means mucosa, submucosa, muscularis, till serosa, all the layers are involved in a case of Crohn's disease. So there will be skip lesions and there will be transmural involvement. But in cases of ulcerative colitis, it is completely opposite. Here there will be only superficial lesions. It will not be a transmural lesion. And second, it will not be skip. It will be a continuous lesion. So in a case of ulcerative colitis, there will be continuous lesions. And important, there will be superficial lesions as well. There will be superficial ulcers which will be formed. Okay. Now, Crohn's disease is commonly associated with which another disease or which another condition. So Crohn's disease is commonly associated with arthritis. Okay, inflammation of the joints. Crohn's disease is commonly associated with arthritis, whereas the most common disease associated with ulcerative colitis is PSC. And what is PSC? It is nothing but primary sclerosing cholangitis. What is cholangitis? Inflammation of the biliary tree or inflammation of the bile ducts. Okay, so please remember, ulcerative colitis is commonly associated with primary sclerosing cholangitis, a previous year question. Next, what are the investigations done in cases of inflammatory bowel disease? So the investigation that we can do, usually, as we know that inflammatory bowel disease is an autoimmune condition. What do I mean by this term, autoimmune? That means here there will be some antibodies which are formed, which will target our own intestine. Okay, our body is forming some antibodies which are targeting our own intestine. ठीक है, कुछ antibodies बनेंगी जो अपनी ही body को damage करने पे तुली हुई है. ठीक है, so that's important. So the investigation is usually antibody titer. And which is the antibody seen in cases of Crohn's disease? So the antibodies seen in cases of Crohn's disease are called as ASCA. What is ASCA? Anti-Saccharomyces cerevisiae antibody. Anti-Saccharomyces cerevisiae antibody. Whereas in cases of ulcerative colitis, these are called as P-ANCA. That is, P-ANCA antibodies are a feature of ulcerative colitis. Please remember that. Okay. Then, if I talk about another investigation, I can perform a colonoscopy. Okay. And when I perform a colonoscopy, guys, definitely what I am able to see in a case of Crohn's disease, I am able to see cobblestone mucosa in a case of Crohn's disease. Okay, in a case of Crohn's disease, I am able to see cobblestone mucosa. But in cases of ulcerative colitis, I am able to see pseudopolyps. In cases of ulcerative colitis, I am able to see pseudopolyps. Whereas if I talk about radiological investigation, what is the radiological investigation that I'll do? I'll do a barium enema. Why enema? Because here the large intestine is commonly affected now, and for colon we go for a barium enema. On a barium enema in a case of Crohn's disease, I'll see there will be a lot of strictures, and due to this strictures, due to fibrosis, I'll be able to see this classical sign. And in a case of Crohn's disease, I'm able to see this classical string sign of Cantor. I'm able to see this classical string sign of Cantor. Whereas in cases of ulcerative colitis, you can see that the large intestine is not having these hostrations. Okay, it appears like a pipe. Therefore, in cases of ulcerative colitis, on a barium enema, I am able to see loss of hostrations known as the lead pipe colon. I am able to see loss of hostrations known as the lead pipe colon. Okay, important is that. Now, talking about the investigation of choice. If I talk about investigation of choice, it is usually a colonoscopy should be done plus biopsy. Investigation of choice is a colonoscopy plus biopsy. Now, all of you will be answering. You have completed your pathology. Please answer me that what is the biopsy feature in Crohn's disease and ulcerative colitis. What you will see on a biopsy in a case of Crohn's disease and ulcerative colitis. Okay, so write CD dash and UC dash. Answer it in the chat box. Then if I talk about the first line management, definitely the first line management in both the conditions is medical management. And what is the drug of choice for that? So we know in Crohn's disease, the drug of choice is usually steroids. The drug of choice in cases of Crohn's disease is generally steroids. But in cases of ulcerative colitis, we generally go for a 5-ASA derivative, that is 5-amino-salicylic acid derivative, and the drug which is preferred is known as sulfasalazine. The drug which is considered as the drug of choice is known as sulfasalazine. Okay, in cases of ulcerative colitis treatment. That's important. Please remember. So just answer me the investigation of the biopsy features in cases of CD and UC. Okay. Important is if I talk about the surgery. Now, if the intestine is completely damaged, then definitely I can go for a surgery, and that is what is called as total. Okay, then I will go for a total proctocolectomy. I told you proctum is nothing but the rectum. So rectum will not be removed in cases of Crohn's disease, but it is removed in cases of ulcerative colitis. Okay, so we will go for a total proctocolectomy, and if we have removed the total colon, what is left behind? The large intestine has been removed, so the small intestine is left, that is the ileum is left. Now we will bring the ileum downwards. Okay, we are bringing the ileum downwards, and we are forming a J-shaped pouch with the ileum, and we are connecting it to the anal canal. Okay, this is what is called as the ileal pouch anal anastomosis. This is what is known as the ileal pouch anal anastomosis. So ileal pouch anal anastomosis has to be done. Okay, so total proctocolectomy with ileal pouch anal anastomosis. No answers, so chalo. Please remember, in a case of biopsy, in a case of Crohn's disease, I am able to see a classical non-caseating granuloma. Okay, that will make my diagnosis because I am able to see a non-caseating granuloma in a case of Crohn's disease. Whereas if I talk about ulcerative colitis, here on the biopsy, I am able to see cryptitis or crypt abscesses. What is crypt abscesses? So I hope all of you are quite aware. These are known as the crypts. In the crypts, I am able to see collection of neutrophils. That is what is called as a crypt abscess. So that is what is seen in a case of ulcerative colitis. So don't forget it. Please remember, that's important. So that is what is important to be remembered about inflammatory bowel disease or IBD. Next cause of intestinal obstruction, that too in a neonate. Please remember, that too in a neonate will be this condition. What is seen in this condition? A neonate has been brought to you, okay, to the pediatric emergency room with complaints of no passage of meconium. On digital rectal examination, the meconium floods out. What is the diagnosis and management? तो एक neonate लाया गया है, नए नवजात शिशु लाया गया तुम्हारे पास, okay, and the child has not passed any meconium. Therefore, you are performing a digital rectal examination, DRE, and as soon as you insert your finger, usually you perform a DRE in a case of neonate with the help of the little finger. So as soon as you insert the little finger, the meconium floods out. बाढ़ आ जाती है पूरे meconium की. So what is your likely diagnosis and what is the management? Make a diagnosis. Very good, Ravinder. It is a case of Hirschsprung's disease. Very good. It is a case of Hirschsprung's disease. So important is, if I talk about Hirschsprung's disease, guys, Hirschsprung's, I hope all of you are quite aware. Hirschsprung's disease is also known as congenital. Why? Because it is present since birth, right? So it is a case of congenital aganglionosis. It is a case of congenital aganglionosis. It is a case of congenital aganglionosis, or it is also called as a congenital megacolon. So what do I mean by this term? So it is a case of congenital aganglionosis or megacolon. So important is, please remember, usually in the intestine, as told you, there are 4 layers in the wall. Now there is mucosa, there is submucosa, there is muscularis, and there is serosa. Okay, so usually we have one nerve plexus. We have one nerve plexus in the submucosa, and this is called as the Meissner's. Whereas we have another nerve plexus in the muscularis layer, and that is called as Myenteric or Orbach's plexus. Okay, so these are the 2 nerve plexuses present in the intestine of a patient or a GIT of the patient. Now what has happened over here? The ganglion cells which were there, okay, the ganglion cells which were there now, they are not present in the Meissner's as well as the Myenteric plexus. Yes, so there is absence of ganglion cells in the Meissner's as well as the Myenteric plexus. So if the ganglion cells or the neurons, they are absent, definitely what will happen? The intestine will not be able to perform peristalsis because there is no stimulus only. न्यूरॉन ही नहीं है तो स्टिमुलस आएगा क्या? नहीं आएगा. और स्टिमुलस नहीं आएगा तो पेरिस्टाल्सिस होगा क्या? नहीं होता. That is what is seen in a case of Hirschsprung's disease. So please remember over here, in cases of Hirschsprung's disease, there is absence of, okay, so there is absence of ganglionic cells. There is absence of these ganglionic cells in both the plexuses, not only the Meissner's plexus but also the Myenteric plexus. Okay, there is absence of ganglionic cells in the Meissner's as well as the Myenteric plexus of the nerves. Okay, due to that there is no peristalsis. Due to that there is no peristalsis in some part. Okay, so please remember this is only about some part of the intestine. For example, see, this part of the intestine is having the ganglionic cell, but now this part of intestine does not have the ganglionic cell. Therefore you can see this part of the intestine is collapsed. Okay, this part of intestine is collapsed. Therefore all the food will collect over where? In the proximal part. All the food will collect in the proximal part. Therefore the proximal bowel loops or the proximal colonic loops, they will get dilated or they will get distended. That is the likely case or classical case of Hirschsprung's disease. That's important. Okay, chalo, so that is important. You need to remember. See, okay, over here, yeah, so you can see this is the collapsed loop. Okay, this is the collapsed part which is not having any ganglionic cells, and this is the transitional zone, and this is the proximal dilated bowel. This is the proximal dilated bowel. How the case will present to you? Definitely, usually there can be 2 types of presentation. What can be there? So please remember, one patient can be brought to me in emergency, okay, and he will usually be a neonate. He will usually be a neonate, and the same history which was given in the question, that the neonate is not passing meconium. The neonate has not passed meconium, and there's a lot of no meconium has been passed, and there's a lot of abdominal distension. Okay, because we are feeding the baby with milk now, but the baby is not passing any meconium or stools. Therefore, a lot of the intestines will keep on distending, and the abdomen will also keep on distending. Phulta jata hai abdomen. So there is abdominal distension. Okay, so that is a case of neonate when there is a complete loss of ganglionic cells. Next is a condition where there is a very small segment which is not having these ganglionic cells. Okay, so in that condition, the child will not be brought in the case of emergency. The child will be brought in OPD, and it will not be a neonate now. This time it will be a child who is brought to me. Okay, so usually in childhood, usually in school age, the child is brought to me, and the main complaint that the mother says is chronic constipation. Okay, recurrent or chronic constipation is the main complaint of this child. Okay, so this is the 2 types of presentation in a case of Hirschsprung's disease. What is done for diagnosis now? Once you suspect, okay, it is a case of Hirschsprung's disease, definitely, what is done for diagnosis? The investigation of choice which is done for diagnosis, as I need to see whether the ganglionic cells are present or not, I need to take a biopsy and I need to see it under the microscope. Therefore, the investigation of choice is a full thickness rectal biopsy. Okay, the investigation of choice is a full thickness rectal biopsy. But if they ask you to see the extent, okay, to see the extent that how much part is aganglionic, okay, how much part is aganglionic, to see the extent of the disease, कि कितने हिस्से में ganglionic cells नहीं है, वो देखने के लिए, to see the extent of the disease, if they ask you, then the better investigation is MRI. Better investigation is MRI. But if that is not an option, go for a barium enema, as we have seen. Okay, if that is not an option, go for a barium enema. What is the treatment in this patient? What is the treatment in this patient? Just remember, the treatment in this patient is definitely what? As there is absence of ganglionic cells, okay, definitely we need to cut that part. Okay, definitely we need to what? We need to cut that part, and we need to bring down the remaining part of the colon and attach it to the anal canal or the rectum. Okay, so that has to be done. So it is done by various operations that we have. Either it is called as the Duhamel's operation. It is either known as the Duhamel's operation. It is also known as the Swenson's operation, or the third one that we have is known as the Sove and Parks coloanal anastomosis. Okay, so Sove and Parks operation, or the Sove and Parks coloanal anastomosis. So these are the surgeries which can be done in a case of Hirschsprung's disease. Please remember. Next, please let me know. This is a case of barium enema. This is a barium enema, and the patient has come to me with complaints of abdominal pain. The patient has come to me with complaints of abdominal pain, and this is the barium enema finding. What is the likely diagnosis? What is the sign seen on barium enema, and what is the likely diagnosis? Okay. Now, if I talk about colorectal cancer, guys. If I talk about colorectal cancer, okay. In cases of colorectal cancer, sorry. If I talk about colorectal cancer, the most common site for a colorectal cancer is definitely the rectum. Okay. So please remember, the most common site for colorectal cancer is the rectum, followed by the sigmoid colon. Okay, it is the rectum followed by the sigmoid colon. Colorectal cancer is commonly associated with multiple syndromes. One of the important syndrome you need to remember is FAP. What is FAP? Familial adenomatous polyposis. When there are more than 100 adenomatous polyps in the intestine of this patient, it is associated with a gene mutation that is called as APC gene mutation, located on chromosome number 5. Okay, so that is commonly associated. And in a case of FAP, the patient has 100% risk of colorectal cancer. Next is what is called as HNPCC. Here the patient will not have polyps. It is a hereditary non-polyposis colon cancer. And hereditary non-polyposis colon cancer is also known as Lynch syndrome. That has been asked. And important is HNPCC or Lynch syndrome is associated with gene mutation. And what is that? It is usually associated with a mismatch repair gene defect. It is associated with mismatch repair gene defect. Please remember that. Okay? So that has to be remembered. Next is definitely your Peutz-Jeghers syndrome. The next one important is definitely your Peutz-Jeghers syndrome. Okay? So Peutz-Jeghers syndrome has hematomatous polyps. Usually hematomatous polyps, only if they are present, that is not a risk for colorectal cancer. But if hematomatous polyps are associated with some syndrome like Peutz-Jeghers, definitely that is a risk factor for colorectal cancer. It is due to STK11 gene mutation. Okay, sure. So these are the important ones. Definitely smoking, alcohol, they are always a risk factor. Here also they are an important risk factor. If I talk about the complaints of the patient, definitely the patient will have a chronic weight loss. Okay, the patient will have bleeding also sometimes per rectum due to the cancer. Okay, and the patient will have other signs of malignancy as well. Okay, there can be a mass rarely which can arise. Important is, please remember, if I check a case of colorectal cancer, what is the investigation of choice? The investigation of choice is usually, I will insert a camera from the rectum, that is called as colonoscopy, and then I'll take a biopsy. The colonoscopy plus biopsy is the investigation of choice. If they ask you what is the investigation of choice for T and N staging, okay, for other types of cancers, that is whether it was a esophageal cancer or a stomach cancer, what did I tell you? T and N staging is decided by the depth of invasion. Ki kitne layers involved, how many layers are involved. For that it was endoscopic ultrasound. But for colorectal cancer, we are not able to perform endoscopic ultrasound. Therefore, over here, definitely the investigation of choice for T and N staging is a MRI. Here it is definitely MRI. Investigation of choice for overall staging. What do I mean by overall staging? Not only T and N, but T and M staging. And that is what is a PET CT. That is what is a PET CT. That's important. Okay. If they ask you what is the most common site of metastasis, what is the most common site of metastasis in a case of colorectal cancer? What did I tell you? Whether it is esophagus, stomach or colorectal, the most common site of metastasis is the only bechara organ known as liver. Okay, it is always the most common site. Okay, very good. Yes, for staging, once we have done the TNM staging, usually for staging we use a criteria, and that is what is called as Duke staging. So if they ask you that Duke staging is used for which cancer, Duke staging is used for colorectal cancer. Duke's grading is used to assess the severity of chronic stable angina, whereas Duke's criteria is used to make a diagnosis of infective endocarditis. These are the important Dukes you need to remember. Okay, that is important. Then if I perform a barium enema in a case of colon cancer, on a barium enema I'll be able to see a classical sign. And what is the classical sign? You can see here there is a cancer, right? So on a barium enema I'll be able to see a narrowed lumen, and that is classically called as your upper core appearance. That is classically known as your upper core appearance. Okay, so that is what is seen. Then if I ask you what is the tumor marker, please answer this question now. What is the best tumor marker for a colorectal cancer? Okay, what is the best tumor marker for a colorectal cancer? Answer that question in the chat box. Okay, till that time I'll talk about the treatment now. Important is the treatment of choice is always removal. Because it is a cancer, definitely the treatment of choice is always a removal. Important is if the cancer is in the cecum, I will remove the whole right side of the colon. That is what is called as right hemicolectomy. I'll remove the whole right colon. That is called as right hemicolectomy. If the cancer is in the ascending colon, if the cancer is in the ascending colon, or it is usually in the hepatic flexure, or it is in the transverse colon, then I'll go for a extended right hemicolectomy. If the cancer is in the descending colon, or it is in the splenic flexure, then definitely I'll go for a left hemicolectomy. And if the cancer usually is in the sigmoid colon, I can only go for a sigmoidectomy. Yes, I can only go for a sigmoidectomy. Or there are very high chances, if sigmoid colon is affected, rectum is also affected a lot of times. Then I need to remove both. Then in that condition, I'll go for LAR. And what is LAR? Low anterior resection. LAR is nothing but removal of sigmoid colon along with the rectum. That is what is called as LAR, low anterior resection usually. Okay, so that is what is done. Yes, very good all of you. It is serum carcinoembryonic antigen, which is the best tumor marker. It is carcinoembryonic antigen, which is the best tumor marker for colorectal cancer. Very good. Okay, no issues with this, anybody? That's important over here. Then if the cancer is in the rectum, which is the most common site, so what should be the treatment? Okay, so if the cancer is in the rectum, so what should be the treatment in this condition? So please remember, if the cancer is usually in the rectum, one of the treatment options is also radiotherapy. Yes, radiotherapy cannot be used for any other colorectal cancer except for rectal cancer. Okay, so radiotherapy is not useful for any other colonic cancer. It is only useful for rectal cancer. But definitely better than radiotherapy is always a surgical resection. And what is that resection that I'll do? Okay, what is that resection that I generally do in this patient is usually I go for a APR. And what is the APR? Abdominoperineal resection. One team operates from the perineum, one team operates from the abdomen. They separate the rectum and they remove the rectum. That is what is called as abdominoperineal resection usually. Okay, so we will go for a abdominoperineal resection, which has to be done in case of rectal cancer. No issues with this, anybody? So that is important. Okay, so please remember. Yes, all of you are right. This barium enema finding which is seen over here, very good. All of this, these are nothing but the thumbprint sign, and thumbprint sign is a characteristic feature of ischemic colitis. Very good. Thumbprint sign is a characteristic feature seen in case of ischemic colitis, also known as mesenteric ischemia. Okay, so ischemic colitis, nothing is a sequel or complication of mesenteric ischemia when there is some blockage in the blood vessels which are supplying the intestine. Therefore, there is decreased blood supply to the intestine, and that causes inflammation, ulceration, or perforation of the intestine, or even necrosis. Okay, so that is what is seen, thumbprint sign. Okay, no issues with this. Then moving further, guys, talking about anal cancer. Important about anal cancer is only one thing that you need to remember. Anal cancer, more commonly, colorectal cancer is always a adenocarcinoma. Most of the times it is a adenocarcinoma because the epithelium, as I have told you, it is the columnar epithelium. But anal canal, as I've told you, esophagus, oral cavity, and anal canal, these three are lined by squamous epithelium. Therefore, here the most common type of cancer is always squamous cell carcinoma. Adenocarcinoma can happen in anal canal, but it is rare. And if there is an adenocarcinoma in anal canal, that has to be treated like a rectal cancer. That has to be treated like a rectal cancer. Please remember that. If they ask you what is the treatment of choice for anal cancer, if they ask you what is the treatment of choice for anal cancer, then your answer should be a concurrent chemoradiation. That means we will give chemo as well as radiotherapy to the patient. And what is this regime called as? What is this regime called as? The chemoradiation regime in cases of anal cancer. I need the name of the regime because it was a previous year question. Please let me know in the chat box. Okay? Till that time, I'll further progress to talk about rectal prolapse in a patient. If I talk about rectal prolapse, you might have studied about uterine prolapse or genital organ prolapse in gynae. Okay, here, what does the prolapse means? So prolapse, for example, this is your anal canal and this is your rectum, right? What has happened now in this patient? The rectum is coming out of the anal canal. The rectum is coming out of the anal canal. This is what is called as a prolapse. Okay, something coming out of the anal canal is what is known as. So here, if the rectum comes out of the anal canal, that is known as the rectal prolapse. That you need to remember. Now, rectal prolapse can be either a partial thickness rectal prolapse or it can be a full thickness rectal prolapse. What do I mean by this? What is the basic difference between both of them? In partial thickness rectal prolapse, you can see over here, this is a partial thickness rectal prolapse. Okay, so it is a partial thickness rectal prolapse. You can see only the inner layers of rectum have come out. That is the mucosa and the submucosa. So if only the mucosa or submucosa of the rectum are coming out, only the mucosa or submucosa of the rectum are coming out, that is the partial thickness rectal prolapse. But if all layers of the rectum are coming out, that is a full thickness rectal prolapse. Next is the most common age group. Partial thickness rectal prolapse is more common in children. Partial thickness rectal prolapse is more common in children. But full thickness rectal prolapse is mainly common in adults or elderly patients. Okay. Full thickness rectal prolapse is more common in adults or elderly patients. Okay. So now in elderly, why there is a high chance of rectal prolapse? Because in elderly patient, definitely the perineum which is there, the perineal muscles, they become weak or they become lax. Okay, so जो बुढ़े लोग होते हैं उनमें क्या होता है, जो muscles होती है उनकी टोन कम हो जाती है और जो muscles है वो weak हो जाती है. ठीक है, due to that there is a high risk of prolapse in a case of elderly patient. ठीक है, full thickness rectal, and it is definitely more common in females because rectal prolapse का one of the important risk factor is a obstructed or an abnormal labor. Okay, so if there was an obstructed or an abnormal labor in the female, that patient in the future can have a rectal prolapse as well. That is a very important risk factor. Therefore, females are commonly affected in the elderly age group. No issues with this. The patient will have a constant dragging sensation. Okay, or there will be a constant discomfort. A mass will be coming out from his anal canal. Okay, that is the usual complaint of the patient. If I talk about the treatment in this patient, what should be done? If it is a child who is coming to me with a partial thickness rectal prolapse and it is his first episode, okay, the child is having first episode of rectal prolapse, then I will just put the rectum into the anal canal with the help of my fingers. Okay, I'll just put back the rectum which is coming out. That is called as digital repositioning. That is what is known as digital repositioning. Okay, so digital repositioning is done in a partial thickness rectal prolapse in the first time or the first episode. But if the patient is coming to me with second episode or recurrent episodes of rectal prolapse, then usually I will go for a Hirschsprung. Okay, I take purse string sutures all around the anal canal and I tighten up those sutures only. That is what is called as a Hirschsprung. So that if the anal canal, I have taken up sutures all around the anal canal and I have tightened up those sutures, what has happened? The anal canal is also narrowed down. As the anal canal is narrowed down, definitely, what will happen? Will the rectum be able to come out now? No, the rectum is not able to come out. That is what is a Hirschsprung. Then in cases of full thickness rectal prolapse, definitely then I can go for either perineal surgeries. Okay, I can go for either a perineal surgery, which are preferred in elderly patient. Okay, because they have less complications. And second is abdominal surgery, which are preferred in young fit patients. Perineal surgeries are usually which are procedures like Hirschsprung. Okay, so Hirsch is an example of a perineal procedure. Second is definitely a Delorme's repair or a Altemeus repair. So either it can be a Delorme's or a Altemeus repair. These are the perineal procedures done in cases of rectal prolapse. full thickness rectal prolapse. But the abdominal procedures, okay, the abdominal procedures which are there, definitely it is known as the Wells and Ripstein's rectopexy. Okay, it is known as pexy ka matlab hota hai fixation. What we are fixing? The rectum. It is known as rectopexy. Okay, and it is an abdominal procedure known as Wells and Ripstein's rectopexy. The another one, I'll just tell the name. It is known as Frickman and Goldberg's resection rectopexy. Okay, so these are the two rectopexies which can be done from the abdomen of the patient. Now talking about another condition. Before that, nobody answered it. Okay, so please remember the regime which is used for chemoradiation of anal cancer is known as the Negro's regime. Okay, it is known as the Negro's regime. Okay, so that's important. You need to remember this. It is known as the Negro's regime. Next, moving further, talking about this condition. Okay, what is this? You can see this is the buttocks. Okay, this is the buttock, and in the midline of the buttock, what is the midline of a buttock called as? You can see the midline of a buttock is called as a natal cleft. Okay, in the natal cleft, this is the anal canal. Okay, so in the natal cleft, definitely you are able to see multiple openings. And what are these multiple openings which are seen in the natal cleft? The multiple openings which are seen in the natal cleft, these are what are called as sinuses. And what did I tell you about sinus? They are nothing but one-way communication with skin. So if there is a one-way connection with skin, that is what is called as sinus. It is nothing but a blind tract. And what can happen over here? There can be infection. And what can come out from these sinuses? Definitely pus can come out from the sinuses. Yes, very good. This is a case of pilonidal sinus. Okay, so this is a classical case of pilonidal sinus, which is also known as jeep driver's bottom's disease. Okay, it is also known as jeep driver's bottom disease. So a person who sits a lot for a longer duration of time, like a jeep driver or a truck driver, okay, and they are having a hairy gluteal skin, and there is not proper hygiene which is maintained. Okay, so due to that reason, what can happen? There will be infection of the anal glands, and that infection can further progress and complicate into a pilonidal sinus, also known as jeep driver's bottom's disease. Please remember. So here they will mention there is a hairy gluteal skin, okay, on which you are able to see some openings. And what is the most common site for this pilonidal sinuses? As I've told you, it is the natal cleft, definitely. Okay, that is the midline in between the two buttocks. Now, important is definitely what is the complaint of the patient. The patient will complain ki Doctor Saab, I am having a lot of pain. Definitely, along with pain, the patient will have pus sometimes coming out from the sinuses as well. There will be multiple sinuses from which pus is coming out. That is the usual complaint. Okay, what is the treatment in this condition? What is the treatment in this condition? So the treatment is known as a surgery, which is known as the Bascom's procedure. The treatment is known as a surgery known as the Bascom's procedure. Please remember. Okay, we can also use a rhomboid or a limber flap procedure, or we can also use a Cariacis surgery. But the best one or a common one that is done is known as a Bascom's procedure. That was a previous year question again. Next, if I talk about the rosy roti of a general surgeon, okay, and that is what is the hemorrhoids, the bread and butter. That is what is the case of hemorrhoids. Hemorrhoids are also known as piles. In Hindi, they are also called as bawasir. Okay. So if I talk about hemorrhoids, you should be aware of it because you will be giving advices to a lot of your relatives regarding this. What is the risk factor for hemorrhoids? If a patient is having chronic constipation, that is a very important risk factor for hemorrhoids, definitely. Okay, chronic constipation is an important risk factor. Usually, what are hemorrhoids? Hemorrhoids are nothing but dilated vessels. Yes. Okay, they say it is a mass, but that mass is nothing but the dilated vessels. Okay, so these are nothing but anal cushions, or these are dilated vessels in the rectum or the anal canal of the patient. Okay, and these dilated vessels in the anal canal or the rectum, they will come out. Okay, and that will be felt as a mass. That is what is a hemorrhoid. Now if I talk about hemorrhoids, guys, please remember hemorrhoids can be either primary hemorrhoids or secondary hemorrhoids. What is the basic difference? That has been asked. So if I consider anal canal as the clock, definitely if the hemorrhoids are coming out at 3 o'clock, 7 o'clock or 11 o'clock position, 3 o'clock, 7 o'clock or 11 o'clock position, these are considered to be the primary hemorrhoids. And if the hemorrhoids are anywhere else apart from these three positions, if the hemorrhoids are anywhere else apart from these three positions, it is called as a secondary hemorrhoid. तो 3, 7, 11 पे अगर है तो प्राइमरी हेमोरॉइड्स हुए, इसके अलावा कहीं भी और है, दैट इज अ सेकेंडरी हेमोरॉइड. ठीक है. Now, in a case of hemorrhoids, definitely, what is the most common complaint of the patient? The most common clinical feature of a patient, as we discussed, that hemorrhoids is the most common cause of lower GI bleed overall also and in adults also. So it causes hematochezia. What is hematochezia? Fresh blood in stools. Okay. So the most common clinical presentation or complaint of the patient is bleeding per rectum. And once there is a bleeding per rectum, you can see whenever the patient goes for defecation, जब भी stool pass करने जाता है patient, then during defecation or during passing stools, there's a lot of bleeding which occurs. And usually it is a painless bleeding or a painful bleeding. So please remember, most of the hemorrhoids are painless. Most of the hemorrhoids are painless. Painful bleeding is usually seen only in two conditions. Painful bleeding is only seen in two conditions. One, if it is an external hemorrhoid, and second, if it is a thrombosed hemorrhoid. So in cases of external piles and thrombosed piles, these are the only two conditions where the hemorrhoids will be painful. So what do I mean by this? So please remember, a lot of people will be aware, this is the rectum, okay, or the anal canal. Okay, so this is the rectum and the anal canal. You can see this is the dentate line. Okay, this is what is the dentate line. If the hemorrhoids are below the dentate line, these are called as external hemorrhoids. If the hemorrhoids are below the dentate line, these are external hemorrhoids. Whereas if the hemorrhoids are above the dentate line, these are called as internal hemorrhoids. Important is, above the dentate line, the nerve supply is given by the hypogastric plexus. And the hypogastric plexus does not carry any pain fibers. Therefore, please, important thing you need to remember is, internal hemorrhoids are painless. Internal hemorrhoids are painless because they have no pain fibers in that region. Whereas external hemorrhoids, they arise below the dentate line. And please remember, in this area, the nerve supply is given by the pudendal nerve. And definitely it has pain fibers. Therefore, the external hemorrhoids will be painful. That's the basic. Internal are always painless. External are always painful. Now, if I talk about the grading of hemorrhoids or the degree of hemorrhoid. So, the grade 1 or first degree hemorrhoids which are there, the mass will not come out anytime. Okay, there will be no prolapse. Okay, there will be no prolapse of a mass. There are only internal hemorrhoids. So grade 1 are nothing but internal hemorrhoids which never come out of the anal canal. First one. Grade 2 or second degree hemorrhoids is what? The mass comes out when the patient goes for defecation. So when the patient goes for passing the stools and the patient applies pressure, because the patient is suffering from constipation now, therefore the patient tries to apply pressure. As the patient applies the pressure, due to the pressure, the mass will come out. But it will again go inside as soon as the patient releases the pressure. Okay, so there is a prolapse which is seen, but a spontaneous reduction is also there. Okay, prolapse is seen on straining or bearing, but spontaneous reduction is also there. अपने आप वापस चला जाता है. That is the second degree or grade 2 hemorrhoids. Third degree or grade 3 hemorrhoids are what? Here on bearing down or straining, definitely there is a prolapse of a mass. मतलब the hemorrhoids will come out जैसे ही patient pressure apply करेगा, force लगाएगा. But ये अब अपने आप वापस नहीं जाएगा. इसको रखना पड़ेगा अंदर with the help of your fingers. So what did I tell? The grade 3 or the third degree hemorrhoids, here the mass will come out when the patient applies pressure. But here now the mass will not go inside on its own. You need to put the mass back inside into the anal canal. That is grade 3. And 4th degree hemorrhoids are always prolapsed outside. चौथी डिग्री जो होता है वो हमेशा बाहर ही रहता है hemorrhoids. Okay, 4th degree are always prolapsed outside. Now, what is the investigation of choice of hemorrhoids? We know the investigation of choice of hemorrhoids is a proctoscopy. Okay, we know it is a proctoscopy. I've discussed that. Okay, please remember it is proctoscopy definitely. First degree hemorrhoids, what should be done in first degree hemorrhoids? Nothing else but lifestyle modifications. And what is the lifestyle modifications to be done in a case of first degree hemorrhoids? As the patient is having chronic constipation, due to that the patient is having hemorrhoids. So ask the patient to definitely avoid any fried fatty food. Ask the patient to avoid fried fatty food because that causes constipation. Next, ask the patient to take a high fiber diet like green leafy vegetables. Ask the patient to take a lot of fluids. Okay, so because high fluid intake will cause smooth passage of stools. Okay, apart from that, also ask the patient to take a sitz bath. What is a sitz bath? Ask the patient to take warm water in a tub, and then the patient will sit in that tub which contains the warm water. That will relax the anal sphincter, and if the anal sphincter is relaxed, definitely the patient will not experience a lot of pain because the mass will go inside. Okay, so definitely sitz bath is to be recommended. And if the patient is having constipation even after lifestyle modifications, you can also give the laxatives like syrup, loose, cremafin, all of these can be given. Second degree hemorrhoids, definitely for second degree hemorrhoids. Now along with lifestyle modifications, you need to go for a better treatment. And I've told you in esophageal varices also, what was the treatment? That was banding. For second degree, definitely you will go for banding. If banding is not an option, then go for sclerotherapy. But I've told you what is always better. Better is always banding. So if they ask you treatment of choice for second degree hemorrhoids, answer should be banding. Not an option, go for sclerotherapy. And the most common sclerosing agent used, I told you yesterday also, it is 3% sodium tetradecyl sulfate. It is 3% sodium tetradecyl sulfate. Next, for third and fourth degree hemorrhoids. So here in third degree you can try banding, but most of the cases fail. So therefore in third and fourth degree hemorrhoids, I need to go for a surgery. And I've told you what is the surgery of choice. What is the surgery of choice, guys? Please let me know now. Okay, yes, rubber band ligation is what is banding. Please, what is the surgery of choice in third and fourth degree hemorrhoids? Please let me know. I've told that to you earlier. Hemorrhoidectomy, definitely hemorrhoidectomy was done earlier, but nowadays it is not considered the surgery of choice. Okay. So hemorrhoidectomy can be an open hemorrhoidectomy known as Milligan-Morgan hemorrhoidectomy, or a closed hemorrhoidectomy known as Ferguson hemorrhoidectomy. But nowadays we prefer a better surgery. I told you we use a circular stapler, right? And with the help of the circular stapler, we are fixing the hemorrhoids. And what was that called as? That procedure, that surgery was called as stapler hemorrhoidopexy, right? That surgery was known as stapler hemorrhoidopexy. That was the better surgery. Surgery of choice nowadays is stapler hemorrhoidopexy. No issues with this? Very good, very good. Okay, so please remember that's important. Okay, the complication of this surgeries can be urinary incontinence. The most common cause, sorry, urinary retention. The most common complication of this hemorrhoidectomy surgery is usually urinary retention. Okay, so hemorrhoidectomy can also be done. Moving further, talking about this condition. What is this usually? You can see the patient is having anal fissure over here. Okay, so there is nothing but a fissure or a cut. Okay, cut or a crack in the anal canal is what is a fissure. Just understand in simple terms. Cut or crack, okay, in the anal canal is what is a fissure. Okay, if I talk about this anal fissure, please remember it is an extremely painful condition. It is an extremely painful condition. And here also the patient can have bleeding per rectum. But in hemorrhoids, just say there was a lot of bleeding. In this condition, there will only be minimal bleeding. There will only be minimal bleeding. And in hemorrhoids, most of the cases were painless. Here, all the cases are painful. Here, all the cases are painful. Okay, so that is important. What is the most important risk factor? Usually, the most important risk factor is hard stools. So, the patient is having chronic constipation and the patient is not drinking a lot of water. Due to that, the patient is having hard stools. And these hard stone-like stools, when they are passing from the anal canal, they are injuring the anal canal. जब ये hard पत्थर जैसे stools anal canal से बाहर निकलेंगे, they will cause damage to the anal canal. That is what is called as an anal fissure. No issues with this. That's the important thing. Now, important is what should be done for investigation. Okay, so investigation or to make a diagnosis, what should be done? Please remember, we will not do any kind of digital rectal examination or we will not do a proctoscopy. Because this is an extremely painful condition. याद रखना अगर करने की जरूरत कर ली तुमने पेशेंट की लात खाओगे. If you try to do it, please remember you will get kicked by the patient. That's important. Okay, don't try. Okay, so the investigation of choice is nothing but an external inspection only. Yes, just separate the buttocks of the patient and examine the anal canal from outside. That is the external inspection. You will be able to see a fissure in the anal canal. Okay, so external inspection has to be done. If it is a chronic fissure, that means the patient is presenting to you late, then you will be able to see a skin tag as well. In the fissure, you will be able to see a skin tag if it is a case of chronic fissure. What should be done for treatment? So in treatment, first of all, we will ask the patient to avoid constipation. That is again the lifestyle modification which we recommended in hemorrhoids also. That is, take high fiber diet, high fluid or increased amount of fluid should be taken. Definitely avoid fried fatty foods to avoid constipation. Apart from that, take a sitz bath so that it will relax the anal sphincter and the pain of the patient is relieved. So all of these lifestyle modifications will be done. Definitely. Apart from that, you can also use painkillers locally. And these painkillers or analgesics which are used locally can be usually a 2% xylocaine jelly or a lignocaine jelly. Yeah, 2% xylocaine or a lignocaine jelly can be applied locally so that the pain of the patient is relieved. Okay? If the patient does not improve on this even, then we will go for a surgery and that is called as a lateral anal sphincterotomy. Yes, we are giving cut or incision on the sphincter so that the pressure from the sphincter is released and so that the patient is not able to experience a lot of pain. Okay, yes, diltiazem nitrate gel can also be used. Diltiazem nitrate is usually avoided due to the risk of headache. Diltiazem can also be used because it relaxes the anal sphincter as well. Okay, so lateral sphincter the lateral anal sphincterotomy should be done in the patient. Lateral anal sphincterotomy should be done. But as you are cutting a sphincter, what can be a risk factor or a complication of this condition or this surgery? So please remember, as you are cutting the sphincter, अगर तुमने sphincter को ज़्यादा cut कर दिया, if you cut the sphincter too much, what will happen? Now the sphincters will relax. Okay, they will not be able to constrict. And if the sphincters are not able to constrict, what will happen? The feces will flow out. Therefore, there will be a fecal incontinence. Okay, there is a fecal incontinence. So a risk factor which is associated or a complication which is associated with lateral anal sphincterotomy is fecal incontinence. Okay, there will not be any control left over the feces of the patient. Okay, next condition that I'm discussing, appendix, we'll talk about after the break. Okay, so we will complete all the intestine and then we will take a break definitely. Okay, so if I talk about this, guys, so what is seen over here? This is a case of fistula. Okay, so this is a case of anal fistula, also called as fistula in ano. This is what is a case of anal fistula or fistula in ano. Please remember, what is a fistula? I've told you, a two-way communication. One side it is connected with the skin, another side it is connected with the anal canal. Another side it is connected with the anal canal. Okay, so this is what is a case of perianal fistulae. Okay, this is what is a case of perianal fistulae, anal fistulae, or you can call it fistula in ano also. Okay, no issues with this, anybody? That's important. If I talk about the types of perianal fistula, according to the Parkes classification, you just need to remember the most common type of fistula. The most common type of fistula is the intersphincteric fistula. The most common type of perianal fistula is the intersphincteric fistula. So just once see over here. Okay, once see over here. What is this? Yeah. So the first one that you can see. Okay, follow this. So this is what is called as the extrasphincteric fistula because it is not in relation with the sphincter. So you'll say sphincters ka hai, sir. The purple one that you can see is the internal anal sphincter and the yellow one that you can see is the external anal sphincter. Okay. So the first one that you can see, the first fistula, is not connected to any of the sphincters. So it is an extrasphincteric fistula. Next, the second one, which is the most common type, this one is the intersphincteric fistula. As you can see, the fistula is opening between the two sphincter. It is the intersphincteric or the most common type of fistula. The third one that you can see, it is crossing both the sphincters and then it is opening on the skin. It is called as the transsphincteric fistula. Then the fourth fistula that you can see, it is going above the sphincter and then it is opening out. This is what is called as a suprasphincteric fistula. The one which goes above the sphincter and then comes down again is called as a suprasphincteric. And the one which has no relation with the sphincters, okay, one which has no relations with the sphincters and it is above the anorectal ring, okay, and it is above the, so this is the anorectal ring over here. This is the anorectal ring. So fistula which is lying above the anorectal ring, this is what is called as the extrasphincteric fistula, or important, please remember, it is also known as a high fistula. All of the others, all of these were low fistulas. Okay, all of these are low fistulas. Please remember, the treatment is decided whether by whether it is a low fistula or a high anal fistula. That's the important condition in deciding the treatment. Now, perianal fistula hote kyun hai? Because the patient was having some infection of the anal glands. Okay, the patient was having some infection of the anal glands, due to which either we performed the incision and drainage or there was rupture of the abscess. Either we performed a incision and drainage or there was a rupture of an abscess, and due to this a fistula was formed, a perianal fistula was formed. Okay, so that is the usual cause for it. What is the complaint of the patient? The patient will have a lot of fistulae. Okay, the patient will have a lot of opening around the anal canal and all of them will be draining pus. There will be pus discharge from all the fistulae. The common complaint is, Dr. Saab, undergarment is stained with pus. Okay, so the fistulae, multiple perianal fistulae, draining a lot of pus and pain will be there definitely. Okay, what is the investigation of choice? So please answer the investigation of choice over here. This is important. Answer the investigation of choice in this condition. If I talk about the treatment of this patient, as I've told you, if the fistula is lying above the anorectal ring, then my treatment is definitely insert a Seton thread. What is the feature of a Seton thread? It will cause fibrosis of the fistula. Okay, it will cause fibrosis of the tract and therefore the tract will close on its own. क्या करता है ये Seton thread? ये क्या कर देता है? Fibrosis कर देता है पूरे fistulous tract का, and इसीलिए वो जो tract है वो बंद हो जाता है अपने आप. ठीक है? Or this Seton thread we can keep tightening up, and that will cause definitely rupture of that will cause opening up of the fistulous tract. So just remember, above anorectal ring, that is a high fistula, treatment is always a set-on thread. But if the fistula is lying below the anorectal ring, if the fistula is lying below the anorectal ring, it is called as a low fistula. And what should be the treatment of a low fistula? Please remember, the better treatment of low fistula is, if for example, this is a fistula tract. Okay, this is a fistula tract. If I am opening the fistula tract, this is what is called as a fistulotomy. And if I am removing this, this is called as fistulectomy. What is better? Opening of the fistula tract is better. That is what is called as fistulotomy. So fistulotomy is preferred in a low perianal fistula over a fistulectomy. Yes, fistulotomy is preferred over a fistulectomy in a case of low perianal fistula. Okay, in a cases of low perianal fistula. Very good. Yes, Dheeraj, very good. The investigation of choice. Yes, Mohit. It is MR fistulogram. Okay. The investigation of choice is what is called as the MR fistulogram. So you are using MRI for taking a picture of this fistula. That is the MR fistulogram. That is the investigation of choice. Last one that we are to discuss over here. What is this investigation? This investigation is an invertogram. Okay. And invertogram is performed usually in the first 24 hours of life. Okay. Invertogram is performed in the first 24 hours of life. And why it is performed? To check for any anorectal malformation. If a child is having any anal or rectal malformation, that means if the anal canal is not formed, or if the anal canal is closed, or if the rectum is not formed, any of such conditions, definitely that is called as anorectal malformation. So if a patient is having anorectal malformation, we discussed, it is associated commonly with the vectoral group of anomalies. Okay? And in anorectal malformation, definitely we are performing invertogram. Investigation of choice is always a MRI. Please remember, investigation of choice will be MRI, but over here invertogram can be done as well. Okay? And in invertogram, what is done? You can see a metallic marker is placed over here. This is a metallic marker. For example, one of the conditions of anorectal malformation can be imperforate anus. What do I mean by imperforate anus? You might have studied about imperforate hymen and gynae. The imperforate anus is, that means the anal canal is not open in this child. एक बच्चा पैदा हुआ और उस नवजात शिशु में क्या नहीं बना हुआ? Anal canal या anal opening नहीं बना हुआ. That is what is the imperforate anus. So if a child is having imperforate anus, what we should do? The site at which the anal opening should have been there, we will keep a metallic marker at that site, and then we will invert the child and take a X-ray. And we try to measure the distance between the metallic marker and the tip of gas shadow. If I measure this distance between the metallic marker and tip of gas shadow, if this distance is more than 2 centimeters, it is considered as a high anorectal malformation. But if the distance is less than 2 centimeters, then it is considered as a low anorectal malformation. Okay? Important is, in both these conditions, I will perform a surgery, and that is called as PSARP. What is PSARP? PSARP is nothing but posterior sagittal anorectoplasty. Posterior sagittal anorectoplasty. That has to be done. That is the definitive surgery or treatment of choice in cases of low or high anorectal fistula. Important, low or high anorectal malformation. In high anorectal malformation, as the gap is too much, we will wait for the child to grow, and then we will perform the anastomosis or the repair. So till that time, from where the child is going to pass feces, till that time the child is going to pass the feces from a colostomy. What is a colostomy? I have told you already. We will open up the colon on the abdominal canal, abdominal cavity. We will open up the colon on the abdominal wall, and we will attach a stoma back to it. So the feces will come out from this colon and it will collect in the stoma bag. Okay, so till the time we perform a surgery, this colostomy has to be performed in a case of high anorectal malformation. It is not required in a case of low anorectal malformation. That has to be remembered. Okay, chalo, take a break, then we'll meet after 15 minutes. Welcome back, guys. Hopefully, I'm audible now. Let me know. Please let me know if we can. Shall we start talking about appendix and then further the hepatobiliary? Okay, great. Now, starting with your appendix. Okay, appendix is also known as your vermiform appendix, and I hope all of you are quite aware. Where is this appendix present? So, where the small intestine ends, that is your ileum, and where the large intestine begins, that is your cecum. Okay, so at the junction of this ileum and cecum, okay, so at the ileocecal junction, definitely we have this tubular structure, and this tubular structure is nothing but your vermiform appendix. Please remember, okay, it is a vestigial organ as such. In case, usually, if the neck of the appendix or the mouth of the appendix gets blocked, what will happen? Definitely all the mucus which is there, that mucus will keep on collecting in the appendix, and there will be a lot of mucus in the appendix. That mucus can get inflamed. Okay, there can be inflammation of the appendix, and that is what is known as appendicitis. Okay, so that's the important thing. Now if I talk about appendix, guys, please remember the base of the appendix which is there, this base of appendix is fixed, but this apex of the appendix which is there now, the apex of the appendix, it keeps on moving. Okay, it is at different sites and different patients. Okay, so the apex of the appendix which is there, it will be at different sites and different patients. If they ask you which is the most common position of appendix, if they ask you which is the most common position of appendix, answer is behind the cecum. And what is behind the cecum called as? It is known as retrocecal. So the most common position of appendix is retrocecal followed by pelvic. Okay, that has been questions. Most common position of appendix is retrocecal followed by pelvic. If they ask you which is the least common position, then the least common position of appendix is usually post-ileal. The least common position of appendix is usually post-ileal. That means behind the ileum. Okay, so that's the important thing you need to remember about the position of the apex of appendix. Okay, so that is important. Then if I talk about the inflammation of appendix, and we know when the appendix undergoes inflammation, the patient comes to us in emergency usually, and the patient will have low grade fever, the patient can have abdominal pain, the patient will definitely have anorexia or loss of appetite. Okay, so all of these features, and all of them are suggestive of what? All of them are suggestive of appendicitis. So when a patient is coming to us in emergency and there are severe signs and symptoms, that is definitely suggestive of acute appendicitis. Please remember, chronic inflammation mein the signs and symptoms will be mild to moderate. They will not be severe, and the patient usually does not present in emergency. The patient comes to us in OPD in a case of chronic condition. But here, as it is acute appendicitis, the patient presents to us in emergency with severe signs and symptoms. Okay, acute appendicitis can be catarrhal. Catarrhal का मतलब होता है superficial. Okay, so catarrhal means superficial appendicitis, which is definitely the more common one. And second can be obstructive appendicitis, that the one that I've explained to you. Obstructive, when the mouth of the appendix gets blocked or it gets obstructed, that causes inflammation, that is called as the obstructive appendicitis. Important is, appendix is more common in which age group? So please remember, appendix is more common in teenagers. What is teenagers? Definitely the adolescent age group, followed by children. Yes, please remember, appendicitis is more common in teenagers or adolescents, followed by the children. That you need to remember properly. Okay, important is, now when the patient is coming to me, what will be his clinical signs and symptoms? Okay, so if the patient is coming to me, the signs and symptoms are remembered usually with a scoring system. Okay, with the help of the scoring system, you will be able to know is the patient having any chances of appendicitis or not. Okay, so you will try to assess or examine the patient based on the scoring system. What is the scoring system called as? It is known as the Mantral scoring system. Also, the another name for the scoring system is modified Alvarado scoring system. Okay, so this is also known as the modified Alvarado score or the Mantral score. So Mantrals is nothing but the abbreviation of all these parameters. Okay, so Mantrals is nothing but short form of all these parameters which are there. So first of all, M stands for what? You can see M stands for migratory right iliac fossa pain, because where is the appendix located? We know appendix is located in the right iliac fossa. Okay, so definitely M stands for migratory right iliac fossa pain. And where is this pain migrating from the right iliac fossa? This pain migrates to the umbilicus from the right iliac fossa. And the question was, why does the pain of appendicitis migrates from right iliac fossa to the umbilicus? The cause is because both of these sites are innervated, or these are supplied by the same nerve, and that nerve root is nothing but T10 nerve root. Okay, the nerve root which supplies both these sites is usually the T10 nerve root. That has been a previous year question. Okay, due to the T10 nerve root, the pain of appendicitis will migrate from right iliac fossa to the umbilicus as well. So migratory right iliac fossa pain is given a score of 1. Then next is anorexia. Important is, please remember, anorexia is the most constant symptom. That means in majority of the patient, we will find anorexia or loss of appetite as a symptom. Okay, that is again given a score of 1. Then N stands for what? N stands for nausea and vomiting. Nausea and vomiting is again given a score of 1. Then T stands for what? Tenderness. What is tenderness? When we try to palpate and the patient has pain. Okay, so pain on touching is what is called as tenderness. Okay, so tenderness in the right iliac fossa or the right lower quadrant, whatever you call it. Okay, so right iliac fossa, if the patient is having pain, that is given a score of 2. Okay, that's important. Next, if I talk about R, R stands for rebound pain or rebound tenderness. If the patient is having rebound tenderness, what do I mean by this? When you are palpating, then the patient does not have pain. But when you release, the patient starts having pain. Why? When you palpate, definitely the patient is not having pain. But when you release, the peritoneum sets in vibration. And this vibrating peritoneum comes in contact with the inflamed appendix below. ठीक है, तो जब तुमने छोड़ा पैल्पेट करके, पेरिटोनियम वाइब्रेट हुआ, और ये पेरिटोनियम जो वाइब्रेट हुआ ना, इट केम इन कांटेक्ट विद inflamed appendix, and that is causing pain. That is known as rebound tenderness, given a score of 1. Next is elevated temperature. E stands for elevated temperature, nothing else but fever. Again, a score of 1 has to be given. L stands for leukocytosis. Important, leukocytosis, that is increased WBC count or increased total leukocyte count, is given a score of 2. Next is last one. S goes for what? Shift to the left. Okay, so the WBCs are shifted to the left. What do I mean by this? Shift to the left, that means neutrophils are more. If I do a differential leukocyte count, DLC अगर मैं करता हूँ, definitely on that I'll see appendicitis. As I've told you, it is an acute infection, that too an acute bacterial infection most of the times. That is the reason why you will be able to see a lot of neutrophils. So neutrophilia is generally seen in the patient. Okay, that is given a score of 1. So the total Mantras or Alvarado score is 10 definitely. Okay, and out of this they have asked that which two parameters have a score of 2. So we know the LT parameters are given a score of 2. L stands for leukocytosis, that is increased WBC count, and T stands for tenderness, where exactly in the right iliac fossa, or to be very specific, at the McBurney's point. What is McBurney's point? I'll discuss that. Okay, so please remember, if the score is less than 5, then appendicitis is unlikely. मतलब इस patient में appendicitis नहीं हो सकता. But if the score is between 5 to 7, if the score is between 5 to 7, there are equivocal chances. That the patient might have appendicitis. But if the score is more than 7, that is suggestive of appendicitis. That is definitely suggestive of appendicitis. Okay, that is important. So this Alvarado score or the Mantral score will help you assess whether the patient is suffering from appendicitis or not. Once we have done the scoring system, please remember the investigation of choice. If I talk about the investigation of choice in adults, the investigation of choice in adults is a CECT abdomen. Whereas the investigation of choice in children is usually an ultrasound abdomen. Okay, as I've told you, okay, in adults the investigation of choice is a CECT, contrast enhanced CT scan of abdomen, but that in a child will be an ultrasound abdomen. That you need to remember for sure. Okay, that will tell you whether the appendix is inflamed or not. Okay, so once you get to know, okay, the appendix is inflamed, then definitely what should be the treatment? We know for acute appendicitis, the treatment is always a surgery. And what is that surgery? Surgery is definitely appendicectomy. Okay, surgery is definitely appendicectomy. Important is, appendicectomy can be either an open appendicectomy or it can be a laparoscopic appendicectomy. It can be either open or a laparoscopic appendicectomy. Important is, for the open appendicectomy, the incisions that are used are what? And that has been asked a lot of number of times. So if I talk about the incisions which are used for open appendicectomy, so please remember, for open appendicectomy, the incisions which are used over here. For example, this is the umbilicus. Okay, so important is, this is the anterior superior iliac spine and this is the umbilicus. So a line which joins the anterior superior iliac spine and the umbilicus is called as the spino-umbilical line. And on the spino-umbilical line, 2/3 from the umbilicus, 2/3 from the umbilicus and 1/3 from the anterior superior iliac spine, we have a point. And what is this point called as? This point is what is called as the McBurney's point. This point is what is known as the McBurney's point. And this is the usual location of your appendix. This McBurney's point is the usual location of the appendix. So that can help you see a lot of signs as well in appendicitis. So when you press this McBurney's point, and a patient has pain, that is what is called as the McBurney's sign. When you palpate the right iliac fossa or the McBurney's point, and when the patient has pain, that is called as the McBurney's sign. Next is, now you are palpating the left iliac fossa. Okay, now you are palpating the left iliac fossa, but as you perform a deep palpation, the organs are shifted towards the right side, and therefore the patient has pain in the right iliac fossa. This is what is called as the Rovsing sign. So Rovsing says palpation of left iliac fossa causes pain in right iliac fossa. That is the Rovsing sign. Next important is over here. When you were palpating, the patient did not have pain, but when you released, then the peritoneum started vibrating and the patient had pain. What is this type of sign called as? This is what is called as a rebound tenderness. And rebound tenderness in a case of appendicitis is known as the Blumberg sign. Rebound tenderness in a case of appendicitis is what is called as the Blumberg sign. That is important. Okay, it is known as the Blumberg sign. So these are the various signs. Along with that, here, if we perform flexion at the hip as well as the knee joint, and then we perform an internal rotation, what will happen? The patient starts having pain. And this is what is classically known as the obturator sign. It can also be positive if the appendix is pelvic in position. It will be positive if the appendix is pelvic in position. Next, if I perform a hyperextension of the hip joint, there will be pain in the patient. This is what is called as the psoas joint. And when psoas joint is usually the psoas sign is usually positive. So psoas sign is usually positive when the appendix is retrocecal in position. That means behind the cecum in position. Okay? Now coming back to our incisions that I've talked about. So usually if you give an incision at the McBurney's point, okay, an oblique incision is given at the McBurney's point. This oblique incision which is given at the McBurney's point is known as the McBurney's incision. Okay, this oblique incision given at the McBurney's point is known as the McBurney's incision itself. Okay, this McBurney's incision which is there now, please remember this McBurney's incision can be of two types. Either it can be a muscle splitting incision or it can give a muscle cutting incision. If you only split the muscles, if you only retract or split the muscles, separate karte ho, that is what is called as a gridiron incision. The muscle splitting McBurney's incision is known as a gridiron incision. Okay, gridiron incision usually. Whereas if I cut the muscle, okay, if I cut the muscle, then it is what is called as the Rutherford-Morrison incision. Then that is what is known as the Rutherford-Morrison incision. That's important. Next one that you need to remember over here, we have a transverse incision over here. Okay, transverse incision in the right iliac fossa. And somebody said it very good. The transverse incision which is given, or the horizontal incision which is given in the right iliac fossa, it is a bikini incision. That means the scar will be hidden with the help of a bikini. So this horizontal or transverse incision given in the right iliac fossa is known as the Lanz incision. It is known as the Lanz incision. So these are the usual incisions that can be used. Coaches can also be used, but these are the common two incisions which can be used for a appendicectomy procedure. Okay, that's important. Now the question is, please remember my question is, a pregnant female is presenting to you with acute appendicitis. What is the management? And this was the previous year question of FMG examination. Please let me know, if a patient is presenting to you with acute appendicitis and she is pregnant, what should be the management in this condition? Will you go for conservative management, or you will go for elective appendicectomy, or you will go for an emergency appendicectomy? For the options, please let me know. Let me know. So please remember, in pregnancy, I hope all of you are quite aware. Please remember, in pregnancy, appendicitis will have a higher risk of rupture. Why it will have a high risk of rupture? Because we know that pregnancy is an immunocompromised condition. Okay? So there will be a higher risk of rupture in a case of pregnancy for inflamed appendix. And if there is risk of rupture, what will happen if the appendix ruptures? Definitely the infection or the inflammation will spread throughout the peritoneum. Patient will also develop peritonitis, but more important is the patient will also have an abortion. Okay, the patient will lose the fetus as well. That's the important thing. Please remember, the patient will lose the fetus. That is the reason why usually in a case of acute appendicitis during pregnancy, the management is generally an emergency appendicectomy. The management is generally an emergency appendicectomy that has to be performed. Okay, so emergency appendicectomy has to be performed. Please remember that. Okay, that is important. No issues with this, anybody? That's important. You need to remember this. Okay, now what can happen? The patient was having acute appendicitis, but definitely the appendix was inflamed. Okay, the appendix was inflamed, but the patient was not treated properly. So what happened? What is the molecular? What is the policeman of your abdomen who fights with the infections locally within the abdomen? It is your omentum, right? Omentum is nothing but the lymphoid tissue, and I've told you local immunity is provided by the lymphoid tissue. So the omentum comes and omentum wraps around the inflamed appendix. Okay, this omentum will wrap around the inflamed appendix, and as it wraps around the inflamed appendix, it forms a appendicular lump. Okay, it forms a appendicular lump. Now when you palpate the right iliac fossa of the patient, you will be able to feel a lump or the mass in the right iliac fossa of this patient. Okay, and the signs and symptoms will be less severe now because this inflamed appendix has been covered or wrapped around by the omentum now. Okay, so if a patient is having appendicular lump, then what should be done? So in a case of appendicular lump, we'll go for a conservative management. And what is that conservative management known as? Which regime, anybody? Please let me know the name of the regime. So I'll just explain to you the regime. Please remember, the conservative management mein, what we will do is, as I've told you, the same things will be there. Keep the patient NPO, give the patient IV fluids, give the patient IV antibiotics, and as the patient is having pain, give the patient analgesics. These are the things which are done in a conservative management. Then definitely alongside, keep monitoring the patient also. Keep monitoring the patient. What do we need to monitor? We need to monitor the vitals of the patient, the blood pressure, the pulse rate of the patient, along with that the temperature of the patient, the size of the lump or the size of the mass, the tenderness and the fever of the patient. If the patient's condition worsens, okay, if the patient's condition worsens, that means now an abscess has been formed. Now an abscess has been formed, definitely take the patient for a drainage. Definitely take the patient for a drainage or a surgery. Okay, so take the patient for a drainage and a surgery definitely. Okay, but if the patient's condition improves, if the patient's condition improves, then definitely you need to discharge the patient. Yes, you discharge the patient and call the patient after 6 weeks. Okay, call the patient after 6 weeks for a surgery, that is interval appendicectomy. Okay, so once the patient's condition improves, discharge the patient on antibiotics, call the patient after 6 weeks, and then go for an interval appendicectomy. Let the infection subside till that time. Yes, very good. The conservative management which is done, this conservative management that I've explained to you in a case of appendicular lump is what is known as the Ochsner-Sherrin regime. Very good. It is classically known as the Ochsner-Sherrin regime. That has been a previous year question as well. Okay, so that's important. Please remember this. Ochsner-Sherrin regime has to be done. Next, if I talk about, as I've told you, patient recovers, discharge and call for an interval appendicectomy. Okay, interval appendicectomy. But if there is no recovery, that is suggestive of an abscess, then definitely drain the abscess. Okay, drain the abscess and go for a surgery in the patient. Okay, so that's important. Chalo. So that was all about your appendix that you need to remember. Next, talking about your pancreas, guys. If I talk about your pancreas, I hope all of you are quite aware. Pancreas is a gland which has both the functions. Okay, yes, it is a gland which has an exocrine function. What is the exocrine function? That is secretion or production of gastric juices or gastric enzymes, which helps in absorption of food. Okay, so the pancreatic enzymes or the juices which are secreted, okay, that is the exocrine function, and that is released into the duodenum. Which part of the duodenum? Second part of the duodenum. Okay, at the ampulla of Vater, definitely via the main pancreatic duct. Okay, whereas next is the endocrine function. And endocrine function of pancreas is due to the islets of Langerhans, and these islets of Langerhans definitely have alpha cells, beta cells and the delta cells, and they secrete hormones. So alpha cells secrete glucagon, beta cells secrete insulin, and delta cells secrete somatostatin. So that is what is the physiology, basic anatomy and physiology. Important is, I hope all of you are quite aware, this is the duodenum, the C-shaped loop of the duodenum, and in that we have this pancreas which are there. Okay, so if I talk about the pancreas, definitely, so this is the pancreas basically, that is the head, that is the neck, this is the body, this is the tail of the pancreas, and this is what is called as the uncinate process of the pancreas. Okay, important is, now if they ask you which is the most common congenital anomaly of pancreas, if they ask you most common congenital anomaly of pancreas, a lot of people answer it as annular pancreas. No, it is not annular pancreas. Please remember, the head of the pancreas which is there now, it is formed by fusion of dorsal pancreatic bud and a ventral pancreatic bud. तो दोनों जब एक साथ फ्यूज करते हैं तब एक pancreatic head बनता है, dorsal and ventral pancreatic bud. But if these pancreatic buds do not fuse with one another, if the ventral and the dorsal pancreatic bud do not fuse with one another, then the congenital anomaly which is seen in the pancreas is known as pancreas divisum. So please remember at least an important one-liner. The most common congenital anomaly in pancreas is known as pancreas divisum. Okay, and in pancreas divisum, the patient will have a high risk of pancreatitis. The patient will have a high risk of pancreatitis usually. Okay, patient has a high risk of pancreatitis. Treatment, just remember. So what happens over here, as I've told you, the main duct which is there, okay, it will have a very small opening, whereas the second duct which is, okay, so the main duct will have a very small opening. The main duct will have a very small opening. Due to this, what is happening? The secretions of the pancreas are not able to come out. Therefore, they remain in the pancreas. And what are the main secretions of the pancreas which come out via duct? The enzymes. Which enzymes? The lipase enzyme, the amylase enzyme. They are not able to come out. Therefore, they will start damaging the pancreas itself. They will start damaging the pancreas. That leads to pancreatitis in the patient. Okay. So now we are going and we will open up this pancreatic opening. Okay. We are opening up this duct opening. That is what is called as ERCP with sphincterotomy. The treatment option which is there is known as ERCP with sphincterotomy. We will perform endoscopic retrograde cholangiopancreaticography. We will insert an endoscope via the oral cavity to the esophagus, to the stomach, to the duodenum. In the second part of duodenum, laterally we have the pancreatic duct opening. We will give incision over the sphincters of the pancreatic duct opening. That is what is called as sphincterotomy. Okay, so ERCP with sphincterotomy has to be done in the patient. Next is, we have the question that says a male patient. Okay, so we have a case that says a male patient presents to the emergency room with sudden onset severe acute epigastric pain. There's a sudden onset severe acute epigastric pain which radiates on lying supine. Okay, so please remember, there is a sudden onset severe acute epigastric pain, and this epigastric pain is radiating to the back. This epigastric pain is radiating to the back usually. What did I tell you? What is the diagnosis? Chest pain radiating to back or interscapular area makes a diagnosis of aortic dissection. But epigastric pain radiating to back makes a diagnosis of, so please let me know. So definitely the patient is having epigastric pain which radiates to the back, and this pain increases when the patient lies supine, and it is decreased or the pain is relieved when the patient sits bending forward. जब वो आगे झुक के बैठता है ना तो पेन रिलीव हो जाता है, बट अगर वो सीधा लेट जाए तो पेन बढ़ जाता है. ठीक है, and the pain is going back till his back. Okay, it is radiating to his back. Very good. The diagnosis is what is a acute pancreatitis. Okay, the patient is also having fever, nausea, vomiting, all of these features. So definitely the diagnosis in this condition is a case of acute pancreatitis. Okay, because in chronic pancreatitis the patient will not have such severe signs and symptoms. So it is a case of acute pancreatitis where a patient comes to us in emergency with severe signs and symptoms. Okay, so all of these will be present. In cases of acute pancreatitis, what is the most common cause now? Pancreatitis is nothing but inflammation of the pancreas. The most common cause of acute pancreatitis, please remember, is gallstones. Yes, the gallstones come. Okay, so this is the duodenum and this is the pancreatic duct which is opening, and this is the bile duct which opens along with the pancreatic duct. So a gallstone comes and it blocks this opening over here. It blocks the ampulla of Vater. As it blocks the ampulla of Vater, definitely what will happen? The secretions are not able to come out, and again these secretions or these enzymes will start damaging their own pancreas, and that is what is pancreatitis. Okay? So definitely gallstones is the most common cause, followed by second most common cause being alcohol. Okay? So that is important. In cases of acute pancreatitis, what will be the complaints? As I've already told you, the patient will have severe epigastric pain radiating to the back along with fever, nausea, vomiting, all of these features. Okay? Now, what should be the investigation of choice? If I talk about investigation of choice, the investigation of choice in a case of acute pancreatitis is a CCT abdomen. The investigation of choice will be a CCT abdomen. That's important. Okay, CCT abdomen should be seen. And if it is a case of acute hemorrhagic pancreatitis, if it is a case of acute hemorrhagic pancreatitis, what will be seen then? Okay, what is a hemorrhagic? That means bleeding is also seen from the pancreas. So in cases of acute hemorrhagic pancreatitis, a lot of bleeding occurs in the peritoneum, and due to that, what will happen? You can see there will be bruising around the umbilicus. This bruising around umbilicus is known as the Cullen's sign. This bruising around umbilicus is known as the Cullen's sign. And if there is bruising in the flank region, if there is a bruising in the flank region, franks कब देख पाते हो? जब turn करते हो. So that is what is called as a Gray Turner's sign. Okay, that is what is known as the Gray Turner sign. Okay, so please remember, Cullen's sign or Gray Turner sign are usually seen in cases of acute hemorrhagic pancreatitis. They can also be seen in cases of any case of hemoperitoneum. That is usually a case of ectopic pregnancy, also can present to you with these symptoms. Next, definitely on a CCT, as you can see, there's a lot of collection around the pancreas, and this collection can be blood at times. This collection can definitely be some necrosis as well. Okay, so that should be remembered. Important is, if I talk about investigation of choice, then definitely your answer is CCT abdomen. No issues with that. Okay, and CCT abdomen is generally performed after 72 hours of admission. Why? Because usually after 72 hours of pancreatitis, we will be able to know what is the exact amount of necrosis which has happened. कितना necrosis exactly हुआ है, ये हमें 72 hours के बाद exactly पता चलेगा. ठीक है? So it is usually performed after 72 hours. If they ask you what is the best investigation, then definitely your answer should be what? So please remember, what is your best investigation? Okay, so please remember, the best investigation should be serum lipase. Yes, serum lipase followed by serum amylase is the best investigation. Why? Because serum lipase is more specific to the pancreas. Amylase can be seen in pancreatic juice also. It can be seen in saliva secretion also. So therefore, amylase is not specific. But if serum lipase levels are very, very high, that is definitely suggestive of acute pancreatitis in a patient. That is definitely suggestive of acute pancreatitis. That is a very important question. Okay, we can just make a diagnosis with the help of raised serum lipase levels as well. Okay, no need of CCT immediately. Important is, definitely there are a lot of scores or criteria which will tell us about the severity of acute pancreatitis. So please remember, there are multiple scores, okay, but the important scores which are used to assess the severity of pancreatitis. Pancreatitis kitna severe hai? To assess that, definitely we have a score that is known as the Ranson score. That has been asked. Okay, so Ranson score is definitely telling you about the severity of acute pancreatitis. Then if they ask you which is the CT severity index, okay, based on the CT findings of the patient, okay, how the radiologist is telling you that the pancreatitis case is more severe or less severe. That grading, okay, is known as Balthazar grade. Okay, so please remember, the CT severity index that we have is known as the Balthazar grading. Important ones, okay, it is known as the Balthazar grading. That's important. Okay, next important, if I talk about management of this patient. So usually cases of acute pancreatitis are not managed by surgical management. They will go for conservative management. Yes. Okay, cases of acute pancreatitis are managed conservatively. And what will be the conservative management? Again, we know it is same thing. Keep the patient NPO, give IV fluids to the patient, give IV antibiotics to the patient, and give analgesics to the patient. That is painkillers, because the patient is having a lot of pain. So that should be done. Please remember, okay, we don't need to go for any type of surgical management in a case of acute pancreatitis usually. Then in some cases of acute pancreatitis, not all of them, please remember, you know, on X-ray abdomen, you can see that the colon shadow which is there, it appears to be cut off. The colon shadow which is there, it appears to be cut off. This is called as the colon cutoff sign. The colon cutoff sign usually on X-ray abdomen can be a feature seen in cases of acute pancreatitis. Okay, it can be a feature which is seen in cases of acute pancreatitis. Please remember that. No issues with this, anybody? So these are the important things that you need to remember, guys, in cases of acute pancreatitis. Then if I talk about chronic pancreatitis, guys, please remember, chronic, that means here the symptoms or signs of the patient will be mild to moderate. The patient will not come to you in emergency. Mostly the patient presents to you in OPD. In chronic pancreatitis, the most common cause that you need to remember, the most common cause of chronic pancreatitis is usually alcohol. The most common cause of chronic pancreatitis is alcohol. But the other causes of chronic pancreatitis which are there, the other causes of chronic pancreatitis which are there, they are remembered by a classification. Yes, there is a special etiological classification, the classification that can tell you about the causes of chronic pancreatitis, and that is what is called as the Tigard-O classification. That is what is known as the Tigard-O classification. So just remember T for toxins, and the most common toxin responsible will be alcohol or some other drugs can also cause pancreatitis. I stands for idiopathic, that is unknown cause. G stands for genetics. A stands for autoimmune. R stands for recurrent episodes of pancreatitis, and O stands for obstructive cases of pancreatitis. Okay? So these can be the multiple causes of chronic pancreatitis. Okay? So that is important. That was asked. That Tigard-O classification is generally used for. It is used for chronic pancreatitis in a patient. Then in a case of chronic pancreatitis, as the pancreas are damaged, definitely there will be dysfunction of the pancreas. If there is dysfunction of the pancreas, there will be exocrine insufficiency or there can be endocrine insufficiency. That means the exocrine function of the pancreas is also lost and the endocrine function of the pancreas is also lost. If the exocrine function of pancreas is lost, what is not produced properly? The enzymes are not produced properly. And if the enzymes are not produced properly, will the food be able to digest? Will the food be able to absorb? No. So there will be malabsorption in the patient. There will be malabsorption in the patient. That's important. Whereas, as the serum lipase is not there, okay, lipase is not secreted now. Lipase is what? An enzyme which breaks down lipids or fats. So therefore, if fats are not broken down, they cannot be absorbed. Therefore, all the fats, all the lipids will be excreted out in the stools of this patient. And the stools will be heavy, bulky, foul smelling, greasy, oily stools. These are called as steatorrhea. That was the question again. Okay? So in a case of chronic pancreatitis or malabsorption, fat malabsorption, there can be steatorrhea also. Next is endocrine insufficiency. Endocrine was what? The hormones. So now the hormones which were there, insulin, glucagon, all of them will be deficient. So as the main hormone is insulin, insulin deficiency is known to cause diabetes mellitus in the patient. Okay? It will lead to diabetes mellitus or hyperglycemia in the patient. Okay? So that will be seen. Then if I talk about investigation of choice in cases of chronic pancreatitis. Investigation of choice in a case of chronic pancreatitis, definitely you need to remember. Okay, you need to remember that the investigation of choice in a case of chronic pancreatitis will be what? It is usually a MRCP. It is usually a MRCP. That is a magnetic resonance cholangiopancreatography. Okay, so it is usually a magnetic resonance cholangiopancreatography. In that you will see that the duct has been dilated. Okay, on a MRCP scan, you can see that the main pancreatic duct has been dilated and a lot of secretions are present within the main pancreatic duct. Okay, so that can be done. Or if you see that the duct is not the problem, there is no problem at the level of the duct. Okay, there is no obstruction at the level of the duct, so there will not be any duct dilatation. In that condition, definitely you will go for a CECT. In that condition, you will go for a CECT. Please remember, in that condition, you go for a CECT. Next is if I talk about gold standard investigation, that is usually a ERCP. Gold standard investigation is usually a ERCP. Gold standard or best, that means, see the basic difference I've told you earlier also. Investigation of choice means a more practical investigation that can be done, which can be sensitive. 70 to 80% sensitivity is also fine with investigation of choice, but it is non-invasive. It is non-invasive. It is not pricking up. We are not inserting something in the patient. But on the other hand, gold standard or best investigation is the one which will tell you the diagnosis 100% times. Does not matter whether it is an invasive investigation, right? Like if we are pricking the patient or if we are inserting anything in the patient. But these gold standard or best investigations are only done if the investigation of choice is not able to tell you about the diagnosis. Okay? So these are more theoretical investigations, but investigation of choice is a more practical investigation. Okay? That is important to be remembered. Okay? No issues till anybody. Why ERCP is gold standard? Because please remember, ERCP will not only be used for diagnosis of chronic pancreatitis, but it will also help us in treatment of chronic pancreatitis. Therefore, ERCP is considered as the gold standard or the best investigation. How it will help us in treatment? Let's see that now. Okay. Now, if I talk about the treatment of chronic pancreatitis, you can see this is a case of chronic pancreatitis. This is a CECT scan. And in the CECT scan, what did I tell you? Definitely or MRCP or CECT. You can see that the main pancreatic duct is dilated. And in the main pancreatic duct, the secretions are there. all these secretions are not able to drain. Therefore, they are present in the pancreas itself. They are collected in the main pancreatic duct. Therefore, what can be formed out of it? Stones can be formed. So the whitish that you can see now, these are the stones which are formed in the main pancreatic duct. Yes, stones will not be seen in a case of acute pancreatitis. They will be seen in a case of chronic pancreatitis. First thing, okay, stones in the main pancreatic duct. Second important, in a case of chronic pancreatitis on a MRCP, I don't have a, okay. So in a case of MRCP, in a case of chronic pancreatitis, I can see the main pancreatic duct as it is blocked. Therefore, all the secretions are lying inside the main pancreatic duct. It is getting dilated. Okay, it is getting dilated and it gives me this characteristic appearance. What is this characteristic appearance? It is known as the chain of lakes appearance. It is known as the chain of lakes appearance. Okay, so this is the characteristic feature seen on MRCP in a case of chronic pancreatitis, chain of lakes appearance. If I talk about the treatment in a case of chronic pancreatitis now there are two types of treatment options or procedures which are done in a case of chronic pancreatitis. If the main pancreatic duct is blocked, due to which the patient is having chronic pancreatitis. Okay, here due to blockage, the main pancreatic duct has been dilated and due to which the patient has developed chronic pancreatitis. Then we'll go for a draining procedure. The draining procedure is done when the problem lies within the duct. Whereas there is no problem in the duct is open, but the problem is that the pancreas, the tissue of the pancreas is inflamed and it has undergone necrosis. Then we need to go for a resective procedure when the problem is within the parenchyma or the tissue of the pancreas. Okay, then definitely we'll go for a resective procedure. If I talk about the draining procedures in the duct, if the main pancreatic duct is less than equal to 6 mm dilated, if the main pancreatic duct is less than equal to 6 mm dilated, then we'll go with the help of ERCP and we'll just open up the sphincter. We will just open up this sphincter. We will give incision over the sphincter. And I have already told you what it is called as. It is called as ERCP with sphincterotomy. Now you can see ERCP can be used for treatment of chronic pancreatitis. That's the reason why it is considered as gold standard. So ERCP with sphincterotomy should be done if the duct is less than equal to 6 mm dilated. But if the duct is more than 6 mm dilated, if the duct is more than 6 mm dilated, guys, then definitely you need to go for what? Then you need to go for a procedure, and that is what is called as a draining procedure. Either it is known as a Duval's procedure, okay, or it is known as a Pastot's procedure. Okay, it is known as a Duval's or a Pastot's procedure. It is known as Duval's or Pastot's procedure. So please remember what I am trying to tell. See, this is my pancreas. Okay, this is my pancreatic duct and this is my jejunum. If I am connecting pancreatic duct and jejunum like this, that is end-to-end pancreatico-jejunostomy. End-to-end pancreatico-jejunostomy. This is what is called as Duval's procedure. But if I connect the pancreatic duct and the jejunum like this, if I connect the pancreatic duct and jejunum like this, then this is what is called as side-to-side pancreatico-jejunostomy. Okay, side-to-side pancreatico-jejunostomy is another name for Pastot's procedure. It is another name for Pastot's procedure. Next, if I talk about the resective procedure, if the inflammation is in the head of the pancreas, then I go for resection of the head, and the resection of head is known as the Bejer's procedure. The resection of head is known as the Bejer's procedure. If I talk about the tail of the pancreas, I will just remove the tail of the pancreas, and the tail of pancreas is what is removal of tail of pancreas is known as distal pancreatectomy. It is known as distal pancreatectomy. Only remove the distal part of the tail of pancreas. Okay? So these are the usual treatment options for a case of chronic pancreatitis. Now, if I talk about a complication of chronic pancreatitis, it can also occur after acute pancreatitis. It can also occur after chronic acute pancreatitis, but it is more commonly seen after chronic pancreatitis. It is more commonly seen after chronic pancreatitis. And what is that? That is a pseudocyst. That is what? That is a pseudocyst. You can see what is formed. Cyst ka matlab hota hai sac. Cyst means a sac, and a sac which contains fluid. Okay? So here usually a cyst-like structure or a sac-like structure is formed which contains a lot of fluid that arises near to the pancreas itself. Okay, that is what is a pseudocyst. So pseudocyst contains nothing else but fluid. It contains nothing else but usually serous fluid is present inside it. Okay? That is a complication usually after chronic pancreatitis. Now, most of the cases of pseudocyst, the patient will be asymptomatic. Most of the cases of pseudocyst, the patient is asymptomatic, but sometimes if the pseudocyst is too big in size, then definitely the patient will have epigastric pain. The patient can have pain, or the patient can have fullness, or the patient will have bloating sensation. Why? Because this cyst can compress the stomach. Cyst pressure डालेगा किस पे? Stomach पे. So the patient can have epigastric fullness, there will be bloating sensation, there can be nausea and vomiting. Okay, these are rare symptoms though. Okay, so if a patient is having pseudocyst, what should be the treatment? So please remember, the treatment in a case of pseudocyst is usually nothing to be done, because most of the pseudocysts are self-resolving. Yes, most of the pseudocysts resolve by themselves. They undergo spontaneous resolution usually within a span of 4 to 6 weeks. Okay, they usually undergo resolution within a span of 4 to 6 weeks. Okay, they are self-resolving. They will disappear by themselves in a span of 4 to 6 weeks. But if the cyst is more than equal to 6 weeks old, okay, if the cyst is more than equal to 6 weeks old, or if the cyst is more than equal to 6 centimeters in size, or if the cyst is more than equal to 6 centimeters in size, or the cyst wall thickness is more than equal to 6 mm. So that's 666 you need to remember. Okay, if that is there, then definitely you need to go for a drainage of this cyst. And drainage can be either an external drainage or an internal drainage. External drainage, that means we are using a catheter under ultrasound guidance or CT guidance. We are inserting a catheter into the pseudocyst and we are draining that cyst. Okay, so external drainage is done when the cyst is infected or when there is hemorrhage within the cyst. External drainage is done when there is hemorrhage within the cyst or when there is an infection within the cyst, and this external drainage is done with the help of a catheter known as the pigtail catheter. It is done with the help of a catheter known as the pigtail catheter. Whereas if I talk about the internal drainage matlab opening of the cyst into the stomach or into the intestine of the patient. If I open up the cyst into the stomach or intestine, that is called as cystogastrostomy. That is known as cystogastrostomy or cystoenterostomy. So I will open up the cyst into the stomach or intestine so that it can drain over there. But the problem is, if it is infected or hemorrhagic, then definitely we cannot go for an internal drainage. Then we need to go for an external drainage with the help of a pigtail catheter. Okay. Moving further, now talking about pancreatic cancer. If I talk about pancreatic cancer, guys, important is pancreatic cancer. Pancreas is also a gland. Therefore, the epithelium which is present is again a columnar epithelium. And if columnar epithelium is there, then the cancer will again be a adenocarcinoma. Then the cancer is again an adenocarcinoma. If I talk about adenocarcinoma of pancreas, definitely you need to see whether it is carcinoma of head of the pancreas or it is a periampullary carcinoma. What is periampullary? Let me tell you that first. So usually I've told you that this is the second part of the duodenum, and in the second part of the duodenum, the main pancreatic duct will open. The main pancreatic duct will open. Along with that, the bile duct takes a turn. The bile duct takes a turn and it also opens along with the main pancreatic duct. It also opens along with the main pancreatic duct, and the site where they open is the second part of duodenum. And this second part of duodenum where they are opening, this area is called as the ampulla of Vater. This area is what is known as the ampulla of Vater. And a question was, how many sphincters are usually present at the ampulla of Vater? So there are total 4 sphincters which are present at the ampulla of Vater. Please remember, there are 2 sphincters. There are 2 sphincters in the common bile duct. There are 2 sphincters in the common bile duct. And there is 1 sphincter in the main pancreatic duct. And there is 1 sphincter at the opening over here. These 4 sphincters together are known as sphincter of Oddi. Okay, these 4 sphincters together are known as sphincter of Oddi. These are known as sphincter of Oddi. Please remember. Okay, so that is what is important. Important is now this area of ampulla of Vater. If there is a cancer which arises over here, if there is a cancer which is arising over here, if there is a cancer which arises over here, in any part over here, around this part, this is what is called as the periampullary carcinoma. This is what is known as the periampullary carcinoma. Please remember that. Okay, that is important. Now, if there is a carcinoma head of pancreas or periampullary carcinoma, how you are going to differentiate clinically? So important is, you will talk about the jaundice, because see, if there is a cancer over here or if there is a cancer in the head of the pancreas, definitely there will be compression of the ducts, and if the common bile duct is compressed, will it be able to drain the bile? No, the common bile duct cannot drain the bile, and if the common bile duct cannot drain the bile, definitely that will cause hyperbilirubinemia. That is what is nothing but jaundice, right? So the patient will suffer from jaundice in both the conditions. Jaundice, please remember how to differentiate it. Jaundice will be late in cases of carcinoma head of pancreas because it will cause compression from outside and it will take time to develop. But in periampullary carcinoma, the cancer is usually at the opening itself. Therefore, it will cause early jaundice. Next, in carcinoma head of pancreas, Once the compression starts, it will keep on compressing. It will be progressive in nature. But in periampullary carcinoma, what happens? The cancer grows, then it sheds off. Again it grows, it sheds off. इसका मतलब cancer बढ़ता है size में, निकल जाता है, बढ़ता है, निकल जाता है. Therefore, here we have a waxing and a waning course of jaundice. That is what is called as a intermittent jaundice. Okay, waxing and waning course of jaundice, that is the intermittent jaundice will be there. Important is next one, pain. Okay, in cases of carcinoma head of pancreas, the patient will have a constant abdominal pain. Patient will have a constant abdominal pain. But in cases of periampullary carcinoma, the patient will have a colicky abdominal pain. If they ask you what is the investigation of choice, in carcinoma head of pancreas, now you know that the investigation of choice is straightforward CECT abdomen. Why? Because you need to see the tissue of the pancreas or the parenchyma of the pancreas. So it is definitely the CECT abdomen which is done. What is the investigation of choice you will perform for a periampullary carcinoma? Okay, just let me know that. Okay, we have discussed about that investigation. What is the investigation of choice that will perform for a periampullary cancer? We have discussed about that investigation. What you will do if there is cancer in this area? Okay, over here itself now. So what you will do? Treatment of choice if I talk about, please remember, if there is carcinoma head of pancreas, we definitely need to remove the head of pancreas. We definitely need to remove the head of pancreas. As you can see, the head of the pancreas is removed, the neck of the pancreas is removed. Even some part of the body has to be removed at times. Apart from that, I will also remove the duodenum. Why? Because the duodenum lies in close relation. Therefore, there can be risk of spread to the duodenum also. I also need to remove the bile duct. Why? Because the bile duct was opening along with main pancreatic duct. Therefore, the cancer can also spread via this bile duct. Therefore, I need to remove the bile duct. I will remove the cystic duct also. And I will finally remove the gallbladder as well. Okay? So, all of these structures are removed. And this is what is called as the Whipple surgery. This is what is known as the Whipple surgery. This image came earlier in your examination, guys. Okay? So, definitely, this is a case of Whipple surgery. So, treatment of choice that we perform in carcinoma head of pancreas is known as the Whipple surgery. Okay? So, in Whipple surgery, important is, or a problem is what? We are also removing the pylorus of the stomach. We are also removing the pyloric canal of the stomach. So, as the pylorus of the stomach is removed, what is the complication of Whipple surgery? The patient will not be able to drain the contents from the stomach properly, and that is what is called as the most common complication. The most common complication after Whipple surgery is the impaired gastric emptying. The patient is not able to empty the stomach properly. That is called as impaired gastric emptying, because the pylorus has been removed as well. Okay, the pylorus has been removed as well. No issues with this, anybody? So that's important. Very good. It is ERCP usually. Okay, we will go for a ERCP, and if possible, we will also take a biopsy. If that is not possible, then definitely we can just go for a CECT over here as well. Okay, if that is not possible, just go for a CECT. Important is, here also in periampullary carcinoma also, we will go for the Whipple surgery itself, or sometimes we will try to preserve the pylorus. Okay, then that is called as a pylorus preserving pancreatic and a duodenal resection. Okay, so that is another surgery, but usually Whipple's is preferred, because Whipple's, we are removing so many structures, therefore there will be very less chances of recurrence after Whipple surgery. Now you can see, now what is left behind? The common hepatic duct is left behind. Now you are bringing up your vela dost, and who was that vela dost? Jejunum. So you are bringing up him, and you are tying it to the common hepatic duct. That is what is called as hepatico-jejunal anastomosis or hepatico-jejunostomy. The first connection that I have made is the hepatico-jejunostomy. Next connection we need to make is, now the jejunum is pulled upwards, and the second connection is made between the stomach and the jejunum. So stomach and jejunum is called as gastro-jejunostomy or a gastro-jejunal anastomosis. And the third connection that I'll make is between the pancreas and the jejunum. Why? Because the pancreas, some part of pancreas is left still, right? And we need the pancreatic enzymes and juices for digestion. Therefore, it is the pancreatico-jejunostomy. So the three anastomosis which are done in a case of Whipple surgery will be hepatico-jejunostomy, gastro-jejunostomy, and a pancreatico-jejunostomy. That's important. No issues with this, anybody? If I talk about the barium meal or a barium meal follow through that I can do over here, a contrast study, you can get this classical sign in a case of carcinoma pancreas. And this classical sign is not known as the antral pad sign. Antral pad sign is seen on a upper GI endoscopy. Here you are able to see a reverse 3 sign. You are able to see a reverse 3 sign usually, or it looks like a E, na? So it can also be called as the E sign. So reverse 3 sign, E sign, And important, it is also known as the Frostberg sign, and that was the question. Okay, so it is also known as the Frostberg sign. So they have asked, Frostberg sign is a feature of, you know, now it is a feature of pancreatic cancer. Now please tell me, after surgery definitely we can follow up the patient with the help of a tumor marker. So we will see if the tumor marker values are going down or not. So then we will be relaxed. Okay, the cancer is now going out. So definitely, what is the tumor marker? What is the tumor marker in a case of pancreatic cancer? What is the tumor marker? Faster. It is also the tumor marker in cases of gallbladder cancer. It is also a tumor marker in cases of gallbladder cancer. Anybody? Very good, Nat. Very good. It is CA 19.19-9. So very good. It is, the tumor marker is known as CA 19-9. Okay, it is known as CA 19-9. That's important. Okay. So that was all about your pancreas as well. Next topic that we are about to begin is definitely your liver. If I talk about your liver, guys, we know liver is the largest gland of your body. Okay, liver is the largest gland of your body, which weighs around 1.5 kg. It is located in the right hypochondrium, and this liver is usually divided into the two lobes. Okay, this liver is divided into the two lobes by a falciform ligament or by the Cantley's line. Okay, the liver is divided into the two lobes by the falciform ligament or the Cantley's line. Okay, this Cantley's line extends from the gallbladder fossa below to the inferior vena cava above. This is what is the Cantley's line, which divides the liver into the right hepatic lobe and the left hepatic lobe. And definitely we also have the Coynard's classification. In the Coynard's classification, please remember, according to Coynard's classification, the liver is divided into 8 segments. According to Coynard's classification, liver is divided into 4 sectors or 8 segments. It is not 10 segments. A lot of people answered it as 10 segments when it was asked. Like Coynard's classification divides liver into. A lot of people marked it as 10 because they remembered lungs. Lungs are divided into 10 segments. Liver is divided into 8 segments. Okay. And the 4th segment is divided into 4A and 4B as well. You can see in the inner part of the liver. In the inner part of the liver, you have this number 1 segment. This number 1 segment is a special segment. This number 1 segment is known as the caudate lobe. And why it is so special? Because this caudate lobe will drain its bile in the right side also and in the left side also. Second, it will receive its blood supply from the right side also and the left side also. And it will drain directly into the inferior vena cava. That is the reason why the number 1 segment of the caudate lobe is very special. Okay? Next, this 4 number. Okay, this one, the 4th segment which is there, it is known as a quadrate lobe. Okay, this 4th one is also known as a quadrate lobe. That's different. Caudate is different, quadrate is different. Next, if I talk about the benign conditions of liver or mainly the infections of liver. If I talk about infections in the liver, one is called as a pyogenic liver abscess, second is called as an amoebic liver abscess. So abscess, all of you are quite aware now, it is nothing but pus collection. Okay, and that is due to some infection in the liver. Okay, so one is pyogenic liver abscess and second is amoebic liver abscess. Pyogenic का मतलब होता है pus forming. Okay, so if I talk about pyogenic liver abscess, usually it is polymicrobial. The most common cause is polymicrobial. What do I mean by this? Many organisms come together, many bacteria are responsible to cause pyogenic liver abscess. But if they ask you most common organism, okay, so most common organism usually is E. coli. Most common organism worldwide is definitely E. coli because that is present already in the intestine. Therefore, it can go till the liver and it can cause infection in the liver. But if they ask you usually in Asia, okay, India or Asia, definitely here the organism which is responsible is Klebsiella. Here the organism which is responsible is Klebsiella. Whereas amoebic liver abscess, if I talk about, it is due to an amoeba, and that amoeba is known as Entamoeba histolytica. That amoeba is what is called as Entamoeba histolytica. Next important, okay, what is the most common site for a pyogenic liver abscess? Important is, for pyogenic liver abscess, there is not such a specific site. It can occur in right lobe also or left lobe also. But amoebic liver abscess, please remember, usually it is more commonly seen in the right lobe of the liver. It is more commonly seen in the right lobe of the liver, and usually in which quadrants? It is usually seen in the postero-superior quadrants. It is commonly seen in the postero-superior quadrants of the liver. Okay, so which are the postero-superior quadrant? Number 7 and number 8 quadrants. Okay, in these quadrants, amoebic liver abscess is more common. Important is how the infection will spread up to the liver. In pyogenic liver abscess, I hope all of you are quite aware. For example, this is the liver. Right hepatic duct, left hepatic duct combines to form the common hepatic duct. Then it combines with the cystic duct to form the common bile duct. And this common bile duct opens up into the duodenum. So therefore, this organism or infection from the duodenum goes into the bile duct or the biliary tree. And from there, it reaches up to the liver. Please remember that. Okay. So this is called as ascending cholangitis. What is cholangitis? Infection of the biliary tree. And it is going in the ascending fashion. Whereas if I talk about amoebic liver abscess, so the organism first of all comes in the intestine of the patient. In the intestine of the patient, it causes intestinal amoebiasis. Okay. And when it causes intestinal amoebiasis, it causes these classical ulcers. And what are these ulcers? These are the classical flask-shaped ulcers. So flask-shaped ulcers in the intestine are very characteristic of intestinal amoebiasis. Okay. So when there is a flask-shaped ulcers which are formed, then definitely from this flask-shaped ulcers, the organism will spread to the blood vessels. And from that blood vessels, it will go to the portal vein. And from portal vein, it will reach the liver. Okay. From portal vein, it will reach to the liver. So it is usually via the enterohepatic circulation, amoebic liver abscess will occur. Now, if I talk about amoebic liver abscess, please remember it is more common in alcoholic patients. It is more commonly seen in alcoholic patients. Why? Because alcoholic patients are not in their senses. They eat anything they get. Okay? So definitely amoebic infections or amoebiasis is usually spread by fecal-oral route. And when there is fecal-oral route transmission of amoeba, that causes intestinal amoebiasis. From there, it spreads by the portal vein to the liver, and then that causes amoebic liver abscess. Okay? Important is what is the clinical feature. If I talk about the clinical features in a case of pyogenic and amoebic liver abscess, in both the conditions, patient will have fever. In both the conditions, the patient will have fever. In both the conditions, the patient can have abdominal pain as well. Okay, but important is in cases of pyogenic liver abscess, as it is a bacterial infection, definitely the fever, the pain will be much more. Okay, the patient will be more toxic as compared to a amoebic liver abscess. Okay, so that's the basic difference between both of them. If I talk about the investigation of choice, now investigation of choice in both the conditions, please remember the investigation of choice in both the conditions can either be a CCT abdomen for an adult. It can be a CCT abdomen for an adult. But if CCT abdomen is not available, or if the patient is a child, then you can even go for an ultrasound abdomen. Okay? So that would be important. Next, if I talk about treatment in the patient. In pyogenic liver abscess, as it is a bacterial infection, first I'll start the patient on broad spectrum antibiotics. I'll first of all start the patient on broad spectrum antibiotics, and then definitely I'll go for aspiration or drainage of the abscess. Then I'll go for either an aspiration or drainage of the abscess. Okay? Whereas if I talk about amoebic liver abscess, here the drug of choice for an amoebic liver abscess is usually metronidazole. And I hope all of you are quite aware that metronidazole is a tissue amoebicidal agent. It will kill the amoeba inside the tissue amoebicidal. So once you will start metronidazole in the patient, then you will continue metronidazole for a span of 2 to 3 weeks. Okay, you will continue metronidazole for a span of 2 to 3 weeks. And once the patient improves, definitely you will go for what? Definitely you will start another drug in the patient. And that drug is what is called as diloxanide furoate. Okay, that drug is known as diloxanide furoate. Now you will say, sir, why another drug? Because I've told you metronidazole kills the amoeba which is present in the tissues. But what about the amoeba which was present outside the tissues in the intestine? Okay, in intestine also there was amoebiasis now. So for that, we will give 10 days of diloxanide furoate in the patient. Okay. Whereas if the patient's condition does not improve, even after 2 to 3 weeks of metronidazole therapy, then you cannot continue metronidazole therapy. Okay. When we are giving diloxanide furoate, we continue metro as well. Please remember that. Okay. Important is here, if metronidazole के लिए patient does not respond, then definitely we cannot continue metronidazole, and that in that condition we definitely need to go for an aspiration or a drainage. And that aspiration or a drainage is usually done by this. What is this? This is what is the classical pigtails catheter. Okay, so this is what is the pigtails catheter under ultrasound or CT guidance. Mainly under ultrasound guidance, we will insert this pigtails catheter in the abscess and we will drain the abscess whichever is possible. Okay, we will drain the abscess in the patient. Okay, that's important. And once you drain the abscess, you will get this kind of a characteristic pus. And this kind of a characteristic pus that we get in a case of amoebic liver abscess is known as the chocolate pus, or also known as the anchovy sauce pus. It is known as the chocolate pus or the anchovy sauce pus. That's important. Okay? Once we are done with this, then let's talk about hydatid cyst. If I talk about hydatid cyst or hydatid disease, whatever you call it, important is it is caused by which organism? So please remember, cyst is again a cavity or a sac which contains some amount of fluid. So hydatid cyst, maybe we have a cavity or a sac which contains some amount of fluid which can be formed in various organs. But the most common organ in which it is formed, is usually where are we studying it? Definitely the liver. The most common site is usually the liver, followed by lungs. The most common site for hydatid cyst or hydatid disease is usually the liver, followed by lungs. But if they ask you which is the most common cause for it, what is the organism which leads to hydatid cyst or hydatid disease? Very good, all of you. It is Echinococcus granulosus. Okay, it is a tapeworm known as Echinococcus granulosus. So I hope all of you are quite aware. This Echinococcus granulosus is also known as which tapeworm? So this Echinococcus granulosus is also known as dog tapeworm. What is the definitive host? By the name it is evident. Okay, it is dog. Okay, who is the definitive host? Who is an intermediate host? Definitely intermediate host is a sheep. And who is the accidental host? Accidental host is a man. Okay, so that is how we get the infection. Important is, please remember, if there is a single cyst, then the cause can be Echinococcus granulosus. Definitely then the cause is Echinococcus granulosus. But if a patient is having multiple cysts, okay, so in the liver you can see multiple cysts, many cysts, then it is a case of malignant hydatid. Then it will be a case of malignant hydatid. Malignant does not mean cancer, again I am telling you. It just means life-threatening or a severe infection. So in a case of malignant hydatid, the cause is not Echinococcus granulosus, then the cause is Echinococcus multilocularis. By the name it is evident, na? Multilocularis. That is, at multiple locations there is cyst formation. So that has been asked prior. Malignant hydatid is caused by Echinococcus multilocularis. Or if they give you a CT where there are multiple cysts which are seen usually, that is a case of Echinococcus multilocularis. Okay? What is the investigation of choice? Yes, investigation of choice is a CECT abdomen. Investigation of choice is a CECT abdomen, contrast enhanced CT scan of abdomen, and on that we can see. So the cyst which is formed now, it has an outermost covering called as a pericyst. Then it has another covering known as ectocyst, and then it has the inner covering known as endocyst. So this endocyst which is there, it gets separated and it floats inside the cavity or the cyst. It floats inside the cavity of the cyst, and this is what is called as the, as you can see over here in the CCT, this membrane is floating. This is what is called as the floating water lily sign. It is either known as the floating water lily sign. Okay, looks like the water lily flower, or it is also known as, it looks like a snake also now. So this is also known as the serpent sign. It can also be called as the serpent sign. Okay, so that's important to be remembered. No issues with this, anybody? Now if they ask you what is the treatment, so the treatment for most of the cases of hydatid cyst will definitely be what? So the treatment of choice is usually a pair therapy. The first line management or the first line treatment is usually a pair therapy. What is pair therapy? I'll talk about it. Along with pair therapy, definitely we will give albendazole to the patient. Along with pair therapy, we will give albendazole. But the first line management is always a pair therapy. And what is pair therapy? As I've told you, it is nothing but percutaneous. It is percutaneous aspiration. So whatever fluid is present inside the cyst, under ultrasound guidance, aspirate all the fluid. Then I stands for what? Injection of scolicidal agents. What are scolicides? Scolicides or scolex is nothing but the immature forms of this tapeworm. So just give some scolicidal agents which will kill these immature forms, so that again the cyst will not be formed. Okay, injection of scolicidal agents and reaspiration. R stands for reaspiration. That is what is a pair therapy: percutaneous aspiration, injection of scolicidal agents, and reaspiration. That is what is the pair therapy that you need to remember in the patient. Okay, important is that if pair therapy is contraindicated, what are the conditions where a pair therapy can be contraindicated? Important is, please remember, like a case of malignant hydatid. In a case of malignant hydatid, you know now there are multiple cysts. Okay, are you going to perform pair in every cyst? No, it is not possible. So if it is a case of malignant hydatid, or please remember, if the patient is pregnant, or if you will feel that the cyst is too large in size, okay, definitely, or there is a risk of rupture of that particular cyst, then in that condition, definitely you can go for a, if there is a single cyst, if there is a single cyst, a single large cyst is there, and pair therapy is contraindicated because it is a deep seated cyst or it is a dead or a calcified cyst. All of these are contraindication. In that condition, you can go for a cystopericystectomy. Just remove the cyst. That is called a cystopericystectomy. But if it is a case of malignant hydatid, you need to remove that part of the liver which is having the cyst. Because there are multiple cysts, you cannot remove every cyst. Then you need to go for a liver resection. Okay? That is important. And the question was another question which has been asked, which is the most common scolicidal agent used. So there can be multiple scolicidal agent, but the most common scolicidal agent which is used is a 20% hypertonic saline. That means a saline which contains a lot of salt. Okay, 20% hypertonic saline. Other agents which can be used will be mebendazole solution, 95% ethanol or ethyl alcohol can also be used. Okay. So that is important, but 20% hypertonic saline is definitely the most common scolicidal agent which has been used for this. Next, if I talk about the tumors of the liver, if I talk about most common malignancy of liver, we know most common malignancy in most of the organs in the body is not the one which arises from that particular organ, is the one that metastasizes from other sides. What do I mean by this? हिंदी में बताता हूँ. Please remember, किसी भी मोस्ट ऑफ द ऑर्गन्स जो होते हैं तुम्हारी बॉडी में, उसमें जो मैलिग्नेंसी होती है, सबसे कॉमन मैलिग्नेंसी जो होती है ना, वो शायद उस ऑर्गन से अराइज ही नहीं होती है. वो कहाँ से आती है? वो किसी और कैंसर से आता है, और अगर किसी और कैंसर से स्प्रेड होता है तो उसको क्या बोलते हो? मेटास्टासिस. So the most common malignancy of liver is also metastasis, or it can be called as secondaries. The most common malignancy of liver is metastasis or secondaries. But if they ask you the most common primary malignancy of liver, what do I mean by primary? The one which arises from the liver itself, the one which arises from the organ itself. Then it is definitely HCC, that is hepatocellular carcinoma. Then it is definitely HCC or hepatocellular carcinoma. Hepatocellular carcinoma can also be called as hepatoma. Usually oma is a mnemonic, oma is a suffix that we use for benign tumors. But hepatoma is one exception, याद रखना है तुम्हें, that hepatoma is another name for hepatocellular carcinoma. Next is, which is the most common primary tumor in children? So the most common primary tumor of liver in children is called as hepatoblastoma. It is known as hepatoblastoma. Please remember that. Okay. Whereas if they ask you which is the most common benign tumor of liver in adults, usually which is the most common benign tumor of liver, then your answer should be hepatic hemangioma. What is the hemangioma? A benign tumor which arises from the blood vessel. Hemangioma. Okay, hepatic hemangioma. Usually, please remember, investigation of choice for all the other liver tumors, is CCT. Okay, it is CCT, contrast enhanced CT scan of abdomen. We never take a biopsy for liver tumors, whether it is a benign tumor or a malignancy, because there is a risk of spread. Therefore, we avoid taking a biopsy in a case of liver tumors. It is always a CCT abdomen. But in a case of HCC, it is a triple phase CT. In a case of HCC, it is a triple phase CT. We will give contrast and then we will perform the CT in 3 phases. That is called as a triple phase CT. Okay? No issues with this. Hepatocellular carcinoma, as it is a malignancy, it has always to be resected. मतलब निकालनी पड़ती liver. Either will go for a partial or a complete liver resection, definitely. Okay? But in benign tumors, observation and follow-up has to be done. Okay? Most of the benign tumors. Important is, one benign tumor, they will commonly ask you, which is the benign tumor commonly associated with OCP intake? Please let me know now. Which among the most of the benign tumors of liver are commonly associated with oral contraceptive pill intake, but which is the most common and the most strongest one which can be associated with OCP intake? सबसे ज़्यादा risk कौन से benign tumor की होगी liver के, if a patient is taking OCPs, oral contraceptive pills? That is my question to you. Please answer that. Then I start with gallbladder. Triple phase CT is nothing, guys. Please remember, here you will give contrast to the patient. Before giving contrast, you will take one CT. That is called as the non-contrast phase. Then you will give contrast and then you will take a CT. That is called as the arterial phase CT, when the contrast is passing from the artery. And then definitely when the contrast goes to the portal vein, then you will take one CT, that is called as a venous facing. These three CTs you take, that is what is a triple face. So the most strongest association among all the liver tumors with OCP intake is seen with hepatic adenoma. You might have studied it, right? So it is commonly seen with hepatic adenoma. Please remember that. Okay. So hepatic adenoma. And hepatic adenoma, though it is a benign tumor, it has to be removed because there are 10% risk of malignancy in case of hepatic adenoma. Other benign liver tumors, there is no risk of malignant conversion. Next is this, and that is gallbladder. If I start with gallbladder now, okay, let's start with gallbladder. If I talk about gallbladder, guys, important is, I hope all of you are quite aware that gallbladder is nothing but a sac-like structure, okay, which is present in the gallbladder fossa beneath the liver. It is present in the gallbladder fossa beneath the liver. And what is the role or what is the function of gallbladder? Definitely, gallbladder is known to store the bile. It is responsible for concentration of the bile. Okay, so it is responsible for storage of bile and concentration of bile, definitely. And then once we require bile in the intestine, it will release it via the cystic duct. From cystic duct, it will release it into the common bile duct, and common bile duct brings the bile into the intestine. That is the second part of duodenum that we have discussed at the ampulla of Vater. Okay, so that is what is seen. Now, if I talk about the first condition in gallbladder, so please remember, if the gallbladder, usually there's a collection of lot of bile in the gallbladder. If there is a collection of lot of bile in the gallbladder and this bile is not able to go, so what will happen? This bile will be collected in the gallbladder and it will stay there for a long time. And due to that, there will be high risk of formation of stones over here. There will be high risk of formation of stones. And these are what are called as gallstones. Gallstones are also known as cholelithiasis. Please remember, gallstones are also called as cholelithiasis. So there is a slight difference. I'll discuss about choledocholithiasis also. Please remember, choledocholithiasis means stones in the common bile duct. But cholelithiasis means stones in the gallbladder. See, there is a gallstones or cholelithiasis. There are three types of gallstones. Usually, we either have the cholesterol gallstones, we have the pigmented gallstones, okay, which are usually black or brown in color, and then we have the mixed type of gallstones. Important is, please remember, I understood that. So the most common type of gallstones overall, are usually the mixed variety of gallstones. It is usually the mixed variety of gallstones. But the most common gallstones in Asia, if they ask you, in Asia we know we are pigmented people, we are tan people. Therefore, usually the most common gallstones in Asia will be the pigmented gallstones. Important is, cholesterol gallstones are formed in which patients? Definitely the patients who are having high cholesterol, their bile will also have a lot of cholesterol. And then cholesterol stones are formed usually in patients who are having a lot of cholesterol. What are these? These are fat females in the 40s. Sorry. You need to remember the 3 F's. Okay. So fat females in their 40s. Okay. Fat females in their 40s are definitely at a higher risk to develop cholesterol gallstones. And cholesterol gallstones usually have more than 90% of cholesterol content in them. What are the risk factors for cholelithiasis or gallstones? So the risk factor for cholelithiasis will be a lithogenic bile. What do I mean by a lithogenic bile? A stone forming bile. And what is a stone forming bile? A bile which contains excess amount of cholesterol in it, a bile which contains excess amount of bile salts in it, or a bile which contains excess amounts of bile pigments in it. Bile pigments are biliverdin and bilirubin. Okay? So if these are present in high amounts, definitely the patient will have a high risk of gallstone formation. Another is an infection that you need to remember is a Clonerchus infection. Yes, Clonerchus sinuses is a parasite. That infection can also increase the risk of gallstone formation in the patient. Okay, important is that. Now, if I talk about the complaint, most of the cases of gallstones or cholelithiasis are asymptomatic. Sometimes the patient can have a dull pain, usually in the right hypochondrium. Okay? Now, if the patient comes to you, usually you are performing ultrasound abdomen for some other reason. And at that time, you are able to see some stones in the gallbladder. So, usually it is a incidental diagnosis. We do not make a diagnosis usually for a gallstone. It happens. Why? Because most of the gallstones are asymptomatic. Important is, investigation of choice for a gallstone is not a CT. It is not a X-ray. Please remember. Why? Because 90% of the gallstones are radiolucent. What do I mean by radiolucent? Radiolucent का मतलब होता है which appears black on X-ray. If something appears black on X-ray, that is called as radiolucent. And most of the gallstones are radiolucent. It will not be picked up on X-ray or a CT scan. Okay, only 10% are radio opaque. Radio opaque means the ones which appear white on X-ray. Okay. So usually investigation of choice is ultrasound abdomen, and on ultrasound abdomen I am able to see there is a stone, and usually all the sound waves which are coming from the ultrasound, all these are reflected by the stone. Because it is hard, no waves is able to pass back. Okay, and therefore behind the stone I am able to see a shadow. This is what is called as a posterior acoustic shadowing. This is what is called as the posterior acoustic shadowing, and this will help you differentiate a gallstone from a gallbladder polyp. Okay, how? Please remember, in a case of gallstone, posterior acoustic shadowing is present, but in a case of gallbladder polyp, the posterior acoustic shadowing will be absent. It will be absent. That's the important thing. Next is if I perform a CECT abdomen. If I perform a CECT abdomen in a case of gallstone, that is not generally required. I've told you most of the gallstones will appear black on the CT, right? Here also it is appearing black. Then I am able to see this classical sign. And what is this sign called as? This is the classical Mercedes-Benz sign. Yes, Mercedes-Benz sign can be seen on a CT in a case of cholelithiasis or gallstones. Okay, so that is important. No issues till anybody? What is the treatment? Definitely, once you have made a diagnosis of gallstones, if the patient is asymptomatic and the patient is having no problem, definitely leave the gallstones as it is. But if there are multiple gallstones in the gallbladder, first indication. Second, if the patient is a Salmonella typhi carrier. Yes, if the patient is a Salmonella typhi carrier. Third, if the patient is having a gallbladder polyp along with gallstones. If a patient is having a gallbladder polyp along with gallstones. Or if the patient is having this kind of a gallbladder with gallstones in it. If a patient is having this kind of a gallbladder with gallstones in it. What is this kind of a gallbladder called as? You can see the gallbladder is calcified or around. This calcified gallbladder is known as the porcelain gallbladder. So all of these are indications of, or if the gallstone is more than 2 centimeters in size, that is a large gallstone. All of these are indications of surgery or surgical intervention. And the surgical intervention we know, usually we perform a lap chole. What is a lap chole? Laparoscopic cholecystectomy. Okay, lap chole is nothing else but laparoscopic cholecystectomy. That's important. And after a lap chole, one of the complications which can arise, which was a previous year question, the patient can have right shoulder tip pain. Why the patient has a right shoulder tip pain? Because after a laparoscopic cholecystectomy, which was the gas used for creating pneumoperitoneum during a laparoscopic surgery, we know it was the carbon dioxide gas. After the surgery, we remove all the carbon dioxide gas. But in case some of the carbon dioxide gas was left behind and it went beneath the right dome of the diaphragm, and beneath the right dome of diaphragm it was irritating the diaphragm. As the diaphragm is irritated, what is the nerve supply of diaphragm? Phrenic nerve. So the phrenic nerve is also irritated. What is the root value? C3, C4, C5. Therefore the same root value also supplies the shoulder. Therefore the patient experiences the right shoulder tip pain. Okay, so it is due to the retained CO2 gas beneath the right dome of diaphragm that irritates the phrenic nerve. Okay, then this, what I told you, what is this CCT showing us? It is showing us a calcified gallbladder, and this was an August exam question. This is what is called as a porcelain gallbladder. This is known as the porcelain gallbladder. And why porcelain gallbladder is important? Because porcelain gallbladder has high risk of malignancy. It can, most of the times it can progress into a gallbladder cancer. Most of the cases of porcelain gallbladder will further progress into gallbladder cancer, and that is the reason why here we need to go for a laparoscopic cholecystectomy. If a patient is diagnosed with porcelain gallbladder, don't leave it like that. Please remove that gallbladder, because there will be high chance of risk gallbladder cancer. No issues with this, anybody? Then important next one is this. What is this? You can see over here, it is again a benign condition of the gallbladder. Okay, this kind of a gallbladder, please tell me now. This looks like which fruit and what is the diagnosis? Now this you should tell me. Chalo. Easy, eh? A red base with yellow spots on it. Which fruit it looks like? And this gallbladder is known as what? This condition is known as what? Let me know that. Next, if I talk about one condition which is called as gallstone ileus. What do I mean by gallstone ileus? So ileus means intestinal obstruction over here. Okay. Ileus means intestinal obstruction. Paralytic ileus I told you, right? So just like that, here ileus also means intestinal obstruction. But why there is an intestinal obstruction? Because there is a stone, a gallstone, which is causing obstruction in the intestine. How this gallstone came into the intestine? So as I've already told you, gallbladder, cystic duct connecting with common bile duct. Common bile duct opens into the duodenum. Okay. So now this was the connection which was there. Okay, it was the connection. This was the connection which was there. Sometimes it can come via this route, but most of the times via this route it gets obstructed. So therefore what happens? Now in this condition, the gallbladder of the patient is inflamed. Okay, the gallbladder of the patient is inflamed, and when it is inflamed, it gets stuck to the duodenum. And then there is a fistula which is formed between the duodenum and the gallbladder. Via this fistula, the gallstone, okay, via this fistula, the gallstone goes into the duodenum, and then it goes till the ileum. And then it causes obstruction in the level of ileum. Then it causes obstruction at the level of the ileum. Please remember. Okay, so that is what is case of gallstone ileus. That is what is the case of gallstone ileus. Okay. In gallstone ileus, there is a classical cholecystoduodenal fistula which is formed. Okay, so it is the cholecystoduodenal fistula which is formed, due to which the gallstone escapes into the intestine and blocks the intestine, causing obstruction. There is a classical triad in this gallstone ileus, and that is called as the regular triad. The classical triad in the gallstone ileus is known as regular triad. There are three important features. Now, as there is a fistula which is formed between the duodenum and the gallbladder, we know what is present inside the duodenum. We have air inside the duodenum. So that air will go inside the gallbladder also, and therefore the air inside gallbladder will appear black, and that is what is seen over here. That is the first part of the triad known as pneumobilia. Pneumo means air, bilia means bile or usually the gallbladder. Pneumobilia is usually seen, so you can see a black gallbladder, pneumobilia. Second part of the triad, as I've told you, that gallstone is causing obstruction in the terminal part of ileum, and therefore the patient will have features of small bowel obstruction on a CECT abdomen. And these features of small bowel obstruction are nothing but, you can see these. What are these? Multiple air fluid levels. What did I tell you? In cases of intestinal obstruction, we are able to see multiple air fluid levels. So these are the second feature that is seen. And the third feature which is there, okay, third feature which is there definitely is a gallstone which can be seen at times. Okay, sometimes it can be radio opaque also, na? So sometimes a gallstone can be seen in the right iliac fossa, usually in the terminal ileum in the patient on a CT scan as well. Okay, so that is what is the classical triad of regulars, which is positive in cases of gallstone ileus in the patient. Okay, so that is what is done. Treatment may definitely what should be done, as the patient is having gallstone ileus, we need to first go for a conservative management, because we are not sure na initially if the patient is having intestinal obstruction due to what reason. So definitely initially we go for a conservative management. Then once you get to know, okay, so this the cause behind this is usually a gallstone ileus. The cause behind this intestinal obstruction is the gallstone ileus. Then definitely I will go for stone removal. Okay, I will perform an enterotomy, and then I'll go for a stone removal in the patient. And definitely, as the gallbladder has formed a fistula, we also need to remove the gallbladder in most of the cases. That is, a cholecystectomy is also done in the patient. Okay. Now, yes, a lot of you have answered it right. You can see this gallbladder looks like a fruit, and that is nothing but strawberry. So this is what is called as the strawberry gallbladder. And strawberry gallbladder is due to what? All these yellow spots which are seen now, these are nothing but cholesterol deposits on the wall of gallbladder. So as I've told you, if the bile contains high amount of cholesterol, so these cholesterol will start depositing on the wall of gallbladder, and that forms this condition called as cholecystinosis. Okay, so this condition is what is called as cholecystinosis of gallbladder. Okay, this is what is a cholecystinosis of gallbladder, which is generally seen. No issues with this. This is a previous year question and a very classical image. That's important. Next, if I talk about if the gallbladder gets obstructed at the level of the neck, if the gallbladder gets obstructed at the level of the neck or at the Hartmann's pouch, what will happen? The bile will remain inside the gallbladder, the mucus will remain inside the gallbladder, and this gallbladder will become dilated. And definitely, what will happen? This bile or the mucus, okay, it is collected at a site, okay, it is not able to move, therefore it will get infected. And that is the reason why it will cause inflammation of your gallbladder as well. And inflammation of your gallbladder is known as acute cholecystitis. Okay, so inflammation of a gallbladder. So one of the complications of gallstone, apart from gallstone ileus, The second complication, or rather the most common complication, can be acute cholecystitis as well. Okay, a lot of times the patient comes to an emergency. Okay, the patient comes to an emergency with pain in the right hypochondrium. The patient has fever. The patient has nausea, vomiting, all of these other features. That is a case of acute cholecystitis. Okay. So usually if the stone obstructs at the level of the Hartmann's pouch, then definitely it is a case of Mersey syndrome. Please remember, but in Mersey syndrome, the patient will not have so severe signs and symptoms of cholecystitis. Okay? And in cholecystitis, along with all the symptoms, on examination, there is a classical sign which is seen. When I try to palpate the right hypochondrium of this patient, the patient has a lot of pain, and therefore the patient will catch his breath. Okay, so when patient catches breath due to a lot of pain, that is called as a Murphy's sign. So usually we will get the Murphy's sign. Okay, we will classically get the Murphy's sign in a case of, please remember, we will classically get the Murphy's sign in a case of acute cholecystitis. What is the investigation of choice? Now there's a lot of problem over here. Though the books are very clear about this, acute cholecystitis, the investigation of choice is always a ultrasound abdomen. Okay, investigation of choice for acute cholecystitis is always a ultrasound abdomen. But if they ask you the gold standard investigation, then the best investigation is a HIDA scan. Okay, the best investigation is a HIDA scan. But if they ask you the investigation of choice, answer is straight away ultrasound abdomen. Treatment is what? Usually in this condition, treatment is conservative management. Yes. When the gallbladder is inflamed, don't try to remove it immediately. Wait for some time. Treatment is conservative management. NPO, keep the patient nil per oral, give IV fluids, IV antibiotics and analgesics to the patient. Once the patient's condition improves, then definitely you will discharge the patient, keep the patient on antibiotics for a while and call the patient after 6 weeks for an interval cholecystectomy. Okay, for an interval cholecystectomy. That has to be done. Okay, so usually an interval cholecystectomy has to be done. Right, lab collates. Usually after 6 weeks. But if the patient's condition deteriorates or worsens, then sometimes you also need to perform an emergency cholecystectomy also. Okay, so that is important. Next, this was the image in August 2020 examination, and this you can see is a gallbladder. And the options were whether it is a gallbladder polyp or it is any other thing. Okay, so please remember, it is not a gallbladder polyp, because a gallbladder polyp will be something like this. Only one growth, okay, like a polyp will be seen. But here you can see the gallbladder is completely damaged. Okay, the gallbladder wall is completely damaged and there is a complete mass which is present throughout the gallbladder. So this was a case of gallbladder cancer. It was a case of gallbladder malignancy or gallbladder cancer. That you need to remember, guys. Okay, so please remember that. What happened? Gallbladder emergency cholecystectomy is usually done if the patient presents to you within 48 hours of symptom onset. So if the patient presents to you within 48 hours, there is minimal infection. So you can go for an emergency cholecystectomy. But if the patient presents to you after 48 hours, then the infection might have spread a lot. Then only go for conservative management and wait for 6 weeks for the infection to resolve now, and then go for a interval laparoscopic cholecystectomy. No issues till here, anybody? So that's important. If I talk about gallbladder cancer, so please remember, gallbladder is also lined by columnar epithelium. So here also the cancer which arises from gallbladder will be a adenocarcinoma. That's important. Okay. Important is that the gallbladder cancer will have a very poor prognosis. The outcome of the cancer, जो patient है ना वो ज़्यादा टाइम तक जिंदा नहीं रह पाता. There's a very poor prognosis in a case of gallbladder cancer. Please remember that. If I talk about gallbladder cancer, the patient will have chronic weight loss. The patient will have jaundice due to cholestasis. The patient will have a lot of jaundice as well. Okay, so all of these features will be seen. If I talk about investigation of choice, just like all other cancers, here also due to the risk of spread of the cancer, the investigation of choice is a CECT abdomen. Cancer फैल सकता है अगर तुमने biopsy ली. So it's better to go for a CECT abdomen in a case of gallbladder cancer. If I talk about treatment in the patient, then what should be the treatment in a case of gallbladder cancer? So if it is a T1A staging, what do I mean by T1A? That means when the cancer is above the muscle layer. Definitely I can go for a radical cholecystectomy. Okay, I can go for a radical cholecystectomy. Okay, but when the cancer, when the cancer is usually But if the cancer is usually in the T1B stage or the T2 stage, when the cancer is in the T1B or the T2 stage, I need to go for a radical cholecystectomy. But followed by that, I need to give chemotherapy or radiotherapy to the patient. And if the cancer is beyond T2, that means T3, then the patient is only managed on palliative care or chemotherapy. Moving further, as I've already spoken about this diagnosis over here. Okay, this I've already spoken about. A patient presents to you with sudden onset. There is a sudden onset right upper quadrant or a right hypochondrial pain. There is fever, there is nausea, and there is vomiting in the patient. The sign given below is elicited. So the sign given below is positive. I've already told you on deep palpation when the patient will catch breath due to pain. That is known as the Murphy sign. It is usually positive. It is definitely suggestive. Please remember, it is definitely suggestive of acute cholecystitis. Diagnosis is usually made by investigation of choice being ultrasound abdomen, and the gold standard investigation is a HIDA scan. Okay, so that's the important thing usually. Okay. Treatment I've already told you. Conservative management. If the patient's condition improves, definitely discharge the patient on antibiotics. Call the patient after 6 weeks for an interval cholecystectomy. Okay, that's important. Next, if I talk about this condition, what is this condition? You can see this is a CECT abdomen, and on the CECT abdomen, I'm able to see a blackish appearance around the gallbladder. I'm able to see a blackish appearance in the gallbladder or around the gallbladder. This is what is a case of emphysematous cholecystitis. What do I mean by emphysematous? Emphysematous का मतलब होता है usually when there is production of gas or when there is presence of air. Okay, so this is cholecystitis. That means inflammation of the gallbladder. But when there is production of gas in an infection of gallbladder, that is called as the emphysematous cholecystitis. Important is emphysematous cholecystitis ka most common cause is what? The most common cause for this is usually an organism which mostly produces gas and which was also responsible for gas gangrene, and that is nothing else but your Clostridium perfringens, previously called as Clostridium velkai. It is known as Clostridium perfringens, also known as Clostridium velkai. Please remember that. Okay. Investigation of choice is usually a ultrasound or a CCT. Investigation of choice is ultrasound or CCT. Better is definitely CCT because air can be easily picked up on a CCT abdomen. So single best answer is CCT. If I talk about the treatment over here is always an emergency cholecystectomy. Okay, so treatment over here is definitely a emergency cholecystectomy that has to be done. Please remember, gallbladder cancer has the same tumor marker as pancreatic cancer. It is CA19-9. It is CA19-9. ठीक है, चलो आगे बढ़ते हैं. Now talking about this condition, what is seen over here? We have a neonate who has progressive jaundice at birth. Okay, so we have a neonate who is having progressive jaundice at birth, and there are pale stools. LFT shows, LFT, that is liver function test, shows there are raised ALP level. What is ALP? Alkaline phosphatase levels are elevated. What is the investigation of choice? What is your likely diagnosis, guys? Just make a diagnosis for this case for me. A neonate is brought to me. Navjat Shishu लाया गया है मेरे पास, and he is having progressive jaundice. The jaundice is increasing only, it is not decreasing, and the jaundice was present at birth. We know if the jaundice is present on day 1 of life, or if the jaundice persists even after 2 to 3 weeks of life, definitely it is suggestive of a pathological jaundice. So here the child is having pathological jaundice, and the child is having pale colored stools. So pale stools or a dark urine. Okay, either pale stools or a dark urine. Definitely they are suggestive of which kind of jaundice? They are classically suggestive of a conjugated jaundice. That means which bilirubin is mainly elevated? Definitely the conjugated or the direct bilirubin is mainly elevated. So it is a case of conjugated hyperbilirubinemia. It is a case of conjugated hyperbilirubinemia. And LFT is also showing raised ALP. I hope all of you are quite aware. This ALP which is there, that is alkaline phosphatase which is there. This alkaline phosphatase is a marker of some problem in the bile ducts or the biliary tree. Please remember ALT and AST which were there. ALT and AST, they are markers of liver diseases. These are markers of liver diseases. But please remember ALP is usually a marker of. ALP is usually a marker of. Okay, ALP is usually a marker of that you need to remember any bile duct problem, any bile duct pathologies or bile duct obstruction usually. Okay, bile duct obstruction ka marker. Now, important is, please remember what is your Likely diagnosis and investigation of choice. So please remember here, the likely diagnosis is the patients, the neonate which is there, the child who is born, he is not having a bile duct. Okay, the bile ducts of this child have not been developed. Okay, and that condition where the bile ducts of the child have not been developed is known as biliary atresia. What did I tell you about atresia? Atresia का मतलब होता है absence. So biliary atresia, that means there is absence or no development of the bile duct or the biliary tree in this patient. So biliary atresia, if I talk about, please remember biliary atresia is of three types mainly. Type 1 biliary atresia, there is absence of common bile duct. Type 1 biliary atresia, there is absence of common bile duct. Type 2 biliary atresia, there is absence of common hepatic duct. Type 2 biliary atresia, there is absence of common hepatic duct. And type 3 biliary atresia, there is absence of the right and the left hepatic ducts. Okay. Type 3 biliary atresia, there is absence of the right and the left hepatic ducts. If they ask you which is the most common type of biliary atresia, the most common type of biliary atresia is usually type 1. The most common type of biliary atresia is usually type 1 biliary atresia. Okay. So that's the basic thing. So if the bile ducts are not formed, will the bile be able to drain? No, the bile is not able to drain. If all the bile will stay in the gallbladder, it will stay in these ducts and it will finally stay in the liver. If there is excess of bile over here, this bile will be excreted out in the blood and there will be excess of bile in the blood. That is called as hyperbilirubinemia definitely. And that is what is jaundice. So here in this child, as the bile ducts are not formed, there is cholestasis and therefore a lot of bile is collected that goes into the blood and that leads to jaundice in the patient. Okay, so that's important. Now biliary atresia, as I've told you, neonate presenting to you with progressive jaundice, pale stools or dark color urine at birth, suggest you of conjugated hyperbilirubinemia is definitely, and a raised ALP is definitely making you a diagnosis of biliary atresia. Investigation of choice, as they have asked. Investigation of choice is a HIDA scan over here. Okay, investigation of choice is a HIDA scan. What is HIDA? Hepatic immunodiacetic acid scan. Okay, so HIDA is a nuclear scan, hepatic immunodiacetic acid scan. Then if I talk about the treatment in a case of biliary atresia, the most common, that is type 1 biliary atresia. Here, what is not formed? The common bile duct is not formed. So we need to drain the bile into the intestines so that it mixes up with food and it helps in absorption of food. So bring the intestine over here. So we will bring which part of the intestine? Vela dos tumhara, that is jejunum. So bring the intestine over here, that is the jejunum over here, and attach it to the common hepatic duct. And what is this called as? Definitely we know it is known as hepatico-jejunostomy, and this is known as rho and Y, hepatico-jejunostomy. So type 1 biliary atresia, we will go for a rho and Y. Hepatico-jejunostomy. But for type 2 and type 3 biliary atresia, definitely we cannot go for this surgery in that condition. Please remember, for that condition definitely we need to go for what? Definitely in that condition where the common hepatic duct is also not present or the right and left hepatic duct is also not present, we are directly attaching the jejunum to the liver. And that is what is called as, please remember, that is what is known as portoenterostomy, and that portoenterostomy is also known as Kasai procedure. Okay, that is what is known as Kasai procedure or portoenterostomy. So please remember, portoenterostomy or Kasai procedure is the treatment of choice for type 2 and type 3 biliary atresia. That's important. Okay, so if they say, guys, what is the investigation of choice or the best investigation for a intrahepatic atresia? That means if the bile ducts are not formed within the liver, bahar ki to theek hai, okay, the outside bile ducts are absolutely fine, but the bile ducts within the liver are not formed, then definitely the investigation of choice should be a liver biopsy. If the bile ducts within the liver are not formed, they will not be visible properly on a HIDA scan. Therefore, there we will need to go for a liver biopsy. And if there is an intrahepatic atresia, then definitely we need to go for a liver transplant as well. Then we need to go for a liver transplant in treatment. Okay? That has to be remembered. Next is this one. What is this investigation? Jaldi se batao. Both the investigation number 1 and 2. Please tell me both the investigation. Both are previous year questions. What are these two investigations over here? Please let me know. What are these two investigations over here? Shabash. The first investigation. The first investigation that you have is definitely a ERCP. And what is a ERCP? We know now. It is nothing but endoscopic retrograde cholangiopancreaticography. So we are inserting an endoscope. We are going from oral cavity, esophagus, stomach, duodenum. Second part of duodenum, we have the ampulla of Vater. So when we turn the endoscope now, laterally we see the main pancreatic duct opening, and we also see the common bile duct opening. So we need to turn the endoscope, okay, to go inside the duct. See, this is the main pancreatic duct and this is the common bile duct. Okay, so this is what is the cystic duct, this is the common hepatic duct. All of this is seen now. So please remember, definitely this is what is the ERCP. Why ERCP only? Because you are able to see the endoscope. And how you are able to see endoscope? You can see the camera is turned in behind. Okay, the camera is turned behind usually. So if the camera turns backwards, this is called as retrograde. इसीलिए endoscopic retrograde cholangiopancreaticography. That is what is important to be remembered. Okay, so that is what is done. If you see the endoscope, it is ERCP. If you only see the bile ducts from outside, okay, that is a MRCP. Therefore, MRCP is a non-invasive investigation. You will be only able to see the biliary tree from outside. Okay, so you will be only able to see this biliary tree from outside. That is what is a MRCP. Please remember. So you will say, sir, MRCP पे कैसे दिखेगा? Because we will perform a T2 weighted MRI, and I hope all of you are quite aware. T2 weighted MRI पे the water appears white. Any kind of fluid on a T2 weighted MRI will appear white. Therefore, the bile also appears white on a T2 weighted MRI, and therefore these bile ducts are highlighted because they contain bile inside them. Okay, therefore, if the bile ducts are having bile inside them, that will appear white in color, and that is the reason why we can see the whole biliary tree. So therefore we don't need to insert any endoscope, we don't need to give any diet to the patient. Therefore it is a non-invasive investigation. Next is the second one. This image came, you can see there is a T tube which is inserted over here. This is the bile duct, common bile duct, and this is the T tube which is inserted in the patient. Okay, this is the T tube. So once you have repaired the bile duct, please remember, once you have repaired the bile duct of the patient, so that to avoid any injury to the bile duct again, for some time you will insert this T tube. Now see, there was a bile duct injury, you have anastomosed the bile duct injury, okay? But now if bile starts flowing via this, what will happen? These sutures will come off. These sutures will come off. That is the reason for some time you insert a T tube, so that the bile will keep on flowing via this T tube. Okay, once the sutures are fine, once the sutures are healed, then definitely we can remove the T tube. Okay, so that is what is done. So you can see the T tube in this investigation, and this is what is the X-ray. So this is a case of T tube cholangiogram. This investigation is known as a T tube cholangiogram. Cholangio matlab bile ducts or biliary tree, and uska picture is known as gram. So T tube cholangiogram. No issues with this, anybody? Next important one, as you will see over here, is this one. And what is this? This is a case of choledochal cyst. Choledocho, that means choledocho का मतलब होता है bile duct. So if there is a cyst which is formed in the bile duct, it is known as a choledochal cyst. Okay, so choledochal cyst. If I talk about choledochal cyst, definitely, please remember, it is nothing but a cyst or a sac which is formed in the bile duct, and therefore what will happen? The bile will not be able to drain. It will keep on collecting over here, and that will cause cholestasis and leading to jaundice in the patient. Usually this is congenital most of the times, like most of the conditions are congenital only. Okay, it does not rarely forms after birth. If I talk about the classification which is used for choledochal cyst, that has been asked in your exam, so please remember the name also and the types also, because type has been given and asked which type of Todani classification is this. So please remember the classification used for choledochal cyst is known as Todani's classification, and according to Todani's classification, the choledochal cyst is classified into 5 types. Okay, so type 1 which is there, you can see it is nothing but a single extrahepatic cyst. Okay, it is nothing but a single extrahepatic cyst in the common bile duct. Okay, so it is a CBD cyst which is there, that is a type 1 choledochal cyst. Type 2 which is there, it is nothing. Here you cannot see a cyst or a dilatation of the duct, rather you will see a outpouching from a duct. And what is the outpouching from a duct called as? Diverticulum. So type 2 is nothing but a extrahepatic diverticulum. Outside the liver, there is a diverticula which is formed. Type 3 is what? When the common bile duct opens into the duodenum, at that part, when the common bile duct opens up into the duodenum, at that part there is a dilatation or a cyst which is formed. That is called as a choledococele. That is what is known as the choledococele. Okay? So when the intraduodenal portion of CBD undergoes dilatation, that is a type 3 Tudani or a choledococele. Type 4A now. Type 4A, there will be multiple extrahepatics as well as intrahepatic cyst. So if there are extrahepatic cyst as well as intrahepatic cyst, that is a type 4A. Type 4B is what? Type 4B mein there will be multiple extrahepatic cysts only. If there are multiple extrahepatic cysts only outside the liver, then that is the case of type 4B. Type 5 is what? Type 5 mein there will be multiple, but all of them are intrahepatic cysts. Type 5 is multiple intrahepatic cysts only, and multiple intrahepatic cysts only, that is type 5 Tudani. It is also known as which disease? It is also known as Caroli's disease. Please remember, it is also known as Caroli's disease. That you need to remember. Okay? If I talk about choledochal cyst, how the patient is going to present to me? The patient will present to me with usually a classical triad. And what is that classical triad called as? That classical triad is definitely known as choledochal triad. That classical triad is what is called as choledochal triad. And what are the three important features of choledochal triad? It is similar to the Charcot's triad that we'll see in cholangitis. Okay, one feature is different. So as the patient is having a cyst, that causes pain. Second, as there is a cyst now, so when you palpate, you can feel a lump or a mass. So the second feature can be a lump or a mass. And the third part of the triad is usually jaundice. As I've told you, bile is not able to drain. It will keep on collecting in the cyst, and that will cause cholestasis and finally jaundice in the patient. So pain, mass and jaundice is what is the classical choledochal triad in the patient. Okay? So that is what is important to be remembered. Now what is the investigation of choice? If I talk about the investigation of choice in a case of choledochal cyst, usually it is a problem where? It is the problem in the bile ducts. And what was the better investigation for a bile duct? Either it was a MRCP or it was a ERCP. Now both of them, one is non-invasive, the other one is invasive. And we know the investigations of choice are usually non-invasive in nature. So in most of the condition, here we will prefer a MRCP. Here we can prefer a MRCP, magnetic resonance cholangiopancreaticography. Okay? But in some conditions, definitely we can also prefer a ERCP. Some conditions we can prefer a ERCP also. Because if MRCP does not show a proper cyst, then you need to go for a ERCP as well. If they ask you about the treatment, now somebody of you will tell me, okay, some people among you will tell me this one, okay, what is the investigation of choice for type 4A and for type 5? What is the investigation of choice for type 4A and type 5 choledochal cyst? Okay, so definitely for type 4A and type 5 choledochal cyst, what is the investigation of choice? इन दोनों के लिए बता दो. Type 4A and type 5 choledochal cyst, the investigation of choice will be what? Answer it in the chat box. Till that I'll talk about the treatment. Okay, till that I'll talk about the treatment. If it is a type 1 choledochal cyst, okay, type 1 choledochal cyst was what? There was only a cyst in the common bile duct. So remove the common bile duct, again bring your vela dos and connect it over there. That is nothing but your Roux-en-Y hepaticojejunostomy. That is nothing but Roux-en-Y hepaticojejunostomy. If I talk about type 2, what was type 2 usually? In type 2, definitely there was an extrahepatic diverticulum. So definitely just cut that diverticulum and repair the common bile duct. Okay, just cut the diverticulum or the outpouching and repair your CBD. Repair your common bile duct. Okay, repair your common bile duct. Next important, what is to be done for type 3? I write over here. What is to be done for type 3? Type 3 was what? The intraduodenal portion of CBD was dilated. Therefore, just go with the help of an ERCP and open it up properly. That is sphincterotomy. So ERCP with sphincterotomy should be done for type 3. What is done for type 4 now? For type 4 choledochal cyst, definitely if I talk about type 4, I will talk about type 4B first. For type 4B cyst, okay, for type 4B choledochal cyst, definitely what is the treatment now? For type 4B choledochal cyst, important is, here again I need to remove the, Here again, I need to remove the common bile duct or the hepatic duct also, because there are multiple extra hepatic cysts. So outside the liver, I need to remove the whole biliary tree. So if I am removing the whole biliary tree, I will bring your vela dose and I will join it to the liver directly. And what was that procedure called as? That procedure was nothing else but your Kasai procedure, right? That procedure was nothing but your Kasai procedure, where you were performing a direct portoenterostomy. You were performing a direct portoenterostomy. Okay? Direct connection between liver, not the hepatic duct. Direct connection between the liver and the intestine. Okay? If I talk about type 5, that is Caroli's disease, or type 4A, in both of this, what is common? In both of this, intrahepatic cysts are common. In both of this, intrahepatic cysts are common. If intrahepatic cysts are common, so definitely the investigation of choice for both of them cannot be MRCP or ERCP. It has to be liver biopsy. What did I tell you? If intrahepatic cysts are there, intrahepatic duct ka problem hai, then we need to take a liver biopsy itself. And the treatment also will be what? The treatment will also be liver transplant. The treatment will also be liver transplant in this condition. Okay? So that is important to be remembered. Because they are having intrahepatic cyst, the treatment of choice for type 4A and type 5 should be liver transplantation. Okay? Next, if I talk about choledocholithiasis. So chole is nothing but bile. Doco matlab liver, doco matlab duct, and lith matlab stone. So choledocholithiasis means stones in the bile duct. Choledocholithiasis is nothing but stones in the common bile duct, definitely. Or it can be in the biliary tree, anywhere, usually in the common bile duct. Okay, so definitely, just a minute. Sorry. If there is a stone in the common bile duct, what will happen? The bile is not able to drain, and as the bile is not able to drain, definitely it will keep on collecting in the bile ducts here itself. And if it keeps on collecting over here itself, that will cause cholestasis. And when there is cholestasis, that will further progress to jaundice. And this bile is not able to move, therefore it is collected over here. And if the bile remains stagnant, एक ही जगह पे जमा रहेगी, so what will happen? There will be high chance of infection. And infection of the biliary tree or infection of the bile duct is what is called as cholangitis. Infection of the biliary tree or infection of bile duct is known as cholangitis. So due to choledocholithiasis, the patient develops cholangitis. And cholangitis mein, I have told you there is a classical triad. What is that classical triad known as? Charcot's triad. Okay, it is the Charcot's triad which is seen. In Charcot's triad, the two features remain same. The patient will have pain also because there is infection. The patient will have jaundice also because there is obstruction. But here there is no mass, no cyst, so no mass. So one feature which differs from a choledochal triad will be fever. As the patient is having infection, the patient will have fever. So pain, fever and jaundice makes a classical Charcot's triad. Please remember, it makes the classical Charcot's triad. Important is, if we add two more features to it, it becomes the Reynolds pentad. And what are these two important features which are added to the Charcot's triad? Please let me know that. Okay. If I add two important features to the Charcot's triad, it becomes the Reynolds pentad. What are these two important features which are there? Okay, treatment is easy for a choledocholithiasis when there is a stone in the bile duct. Go for what? Definitely investigation of choice. Please remember, investigation of choice over here can be a MRCP. But if you need to perform a ERCP, ERCP is the gold standard investigation. ERCP will be the gold standard investigation. Investigation of choice will be MRCP, but ERCP will be the gold standard investigation because it will also help you in treatment itself. Okay, so please remember, treatment के लिए क्या करते हो? Treatment के लिए definitely go by ERCP, and once you go by ERCP with the help of an endoscope to the bile duct, then definitely remove the stone, and that is what is called as CBD stone extraction. CBD stone extraction, and for that you generally use a Dormia basket. Okay, so Dormia basket is used for removal of this CBD stone, definitely. Okay, very good. Charcot's triad along with the features of hypotension or shock. Okay, Charcot's triad along with features of hypotension or shock. Okay, and definitely mental obtundation or mental confusion. These five features makes up the Reynolds pentad. So Reynolds pentad is nothing but pain, fever, jaundice, that is Charcot's triad, plus hypotension or shock along with mental confusion or mental obtundation in the patient. Very good. Now talking about bile duct injury. If I talk about bile duct injury, oh, this question has become a very common question during your examination nowadays. The reason is if we are performing a ERCP procedure. So while performing ERCP procedure, there can be high risk of injury to the bile duct. Okay, or even while performing other surgeries, there can be high risk of injury to the bile duct, and therefore it has been commonly asked nowadays. So please remember this. I have just compiled all of it in single table. Okay, so if I talk about bile duct injury, if the bile duct injury was seen during surgery, if the bile duct injury occurs during surgery itself. Okay, so I'll just write bile duct injury. If the bile duct injury occurs during surgery, then you need to see whether it is a partial injury like this or it is a complete transaction. So if it is a partial injury, just go for immediate repair. Okay, if it is a partial injury, just go for an immediate repair, because the patient is in front of you. The patient is open in front of you. You are performing a surgery. So if there is a partial injury, just go for an immediate repair. If there is a complete transaction, what do I mean by complete transaction? That means a complete cut in the common bile duct. There was a complete cut to the common bile duct. Okay, not a partial, but a complete cut to the common bile duct. That is a complete transaction. Then you need to see that whether some part of the bile segment is lost or not. So if there is no loss of segment, that means there is only a cut. You can see there is only a cut. There is no loss of segment as such. Then here definitely you will perform an anastomosis. But what did I tell you? When you perform an anastomosis or a repair over here, there will be high chances. If the bile comes in contact, the sutures will come off. That's the reason why you will perform an anastomosis, but you will insert a T-tube also. Okay, you will insert a T-tube. So here you need to go for an anastomosis over a T-tube. You will perform an anastomosis over a T-tube. Okay? And then you take an X-ray, you can see that T-tube cholangiogram. Okay? After few days, the T-tube has to be removed. Okay? Next is, if there is a loss of segment, that means now there is complete injury to the bile duct and some part is also missing. Some part of the bile duct is also missing. So if there is a loss of segment, guys, then remove this distal part. Bring up your vela dos and connect it to the remaining part of the common bile duct. Connect it to the remaining part of your common bile duct. And this is what is called as, what do we call this procedure? Definitely this is what is known as hepatico-jejunostomy. Also known as Roux-en-Y hepatico-jejunostomy. Okay. So it is what is called as, I'll just write properly. It is known as a Roux-en-Y. Okay, so Roux-en-Y hepatico-jejunostomy has to be done if some part of the bile duct is missing. Next, if the patient comes to you with a bile duct injury after surgery, and what will happen if the patient is having a bile duct injury after surgery? So after surgery, if there is a bile duct injury, that will cause a leak. So that has been a common question again in your FMG examination. So if a patient is having a minor leak after surgery, minor leak of bile, okay, so minor leak in the bile duct, if there is, the patient will not have any kind of sepsis, no infection, the patient will also be stable. Then in this condition, no intervention is required. If there is a minor leak now, it will repair on its own, it will heal on its own. No intervention is required. But if there is a major leak, you need to see now what is the site of leak. So if a patient is showing features of sepsis usually, okay, if a patient is showing features of sepsis or the patient becomes unstable usually after surgery, then you will suspect, okay, the patient might be having a chance of bile leak after surgery. And in that condition, you will see the bile leak. And for seeing bile leak, definitely, I've told you, the better investigations to see the biliary tree will be either the MRCP or the ERCP. So with the help of an MRCP or ERCP, you will be able to see the bile duct injury. And once you see the bile duct injury, then you will see whether the patient has come to you within 48 hours. That means if you have picked up the bile duct leak within a span of 48 hours, then definitely you need to go for what? If you have picked up within 48 hours, then you will take the patient again to the OT. You will take the patient again to the OT. You will go for a re-exploration. And you will perform an anastomosis. You will go for a re-exploration and anastomosis, or I will say repair. According to the problem, you will perform a repair. Whereas if I talk about if the patient is presenting to you after 2 days of surgery, presenting to you after 2 days, that means now the bile leak has happened a lot. The patient might be in sepsis, the patient might have peritonitis, all of these features. So in this condition, only go for a ERCP plus stenting. Definitely, if there is peritonitis vagara, you need to go for a exploratory laparotomy then. Okay, but otherwise, you just go for a ERCP plus stenting in the patient. Okay, so these are the usual things that we do for a bile duct injury or a bile leak after surgery. So please let me know now whether you wish to continue now immediately or you need to take a break. If you wish to take a break, then definitely we can take a break now and then we can start with urology. There will be 9 slides which are left, but in urology there will be a lot of small image based questions. Please let me know faster comment section so you can plan accordingly. Okay, great. If all want to continue, let's continue further. Okay, then in middle we will take a break, small break. Okay, sure. Now talking about sorry. So what majority says, let's do some topics and then take a longer break of 10 to 15 minutes. No issues with that. Let's continue with some topics and then take a longer break. ठीक है, थोड़ा सा चलो. Okay, now talking about urology. Okay, so study of the genitourinary system is what is urology. Definitely, please remember, if I talk about urology, important things we will be discussing. Okay, urology means definitely kidneys, which are responsible for production of urine. Then they drain the urine into the ureters. This one pair of ureter brings the urine into the urinary bladder, which is a sac that holds urine, and then the urine is excreted out via the urethra. Okay, so that's the basic anatomy. I hope all of you are quite aware of it. So the first one that is there, this one, as you can see over here, it is a case of congenital anomaly of the kidney, and this congenital anomaly of the kidney which is there is known as what? This is what is called as the horseshoe kidney. It is a case of horseshoe kidney. So what is a horseshoe kidney? I hope all of you are quite aware of horseshoe kidneys. Horseshoe shape looks like this. It looks like a U now. So here also what happens? The kidneys are not in their original position. What is the original position of the kidneys? Kidneys का original position होता है usually T12 to L3. The normal position of usually kidneys, it is present in the retroperitoneum and it is present at the level of T12 to L3. But here the kidneys are ectopic in position. Okay, they are not at their original sites. They are lying in the midline. Okay, they are lying in the midline of the abdomen, not in the periphery. They are lying in the midline of the abdomen, and in the center they fuse. Okay, the lower poles of the kidneys will fuse together. The lower poles of the kidneys will fuse together, and that forms this U-shaped or the horseshoe shaped of the kidneys. So ectopic pair of kidneys which are fusing in the midline. Okay, with fusion in midline. And the question was, this fusion which occurs, okay, this fusion which occurs, it can be seen as a abdominal swelling also. So this fusion which usually occurs is at what site? It is your what vertebral level? Okay, so most common site of fusion usually. So the most common site of fusion which is seen, it is, please remember, it is L3, L4. But if you need to mark it a single answer, then your answer should be L4. Okay, so please remember it is L3, L4. But if you need to mark it as a single answer, then the answer should be L4. Please remember that. Okay, that has been a previous year question. No issues with this, anybody? So usually horseshoe kidney wala patients are asymptomatic. Sometimes there can be a swelling, but even after that, the patient's urine output and urine production will be normal. Very rarely the patient can have symptoms, and in that conditions also, what will be the symptoms of the patient? The patient can have UTI. There will be higher chances of urinary tract infection because the urine is not able to drain properly. So UTI can be there, or the patient can have high risk of renal stone formation. So in that condition also, we will go for a symptomatic management, not a surgical one. We will go for a symptomatic management of the patient. Okay? Most of the condition, we will not cut the kidneys. We will not cut the kidneys. Next is this condition. What is seen? You can see both the kidneys, and on both the kidneys definitely there are multiple cysts which are formed. What are these cysts? Cysts are nothing but sacs, as I've told you, which contain some amount of fluid inside it. So usually on both the kidneys you are seeing multiple cysts. Multi is called as poly, and many cysts are formed. Where? On the kidney. So usually it is a case of polycystic kidney disease, PCKD what we call it. In cases of polycystic kidney disease, please remember, definitely it can be of two types. The polycystic kidney disease can be of two types. Either it can be the autosomal dominant variety or the autosomal recessive variety. The autosomal recessive variety is known as the infantile variety and it is very rare. Okay, it is known as autosomal recessive is known as infantile variety. It is rare. The patient does not live. Okay, so it is incompatible with life. The patient cannot live. Okay, but the autosomal dominant variety is the more common variety. Here the patient can survive definitely. It is called as congenital variety. Why? Because it is present since birth, or it is also called as an adult variety. You will say, so how? So whether it is called as congenital or adult, so it is called as both. Congenital because it is present since birth, but adult because it will only show symptoms after 30 years of age. The patient will only have symptoms after 30 years of age. And what will be the symptoms? The patient can have hypertension, the patient can have hematuria. The most common symptom and most common cause of death also is hypertension itself. Other symptoms can be hematuria, patient can have UTI, the patient can have a lot of stone formation. Sometimes the patient can have pain as well. Okay? So that is important over here. Investigation of choice, if they ask you, definitely as you can see in the image, it is a CECT abdomen. On CECT abdomen, both the kidneys, we can see there are multiple cysts which are formed. Okay, important is on IVP, that is a intravenous pylography or intravenous urography, which is a contrast study done for your kidneys and the ureters. Okay, so IVP or IVU is the contrast study done for kidneys or ureters. Then cystography or cystogram is the contrast study done for your urinary bladder. Micturating cystogram is also a contrast study done for your bladder. But in micturating cystogram, what is the difference? Here we will ask the patient to micturate or urinate, and then we will take a lot of x-rays. तुम patient को बोलते हो पेशाब करे, and then you will take the x-rays. That is the MCU, micturating cystourethrogram. And then lastly RGU, retrograde urethrogram, is for the urethra. Okay? So IVP over here in case of PCKD will show us the classical spider leg appearance. Here it shows the classical spider leg appearance that is commonly seen. If I talk about, okay, treatment definitely in this patient, if I talk about the treatment of this patient, usually most of the patients are managed by antihypertensive drugs. Most of the patients are just managed by antihypertensive drugs. Definitely a lot of patients might require dialysis as well. A lot of patients might require dialysis, and the best treatment will be renal transplantation. The best treatment will be renal transplantation. Okay? But till that time, manage the patient with antihypertensives and dialysis. If I talk about horseshoe kidney, here the investigation of choice is a CECT. Here the investigation of choice is a CECT. But if I perform a IVP, what is the characteristic sign seen on IVP or IVU in a case of horseshoe kidney? So please remember, this is seen as the hand joining sign or the hand shaking sign. So it is classically known as the hand joining or the hand shaking sign. It is known as the hand joining or the hand shaking sign, or it is also known as flower vase appearance. It is also known as the flower vase appearance. The flower vase appearance, hand joining, hand shaking sign are commonly seen in cases of horseshoe kidneys. Next is important, this one. Okay, what is seen over here? You can see that the lower part of the ureter, which is opening up into the urinary bladder, the part of the ureter which is opening up into the urinary bladder, this part has undergone dilatation. Why this part has undergone dilatation, guys? Because the opening of the ureter into the urinary bladder is very narrow. The opening of the ureter into the urinary bladder is very narrow, and therefore this part has undergone dilatation. This is what is called as a uretrocele. And here you can see it is a bilateral condition. So uretrocele can be bilateral or can be unilateral. Here most of the times it is bilateral. Okay? In the examinations usually. Okay? So if I talk about uretrocele, definitely here you can see important is the patient will not have a lot of features, but yeah, at times the ureters, as you can see, they can undergo dilatation, and that can cause pyelonephritis in the patient. That can be a complication. Here the IVP shows the classical appearance. And what is the classical appearance? You can see a cobra head or a adder head like appearance. So there will be a cobra or a adder head like appearance. There is the characteristic cobra head or a adder head appearance which is seen on a IVP, intravenous pylography or intravenous urography. Treatment is what? As I've told you, the patient will have high chances of urinary tract infections. So treatment is what? Open up this now. So as the patient is having a very narrow opening, just make the opening broad. Just make the opening broad. And that is what is called as, usually an incision is given at the incision at ureteric orifice has to be given. Incision at ureteric opening or ureteric orifice has to be given. Okay, so that is what is considered as the treatment for ureterocele. No issues with this, anybody? Next is this one. What is this? You can see in this condition there is this pelvis, renal pelvis. I hope all of you are quite aware. This is the kidney. Okay, there will be there will be minor calluses in the kidney. These minor calluses will combine to form the major calluses. These major calluses finally combine to form the renal pelvis. This is what is the renal pelvis over here. This is what is the renal pelvis. And this renal pelvis finally continues into the ureters. Okay? So we are saying that this renal pelvis which is there now, you can see the renal pelvis on both the sides. On this side it appears to be normal, but on the other side, on the right side, you can see that the pelvis appears as if it is drooping down, na? As if it is drooping down. Very good. So this is known as, this renal pelvis looks like a lily, na? Lily flower. So this IVP shows us the classical drooping lily sign. This IVP shows us the classical drooping lily sign. And if there is a drooping lily sign on the IVP, that is what is suggestive of a duplication of renal pelvis and ureter. That is suggestive of a congenital anomaly, which is duplication of renal pelvis and the ureter. What has happened in this patient, matlab? So please remember, there is duplication of the renal pelvis and the ureter in this patient. That means there are two pelvis in this patient. The upper pelvis which is there, na, it is compressing the lower pelvis. The upper pelvis is compressing the lower pelvis, due to which it appears like a drooping lily usually. Okay, due to which it appears like a drooping lily. Please remember. So there is a duplication of renal pelvis and renal ureters usually. Important is, most of these two ureters there are, na. So एक kidney से कितने pelvis है? दो pelvis है. और कितने ureters है? दो ureter है. So there are two ureters and two pelvis in a single kidney. Now in most of the cases what happens? Both these ureters will combine together and they will open as a single ureter in the urinary bladder. In most of this condition, they will open as a single ureter in the urinary bladder. But in some conditions, what can happen? One ureter opens into the urinary bladder. One ureter opens up into the urinary bladder, but the other one becomes ectopic. What do I mean by this? Other ones opens at some other site. Other ones open at some other site. And due to that, what will happen? If it is an ectopic ureter, what will happen in the patients now? The patients will have high risk of urinary tract infection. The patients will have high risk of urinary tract infection in males usually, males. In males, it opens at the level of prostatic urethra. Therefore, patients will have a high risk of UTI. But in females, it opens distal to the distal sphincter. And as it opens distal to the distal sphincter, there is no control. The urine directly flows out in females. That is what is called as, please remember, okay, so that is what is known as dribbling incontinence of urine. Please remember, that is what is known as dribbling incontinence of urine. So please remember, क्या हो रहा है इस patient में? Okay, so first is, if the ectopic ureter which was there, ये ectopic ureter अगर prostatic urethra में open होता है, like in males, then there will be high chance of infection. ठीक है, क्योंकि यूरिन जमा हो जाती है बहुत ज्यादा. That causes UTI. But if a patient is a female, so in females usually कहाँ open होता है वो? In females, it opens distal to the distal sphincter, and that is the reason why the patient will not have any control over the urine, and that will cause dribbling incontinence of urine. What should be done? तो जो ectopic ureter है ना, उसको वापस से bladder में जाके place कर दो. That is what is called as ureteric reimplantation. जो ureter बाहर open up हो रहा है, उसको वापस से bladder में open up कर दो ढंग से. That is what is known as ureteric reimplantation. Please remember. Okay, so that is what is known as ureteric reimplantation has to be done in the patient. So ureteric reimplantation has to be done. No issues till here, anybody? Ureteric reimplantation has to be done. Next is this condition, guys. And what is seen in this condition, you can see some part of the renal pelvis, and some part of the ureter has been dilated. Okay, the renal pelvis and the renal. Okay, so please remember, the renal pelvis and the ureters have been dilated. Okay, so usually you can see अगर renal pelvis and renal ureter dilate हो रहा है, renal pelvis or renal ureter dilate हो रहा है, so what it is suggestive of? Usually, please remember, this is what is suggestive of. This is what is suggestive of hydronephrosis. This is what is suggestive of hydronephrosis. I hope all of you are quite aware. What is hydronephrosis? When excess of urine Urine is what? Water only, na? When excess of urine collects usually in the renal pelvis or the renal ureter, that is what is called as hydronephrosis. So if excess of urine collects in the pelvis and the ureter, there will be dilatation of the pelvis and the ureter. There will be dilatation of the pelvis and ureter. That is what is called as hydronephrosis. Hydronephrosis can occur due to various reasons. Here the reason which is there, it is a case of PUJ obstruction. Here the reason which is there, it is a case of PUJ obstruction. That is pelvic-ureteric junction obstruction. That means this junction which is there, na, you can see the junction which is there, the pelvic-ureteric junction usually, it is twisted. So as the pelvic-ureteric junction is twisted, na, the urine could not flow properly. Okay, the urine is obstructed, and as the urine is obstructed, definitely it will keep on collecting in the pelvis, and the pelvis keeps on dilating further. That causes hydronephrosis in the patient. Okay, and due to hydronephrosis, the patient can have high chances of UTI also. So therefore, just give antibiotics to the patient. And if there is a PUJ obstruction, then definitely you need to perform a surgery, and that is what is called as Anderson-Heinz pyeloplasty. Okay, so pyeloplasty is nothing but repair of the pelvis, right? So it is known as Anderson-Heinz pyeloplasty, so repair of the renal pelvis or the pelvic-ureteric junction. The treatment which is there is known as Anderson-Heinz pyeloplasty that has to be done. Next important is this one. Okay, what is this condition over here? You can see the ureter which appears over here. The ureter which appears over here, it appears as if it is hook shaped. Okay, ureter should be straight, na, सीधा आना चाहिए नीचे. But यहाँ पे the ureter takes a turn behind and it appears hook shaped. Please remember. So this hook shaped ureter, a fish hook ureter, okay, a fish hook ureter or a reverse J ureter, or it appears like a reverse J shape, na, or a reverse J shaped ureter. A fish hook ureter or a reverse J shaped ureter. If it is seen on IVP, definitely that is suggestive of what? That is suggestive of a retrocaval ureter. That is what is suggestive of a retrocaval ureter. What do I mean by retrocaval ureter? What is cava? Vena cava. That is inferior vena cava. So if the ureter goes behind the inferior vena cava, that is what is known as retrocaval ureter. It is usually seen in the right-sided ureter. What will happen due to that? As you can see, as the ureter is taking the turn, therefore urine is not able to drain properly. अगर urine drain नहीं हो सकती तो क्या हो जाएगा? Urine यहाँ पे जमा होती रहेगी and the proximal part will get dilated. Again, that causes hydronephrosis in the patient. Okay, so there will be hydronephrosis due to retrocaval ureter also. Okay, so what should be the treatment in this condition? If I talk about the treatment in this condition, cut the part behind IVC, the part which is going behind the IVC. Cut the part behind IVC and go for connection of the remaining parts of ureter. Go for the connection of the remaining parts. That is called as uretro-anastomosis, right? That is what is called as uretro-anastomosis or a uretrostomy. Okay, so that has to be done. Next one, this image which you see over here. क्या दिख रहा है इसमें? There's a lot of blackish appearance on the CT scan ना in the kidneys. ये किडनी है और किडनी में क्या दिख रहा है? बहुत कुछ काला काला दिख रहा है. What appears black on a CT? We know air appears black on a CT scan definitely. So you can see there is air inside this kidneys which is usually seen. Okay. What did I tell you? The patient is also having symptoms. चलो मैं symptoms भी बता देता हूँ. Now please tell me the diagnosis in this condition. Huh? Patient में symptoms है. The patient is having pain. The patient is having fever. The patient is having burning micturition as well. ठीक है, और हमें पता है burning micturition is the most common and the earliest symptom of a urinary tract infection or a kidney infection for that matter. ठीक है, so urinary tract infection का symptom लग रहे पूरे and the patient is having on a CT scan air present inside the kidneys. What is the diagnosis? Which type of infection it will be? हमने देखा था जब gall bladder में air थी और उसका infection हो रहा था, that was called as emphysematous cholecystitis. So this would be called as anybody? Infection of the renal pelvis and the kidney is known as pyelonephritis. So this one where there is air inside the kidneys due to an infection of the kidneys is known as emphysematous pyelonephritis. So it is a case of emphysematous pyelonephritis, guys. It is a case of emphysematous pyelonephritis in the patient definitely. And here important is to remember over there the most common cause of emphysematous cholecystitis was Clostridium perfringens, but over here the most common cause of emphysematous pyelonephritis, that was a previous year question, Please remember, it is the same as UTI. What is the most common cause of UTI? We know the most common cause of UTI is definitely E. coli. So here also the most common cause of emphysematous pyelonephritis is E. coli. And that's the basic difference you need to remember. Here it is not Clostridium. Okay, and a lot of people have made that mistake. Don't make that mistake. Treatment is what? Usually antibiotics has to be given to the patient. Treatment with antibiotics to be given to the patient. Okay. Next, if I talk about another condition, and that is this one. This is a IVP, and this IVP classically shows which kind of appearance. You can see this is the renal calyx, and this kind of appearance is seen. What is this kind of appearance called as? What is this kind of appearance called as? This is the classical paintbrush appearance. Please remember, this one is the classical paintbrush appearance. So if your IVP showing you the classical paintbrush appearance, definitely that is what is suggestive of what? Paintbrush appearance on IVP is what is suggestive of a medullary sponge kidney. That is what is suggestive of a medullary sponge kidney. And what is the cause of medullary sponge kidney? Here there is dilatation of the collecting tubules. Yes, the last part of the nephron kya tha? Collecting tubules na. So the collecting tubules were getting dilated. Okay, so if there is dilatation of the collecting tubules, that is what is called as medullary sponge kidney. Here the patient will have a high risk. If the collecting tubules are dilated, will the urine be able to drain properly? No. Again, अगर dilate हो जाता है तो urine वहीं पे जमा रहेगी. So if the collecting tubules are dilated, the urine will stay over there. That will cause again urinary tract infections or pyelonephritis in the patient. And that is the reason why in medullary sponge kidney also treat the patient with antibiotics usually. Treat the patient with antibiotics. Okay? So that is important. Next, if I talk about this, yes, definitely a lot of people were right. So this condition, if I talk about, is a case of renal TB. This is what is a case of renal TB. If I talk about renal tuberculosis or kidney tuberculosis in the patient, definitely. So important is, please remember, the cause, all of us are quite aware, any TB will be caused by Mycobacterium tuberculosis, definitely. Okay. If I talk about renal TB also, please remember, most common site for TB usually is the lungs, followed by that is the lymph node, followed by that is the pleura, then it is definitely the bones, the gut, and the genitourinary system after that. Okay. If I talk about renal TB now, important is, yahan pe what will be the most common or the earliest feature of the patient? There can be earliest, please remember, there can be other features of TB also. And what are the other features of TB? The constitutional symptoms of TB are 4 symptoms hote, yaad rakhne hamesha. Okay. The patient of TB will have loss of appetite, that is anorexia, due to which the patient of TB will not eat anything, causing weight loss. The patient will also have low grade fever, and that low grade fever generally rises in the evening time. Okay. And fourth one, the patient will also have drenching night sweats. Okay. His clothes will be wet throughout the night. Okay. So these are the usual symptoms. But the most common or the earliest feature of TB, that is the renal TB, will be increased frequency of micturition. The patient will have increased frequency of micturition. Yes, it is not decreased. The patient wants to go to the bathroom or the loo more number of times. There will be increased frequency of micturition. Please remember that. Okay? Khayal rakhna. Apart from that, the patient can also have hematuria at times. Usually TB is painless, but sometimes there can be pain. Otherwise, usually it is painless only. Okay? Now, if I talk about the IVP, what does the IVP shows over here? The IVP over here, it shows that the calyces which are there is some necrosis at the papilla or the calyces. Okay? There is some necrosis at the papilla or calyces. So initially, the earliest feature which is there, the earliest feature which can be seen on the IVP, the earliest feature which can be seen on the IVP is an ulcer at the papilla. There will be ulcer at the renal papilla. But then there will be more damage. The ulcer will progress further. There will be more damage at the papilla or the calyx. And then it will appear as if the calyx has been eaten up by a moth. किसी कीड़े ने खा लिया, काट खाया उस kidney को, ठीक है? That is what is called as moth-eaten calyces. Then definitely there will be appearance of moth-eaten calyces. Then definitely what will happen? The infection will progress further. Now there will be pus throughout the kidney. And if there is pus throughout the kidney, that is called as pyonephrosis. Okay, there will be pyonephrosis. And then when the kidney will start healing, जब kidney ठीक होना शुरू हो जाएगी, when the kidney starts healing, what will happen? There will be fibrosis of the kidney. And along with fibrosis, there is also calcification of the kidney. And then the kidney will appear completely white. And this white kidney which is seen on a plain X-ray, this is not a IVP. This is a plain X-ray KUB. What is a KUB? Kidney, ureter or bladder का plain X-ray है ये. Okay, why? How I am able to differentiate between a IVP and a plain X-ray? Please remember, see, if it was a IVP, if it was a IVP, definitely you can see in a case of IVP, there is contrast in the renal pelvis, there is contrast in the ureter, and most important, there is a contrast in the urinary bladder. So agar if you are able to see the contrast or whitish appearance of the urinary bladder, then it is a IVP or intravenous pylography. But if you are not able to see any contrast in the ureter or the urinary bladder or the renal pelvis, then it cannot be a IVP, it cannot be a contrast study, it has to be a plain X-ray KUB. और अगर plain X-ray KUB पे definitely I'm seeing a white kidney. On a X-ray, what appears white? On a X-ray or a CT scan, calcification usually appears white, right? So definitely here there is a fibrosed and a calcified kidney, and that is what is called as a putty kidney. That is a classical feature of a putty kidney. And putty kidney will completely undergo calcification, and then it will be called as a cement kidney. It will become very hard, and then it will be called as a cement kidney further. No issues with this, anybody? So these are the various stages of your renal tuberculosis. Please remember that. Okay, various stages of renal tuberculosis. Please remember. Okay. In cases of bladder TB also, the patient will have same symptom. Earliest symptom will be increased frequency of micturition. But in cases of bladder TB, definitely the patient will have a classical feature. In cases of bladder TB, the patient will have a gall hole ureteric orifice. If we perform a cystoscopy, what is a cystoscopy? Examination of your urinary bladder by inserting a camera from the urethra. That is gall hole ureteric orifice will be there. Or in the later stages, the patient will develop a thimble bladder. In the later stages, there will be a contracted and a narrowed bladder. Puri bladder fibrose ho jayegi, and there will be a contracted and narrowed bladder due to fibrosis known as thimble bladder. Okay? No issues with this, anybody? What is the treatment of choice in cases of renal TB? Definitely the treatment of choice for renal as well as bladder TB or any kind of TB for that matter is always ATT, anti-tubercular therapy. 2 months of intensive and 4 months of continuation phase. Along with that, definitely if there is pus, if it is a case of pyonephrosis or if there is pus in the urinary bladder, always drain an abscess or always drain a pus. Okay? So that has to be done. No issues with this, anybody? That is important. Now, before starting stones, let's take a break so that you will also get some time, and then we can start with the stones, and then we'll finish it off. There will be 6 to 7 slides which are remaining. 6 to 7 slides are remaining. Definitely we will be able to finish it off as early as possible. Okay, we'll try to finish it off before 11 itself. A break of 15 minutes. Hello guys, shall we start now? Hopefully. Chalo. Let's start. Now talking about the next condition, and that is what is renal stone. If I talk about renal stones now, we know renal stones are also called as nephrolithiasis. Okay? So renal stones, or rather I'll be talking about the stones in the urinary systems together itself. Okay? I'll be talking about the stones in the urinary system together. That is what is called as nephrolithiasis. Okay? So if I talk about nephrolithiasis, guys, usually we know there are various types of stones which can be present in the kidneys, right? Various types of stones can be formed in the kidneys. And unlike the gallstones, what did I tell you about gallstones? The majority of the gallstones, 90% are radiolucent, which will appear black on X-ray or a CT. But yaha ulta hai completely. 90% of the renal stones are usually radio opaque, which will appear white on a X-ray or a CT. Therefore, here we can definitely go for an X-ray or a CT scan. Definitely. No issues with this, anybody? Now, if I talk about the different types of stones, okay. If a patient is having some kind of stone, then definitely if I examine the urine of this patient, if I send his urine for examination, I'll be able to see some specific type of crystals or some specific shape of crystals. Depending on that, I can make a diagnosis. Okay, this patient might be suffering from this specific type of renal stones. Okay. So if I talk about that, first are usually the dumbbell shaped crystals. So if dumbbell shaped crystals are seen, definitely that is suggestive of what? That is usually suggestive of, please remember, monohydrate. That is what is suggestive of monohydrate crystals. Of which stones? Monohydrate crystals of calcium oxalate stones. Okay, monohydrate crystals of calcium oxalate stones. Then if envelope shaped crystals will be seen, okay, if envelope shaped crystals are usually seen, then that is what is suggestive of what? That is what is suggestive of dihydrate crystals. Of which stones again? Dihydrate crystals of calcium oxalate stones itself. Okay, dihydrate crystals of calcium oxalate stones. Which one is more common among monohydrate and dihydrate? Definitely the more common one will be dihydrate calcium oxalate stones. The more common one are dihydrate calcium oxalate stones. Next are the hexagonal shape crystals. So if I am able to see such hexagonal shape of crystals, then definitely it is what is suggestive of a cystine stones. Then that is suggestive of cystine stones. Next, if I am able to see a coffin lid shaped crystals, if I am able to see a coffin lid shaped crystals, then definitely that is what is suggestive of triple phosphate stones. That is what is suggestive of triple phosphate stones. And triple phosphate stones, all of us are quite aware, these are also known as struwite stones. Triple phosphate stones are also known as struwite stones. Why they are called as triple phosphate? Because they are made up of calcium, magnesium and ammonium phosphate. They are made up of calcium, magnesium and ammonium phosphate. Okay? And last, if there is irregular shape of stones, it can be rhomboid, it can be needle, it can be anything, any shape if it is there. Irregular shape crystals, that is what is suggestive of uric acid stones. That is what is suggestive of urate or uric acid stones in the kidneys. That's important. Okay? So these crystals are very much important. Now my question to you is, please tell me which is the most common type of renal stone. My question to you is, which is the most common type of renal stones? Out of all of these stones, which are the most common type? I'll move on till that time. Please remember the cystine stones which are there. These are considered to be the hardest renal stones. The cystine stones which are there, these are considered to be the hardest renal stones definitely. They cannot easily break. Okay. Whereas this uric acid stones, they are generally formed in two important conditions. When uric acid stones will be formed in the body, when there is of excess of uric acid in the body. जब ज़्यादा uric acid है, तभी uric acid stones बनेंगे. Definitely they are usually formed in cases of gout. They are generally formed in cases of gout. And second, they are also formed in cases of tumor lysis syndrome. Okay, so when you have given chemotherapy to a patient and when there is tumor lysis, definitely there will be destruction of a lot of cells releasing excess of uric acid. That can also lead to formation of uric acid stones. Please remember that. Okay, very good all of you. Overall, the most common type of renal stones are calcium oxalate stones. Overall, the most common type of renal stones are the calcium oxalate stones. Important about the triple phosphate stones will be, please remember, calcium oxalate stones, important thing you need to remember, they are pH insensitive. What do I mean by this term? pH insensitive. That means they are formed in any pH of the urine. Okay, they can be formed in acidic urine, they can be formed in alkaline urine also. They can be formed in acidic or an alkaline urine. They are pH insensitive, and these are having some kind of these kind of margins. What are these? Spike like margins. So calcium oxalate stones usually have these irregular spiculated margins, due to which they will cause damage to the urinary system, and that will lead to hematuria in the patient. So hematuria can occur due to calcium oxalate stones. Next are the triple phosphate or struvite stones. So triple phosphate or struvite stones are mainly formed in an alkaline urine. And when there is an alkaline urine, so alkaline medium is there when there is a urinary tract infection. And what is that specific urinary tract infection which causes an alkaline urine? That has been a previous year question multiple number of times. And answer is Proteus mirabilis. So Proteus infection will increase the risk of triple phosphate stones. The reason is it makes the urine alkaline. That's the problem. Usually these triple phosphate stones which are there, please remember these triple phosphate stones which are there, they are having a silent presentation. That means the patient will not have any symptoms as such. That's the reason why they keep on growing in size, and they grow so much that they take the shape of the renal pelvic calyceal system. They take the shape of the renal pelvic calyceal system, and once they grow so much in size and they take the shape of renal pelvic calyceal system, that is called as the staghorn calculi. Okay, एक बार वो pelvis का shape ले ले, then it is called as the staghorn calculi. Please remember that. Okay, important is that. No issues with this, anybody? So that is important to be remembered. Now, how to differentiate a staghorn calculi? A lot of people are having problem from a hydronephrosis. Please remember, in a staghorn calculi, I have told you, calculi is what? Calculi is a stone. Definitely, it is due to calcium deposition. Okay, so it is calcium phosphate now. So it is definitely due to calcium deposition, and calcium appears white on a CT or X-ray. So here it is actually a X-ray. Here it is a X-ray KUB which is showing you the white appearance, and this appearance is seen like what? This appearance is usually seen like the renal pelvis. Okay, so that is what is the staghorn calculi. On the other hand, if a plain X-ray is showing you the appearance of a kidney, not the shape of a pelvis, the shape of a kidney, then it is a case of putti kidney. Okay, and when a IVP is showing you the shape of a pelvis, when a IVP, you can see the urinary bladder is visible. Why? Because the dye or the contrast is present in the urinary bladder. So this is not a plain X-ray, this is a IVP. On a IVP, if you are able to see the shape of a renal pelvis, that is what is the case of hydronephrosis. So please differentiate it. A lot of people make mistakes even in NEET PG examination. This should not happen. Okay? So that's the important thing you need to remember over here. If they ask you what is the first line investigation, as I've told you, most of the renal stones are radio opaque. Therefore, the first line investigation can be a X-ray KUB. The first line investigation can be X-ray, kidney, ureter, bladder. But if they ask you what is the investigation of choice, what is seen over here, you can see a renal stone. Okay, in this investigation. So investigation of choice is the NCCT KUB. That is a non-contrast CT scan of kidney, ureter and bladder. If NCCT KUB is not an option, NCCT abdomen can be marked as. Okay, no issues with this. The patient usually can be asymptomatic also, or the patient can have lumbar pain, or the patient can also have, please remember, the patient can also have what? Urinary tract infections. So the patient can be asymptomatic, or there can be pain, or there can be UTI in the patient, or there can be chances of obstruction. Na? And when there is obstruction of the ureter, what will happen? Dilatation of the renal pelvis, and that is what is called as hydronephrosis. So patient will have also high chances of hydronephrosis as well. If I talk about the pain according to the location of the kidney stone, please remember, if the patient is having a kidney stone, the patient will only have a lumbar pain. Okay, loin pain. Yahan pe pain hoga bas. Okay, so if the stone is in the kidneys, the patient will only have lumbar pain. But if the stone is located in the upper 1/3 of the ureter, if the stone is present in the upper 1/3 of the ureter, the patient will have lumbar pain which radiates to what? The patient will have lumbar pain radiating to the perineum in females. It is radiating to perineum in females and usually to the testis in males or the scrotum in males. Okay, perineum in females or the testis or scrotum in males. If the stone is at the level of pelvic brim, if the stone is usually at the level of the pelvic brim, then the patient will have a lumbar pain. Please remember, the patient will have lumbar pain which is radiating to, or which is referred to what? Okay, it is usually referred to the if the patient is having a stone at the pelvic brim, it is usually referred to the inner thigh. The pain is usually referred to the inner thigh. The pain is usually referred to the inner thigh. If the patient is having a urinary bladder stone, then the patient will have a suprapubic pain. Okay, the patient will have a suprapubic pain. And when the patient is having a stone at the bladder neck or at the urethra, then definitely in this condition, patient has a suprapubic pain. Okay, patient has a suprapubic pain, but that is referred to the tip of the penis. That is referred to the tip of the penis. Please remember. Okay, so that is what is usually seen in this condition. No issues with this, anybody? That is important to be remembered. Now, if I talk about the urinary bladder stones, guys, if I talk about urinary bladder stones, there also the patient can have UTI, hydronephrosis, all of these features. In a case of urinary bladder stone, please remember which is the most common urinary bladder stone in adults. So important thing to be remembered is the most common urinary bladder stone in adults usually are the uric acid stones. Most common urinary bladder stones in adults are uric acid stones, but the most common urinary bladder stones in children, most common urinary bladder stones in children will be the triple phosphate stone. In children, the most common urinary bladder stones will be the triple phosphate stones, definitely. Please remember that. Okay. Now, usually, this was the X-ray which has been given earlier. Okay. So you can see here a X-ray KUB has been given. Okay, there is no dye over here now. So definitely it is a X-ray which is there. The X-ray is given and you can see a whitish opacity in the center. This opacity is uniform or non-uniform. एक जैसी सफेदी दिख रही है ना? So definitely this is a homogeneous opacity. This you can see there is a uniform opacity now. There is a homogeneous opacity which is seen. So if you can see opacity in the center in the pelvis and homogeneous opacity is seen, this diagnosis which was given to you in the examination was a giant bladder stone. This was a case of giant bladder stone, definitely. Okay, it was a case of giant bladder stone. Ammonium, please remember ammonium is ammonium urate stones itself. Okay, it is known as the ammonium urate stone. So it is combination of ammonia plus urate. It is known as ammonium urate. Who shows with anybody? It is the ammonium urate stone. Who shows with anybody? The ammonia and the uric acid combines together to form the ammonium. Okay. So usually, if I talk about this giant bladder stone, please remember if I talk about this giant bladder stone over here, apart from this, there can be another differential diagnosis which was given in one of the options in your exam. Please remember what was that option usually? Here, if this kind of appearance is seen in the periphery and there is a heterogeneous calcification, if it is seen in the periphery along with a heterogeneous calcification, that is suggestive of a calcified fibroid. From gynae, you need to remember that is suggestive of a calcified fibroid usually. No issues with this, anybody? That's the important thing. Okay. Now, what should be the treatment in this condition? Depending on the location of the kidney stone again, we will decide the treatment in the patient. Okay. If I talk about the treatment of choice, if the stone is in the kidney, or it is in the upper or the middle ureter, okay, it is in the upper or the middle part of the ureter. If the stone is less than 5 to 6 mm, so very small stone, na? If the stone is less than 5 to 6 mm, very small stone, definitely in this condition only observation has to be done. Only observation. We can give medical management like alkazol vagara, which can just drain the stone. Okay. If the stone is more than 5 to 6 mm in size, when the stone is more than 5 to 6 mm in size, definitely we will go for a procedure known as ESWL. What is ESWL? Extracorporeal shock wave lithotripsy. Okay, that procedure is known as extracorporeal shock wave lithotripsy. That is important. Okay, and when the stone is more than 2 centimeters in size, then ESWL is contraindicated. Okay, if the stone is more than 2 centimeters in size, definitely ESWL is contraindicated. In that condition, definitely we will go for PCNL, that is percutaneous nephrolithotomy. It is known as percutaneous nephrolithotomy. BRPO fluid pilau. Okay, so all of that can be given. Now, if there is a low ureteric stone, if there is ureteric stone in the lower part of the ureter or lower 1/3 of the ureter, then we will take a camera. We will go via the urethra into the urinary bladder, from there into the ureter, and then we'll go for a ureteroscopic removal with a Dormia basket. Ureteroscopic removal of the stone is done with Dormia basket. Okay, so ureteroscopic removal of the stone with Dormia basket has to be done. No issues with this. If the stone is in the urinary bladder, if it is a small stone, break the stone. Okay, break the stone and then remove it. That is what is called as lithotripsy. Okay, that is what is known as lithotripsy. But if the stone is too huge in size, then definitely we need to perform a cystolithotomy. That means we need to open up the urinary bladder now. We cannot just break the stone and the stone cannot come out on its own. In this condition, definitely we need to go for a cystolithotomy if it is a very huge or a giant bladder stone. Okay, so please remember, if it is a large urinary bladder stone, I have already written it is cystolithotomy. It is a cystolithotomy which is done. No issues with this, anybody? That's important. And if the stone is in the urethra, then push the stone back into the urinary bladder. Push the stone back into the urinary bladder and treat it like a bladder stone. Push the stone back into the urinary bladder and treat like a urinary bladder stone. Treat like a urinary bladder stone. Important is, but if the stone is at the tip of the penis, or okay, if the stone is at the tip of the penis, or usually in the distal part of the urethra, then you can go for a forceps removal also. Then you can go for a forceps removal as well. Okay, just make sure that the patient is given a local anesthesia, otherwise the patient will cry out in pain. Next, what is this procedure over here? You can see this is what is the ESWL. What is the ESWL? Extracorporeal shockwave lithotripsy. So lithotripsy is what? Breaking down the stone into multiple fragments. Stone ke tukde tukde karna is what is called as lithotripsy. Extracorporeal, why? Because we are giving the shock waves out from outside the body. Okay, we are giving the shock waves outside the body. That is the reason why it is called as extracorporeal. Outside the body, shock waves are given. These shock waves are directed onto the stone so that the stone gets fragmented. And then once the stone gets fragmented into pieces, it will come out. Okay, you need to give a lot of fluid to the patient, so the patient will urinate, and therefore the stone will come out from the urine itself. These fragmented pieces of stone will come out from the urine itself. And this was the question which has been asked. This X-ray had been given and they asked that a patient underwent an extracorporeal shockwave lithotripsy, after which you can see this kind of a picture. What is this? When the stone fragments or the pieces will line one behind another in the ureter. This characteristic phenomena is called as the Steinstrasse phenomena. This characteristic phenomena is known as the Steinstrasse phenomena. Please remember, this is characteristically known as the Steinstrasse phenomena. That's important. No issues with this, anybody? So that is what you need to remember properly for the treatment of renal stones as well as urinary bladder stones. Now we have a question where a patient is coming to us with abdominal mass, there is flank pain and there is hematuria. What is the diagnosis? So this is a classical triad: abdominal mass, flank pain and hematuria. If there is abdominal mass, usually over here in the flanks, that is a classical sign of a renal tumor. That is a classical sign of a renal tumor. So patient will have mass, pain and hematuria usually. Okay? So definitely if I talk about this, the diagnosis is a renal tumor and mainly it is a renal cell carcinoma. Yes, because in benign renal tumors, the patient will be mostly asymptomatic. Okay, in benign renal tumors, the patient is usually asymptomatic. Just answer one of my question. Which is the most common benign renal tumor? Just answer this question. Which is the most common benign renal tumor? Which is the most common benign renal tumor? I need the answer. Okay. So if I talk about renal cell carcinoma now, that is the malignancy or the cancer arising from the kidney. Okay. So in renal cell carcinoma, there can be various types. Please remember. But if I talk about the most common type, definitely the renal cell carcinoma, most of the kidney is also lined by the columnar epithelium. Okay. Kidney is made up of what? Nephrons, and the nephrons are made up of mainly the tubules. Okay, and tubules are lined by columnar epithelium because they need to secrete something. Therefore, the renal cancer mainly arises from nephron, mainly the tubules, and therefore it arises from columnar epithelium. Therefore, it is also adenocarcinoma. Rarely it can be a transitional cell carcinoma when it arises from the renal pelvis. Okay, if I talk about the subtypes, if I talk about the histopathological subtypes, the most common subtype of a renal cancer is usually the clear cell RCC. The most common subtype of renal cell cancer is definitely the clear cell type. As you can see, the cells are not having a pinkish cytoplasm. Okay, they are appearing clear definitely. Okay, the cytoplasm appears clear or a ground glass. That is what is seen. But if they ask you which among the subtypes of renal cancer has the best prognosis, which subtype of renal cancer has the best prognosis, then your answer should be chromophobe type. Then your answer definitely should be chromophobe type. Please remember, the chromophobe type of renal cancer, where the cells are wish shaped, where the cell give a appearance of plant cell. Biopsy is seen like plant cell. So plant cell like appearance on a histopathological examination is suggestive of chromophobe type of renal cell cancer. And important is the chromophobe type of renal cell cancer also has the best prognosis overall. So you will ask me, sir, worst prognosis kiska hai fir? The worst prognosis among all the renal cell cancers, is seen with collecting duct carcinoma or a Bellini duct carcinoma. Okay, worst prognosis among all the renal cell cancer is seen with collecting duct carcinoma or the Bellini duct carcinoma. So please remember, important is, please remember, if it is a most common benign renal tumor, then your answer should be oncocytoma. Then your answer is usually a oncocytoma. The most common benign renal tumor answer is oncocytoma. Now, as I've told you, there is the characteristic triad in a case of renal cell cancer. There is abdominal mass, there is flank pain, and there is hematuria. What is the investigation of choice in a case of renal cancer? The investigation of choice in a case of renal cancer, again I told you, liver cancers and renal cancers. If you try to take a biopsy, there will be spread of the cancer in the peritoneum or in the abdominal wall. That is the reason why you don't take a biopsy in this condition. Here in liver or kidney cancers, the investigation of choice is a CECT abdomen. Contrast enhanced CT scan of abdomen has to be done. And on that contrast enhanced CT scan, you can see this is one kidney, but from the other kidney, you can see a mass which is arising. Okay, so this is a case of renal cell carcinoma. You can see such a huge mass is arising from here. Okay, that is a case of renal cell carcinoma. Okay, once you have done the diagnosis, definitely, if the cancer is less than 4 centimeters in size, you will only remove half of the kidney or some part of the kidney. That is called as partial nephrectomy. So if the cancer is less than 4 centimeters in size, you will go for a partial nephrectomy. But if the cancer is more than 4 centimeters in size, definitely in this condition, you will go for a radical nephrectomy. In this condition, if the cancer is more than 4 centimeters in size, there is a higher risk of spread to the other sites also. Therefore, you will go for a radical nephrectomy in this condition. Okay. If I talk about nephroblastoma now, what is nephroblastoma? So it is actually a kidney cancer which arises from the immature cells usually. Okay. So it is therefore called as nephroblastoma. Nephroblastoma is another name used for Wilms tumor. We know that Wilms tumor is common in which age group? So we know that Wilms tumor is more common in the toddlers, that is 2 to 5 years of age group. If they ask you which is the most common, abdominal malignancy in children, what is your answer? Okay, give the answer for this. Which is the most common abdominal malignancy in children? Okay, so Wilms tumor is definitely common in the 2 to 5 years of age group children. Okay, and as I've told you, Wilms tumor is commonly associated with multiple syndrome. It can be associated with Weber syndrome. It is also associated with Dennis-Drash syndrome, and more important, it is also associated with Beckwith-Widman syndrome. It is also commonly associated with Beckwith-Widman syndrome. Please remember that, where there will be hemihypertrophy in the child, macroglossia, omphalocele, and Wilms tumor. Okay, so these are the features. Wilms tumor, definitely here also the classical triad will be present, that is abdominal mass, flank pain, and hematuria is the classical triad which is also present in a case of Wilms tumor. Please remember that. What is the investigation of choice? Here also the investigation of choice is a CECT abdomen. If they ask you what is the treatment in the child, definitely the treatment in the child, you need to remember the treatment in the child is usually surgery plus chemotherapy in the early stages, or surgery plus chemotherapy plus radiotherapy in the later stages. That means stage 1 and stage 2 is treated by surgery plus chemotherapy, but stage 3 and stage 4 is treated by surgery plus chemotherapy plus radiotherapy. Once you perform a surgery now, then you will send a specimen to the pathology lab. एक बार तुमने surgery कर दी, फिर कुछ टुकड़ा तुम pathology lab में भेजोगे, and then on that you will see on the histopathological examination, you will be able to see that this tumor is a mixed tumor. What do I mean by this? So this Wilms tumor which is there, or a nephroblastoma, is a mixed tumor. That means it will have some epithelial elements also, it will have some blastemal elements also, okay, immature cells, then it will also have some mesenchymal elements as well, supporting tissue. Okay, so all of these will be seen in a case of Wilms tumor. The most common abdominal malignancy in children, so please remember the most common abdominal malignancy in children, you need to remember the answer, it is usually a neuroblastoma. Yes, it is neuroblastoma which is more common, followed by nephroblastoma. So it is neuroblastoma followed by nephroblastoma or Wilms tumor in the patient. That's important. Then if I talk about bladder cancer, okay, so bladder cancer or urinary bladder cancer, definitely, what is the normal lining of your urinary bladder? The normal lining of your urinary bladder is transitional epithelium. Therefore, the most common urinary bladder cancer will be what? The most common urinary bladder cancer will be a transitional cell carcinoma. It will be a transitional cell carcinoma. Important. But sometimes it can be a squamous cell carcinoma. Can anybody tell me the squamous cell carcinoma of urinary bladder is commonly associated with which infection? And that was a previous year question. Okay, so squamous cell carcinoma of urinary bladder is commonly associated with which infection? That is my question. Okay. Here also the patient will have hematuria will be there. The patient can have a mass as well. Okay, urinary bladder cancer. Investigation of choice for a urinary bladder cancer. Investigation of choice for a urinary bladder cancer is done by take a camera inside the urinary bladder, go for a cystoscopy, and along with that perform a biopsy. If I talk about the treatment in a case of urinary bladder cancer, what I need to do? So please remember, I need to go for a radical cystectomy. In most of the cases. And so if I remove the urinary bladder itself, if I am performing a radical cystectomy, okay, I am also removing the lymph nodes. That is usually your obturator group of lymph nodes which is removed. Then I will form a new urinary bladder. And that new urinary bladder is formed with the help of ileum. Please remember that new urinary bladder which is there, it is formed with the help of your ileum. Okay, so a new urinary bladder is formed. That you need to remember. Please remember that. Okay. And if it is a case of early bladder cancer, then definitely in early stages, I can go for a TURBT. What is a TURBT? Transurethral resection of bladder tumor. Okay, in early stages, I can even go for a transurethral resection of bladder tumor. And BCG vaccine has also been indicated in the treatment of bladder cancer. Please remember, it is not typhoid, it is S for S that you need to remember. It was a previous year question. It is schistosomiasis. Schistosomiasis of urinary bladder is known to cause squamous cell carcinoma of urinary bladder. Schistosomiasis of urinary bladder is known to cause squamous cell carcinoma of urinary bladder. Okay, that is important. Now talking about bladder rupture in the patient. So usually a patient had some trauma and due to that his urinary bladder has ruptured. If I talk about bladder rupture, we know that bladder lies outside the peritoneum. It lies in the pelvic cavity, it lies outside the peritoneum. So it is usually an extraperitoneal organ. Therefore, most commonly, which type of bladder rupture will be more common? Extraperitoneal bladder rupture is definitely more common. But you will say, sir, ये intraperitoneal bladder rupture होता कब है? So please remember, in cases when the urinary bladder is full, definitely, and if there is trauma to this full urinary bladder, okay, or over distended urinary bladder, there is trauma to a full or over distended urinary bladder, that can cause a intraperitoneal bladder rupture. That can lead to a intraperitoneal bladder rupture. Okay, so that has to be remembered. In a normal urinary bladder, more commonly it will always be a extraperitoneal bladder rupture. So please remember, if they ask you what is the most common cause, as we know that urinary bladder is placed inside the pelvic cavity within the pelvic bone. Therefore, the most common cause is nothing but a trauma. And which kind of a trauma? Nothing else but a pelvic fracture. We know pelvic bone cannot be easily fractured, so it is due to only a high velocity trauma like a road traffic accident. Okay, so extraperitoneal bladder rupture, the most common cause is pelvic trauma or a pelvic fracture. If I talk about an intraperitoneal bladder rupture, as I've told you, intraperitoneal bladder rupture is again due to a trauma, but to which kind of a bladder? Trauma to a over distended bladder. जैसे कि okay, a patient, समझो कि तुम अपने दोस्त की पार्टी में गए, तुम्हें फ्री में बियर पहली बार मिल रही है. You have drank a lot of beer. Okay, so you are getting free beer, you have drank a lot of beer. Now what is there? There's an over distended bladder. Okay, because beer acts as a diuretic, and you have gone to urinate and there you slipped. Okay, you have a lot of beer, therefore you slipped and there was trauma to your bladder or there was trauma to the suprapubic region. Definitely that has caused an intraperitoneal bladder rupture. So it is usually seen either due to beer drinking or it can be seen due to what? It can be seen when a patient was taken up for surgery. It was a lower abdominal surgery, but the patient did not urinate prior to that surgery. And while performing the surgery, we saw that the urinary bladder is full, okay, and therefore during the surgery there was injury to the urinary bladder. Okay, so over distended urinary bladder during a lower abdominal surgery, there can be risk to injury. There can be a risk of injury to the over distended bladder at that time also. Okay, investigation of choice in both the conditions. Please remember, extraperitoneal bladder rupture, the patient will have inability to pass the urine, or there can be blood which can be seen from the urethra which is coming out. In a case of intraperitoneal bladder rupture, as the urine is going into the peritoneum, definitely the patient is going into a syncopal attack. The patient will have all the features of peritonitis as well. Okay, so that will be seen. If they ask you what is the investigation of choice, in both the conditions, it is either a CT cystography. If the patient is stable, then definitely we'll perform a CT cystography. But if the patient is unstable, then we'll take just an X-ray of the bladder after injecting a dye in it. And after we inject a dye in the bladder and take an X-ray, that is called as a cystogram. That is the basic idea, basic difference. Okay, one picture is taken with CT, that is called as CT cystography. Other is known as a cystogram. Okay? If I talk about treatment of choice in this patient, please remember, in a case of extraperitoneal bladder rupture, nothing has to be done. As it is extraperitoneal bladder rupture, just insert a Foley's catheter, okay, or insert a suprapubic catheter, okay, so that the urine will not stay in the urinary bladder and the urinary bladder will heal by itself. Yes, extraperitoneal bladder rupture will heal by itself most of the times. So here you only need to go for a Foley's catheterization. Or you go for a SPC, that is a suprapubic catheterization. Whereas if I talk about intraperitoneal bladder rupture, I have told you the urine has gone into the peritoneum and the patient is suffering from peritonitis. Therefore, you need to open up the abdomen. That is, exploratory laparotomy has to be done. You need to go for an exploratory laparotomy. Please remember, along with exploratory laparotomy, you need to clean the peritoneum now. And cleaning of peritoneum, we know it is called as peritoneal lavage. Okay, cleaning of peritoneum, we know it is known as peritoneal lavage. Okay, along with that, definitely we'll try to repair the bladder. So we will try to apply sutures over the bladder, the part which has been ruptured. So we'll go for a bladder repair as well. And now these sutures which we have applied, if the urine stays in the urinary bladder, these sutures can come off. Therefore, again, to keep, we should not let the urine collect in the urinary bladder. Okay, as we have repaired it, therefore again insert a Foley's catheter. Okay, so again insert a catheter. Either it can be a Foley's catheter or a suprapubic catheterization, whatever you do. Okay, so that is what is done. If I see the cystogram of both the conditions, you can see the cystogram of extraperitoneal bladder rupture which is there. Okay, this is the bladder rupture and the urine has collected in the pelvis. The contrast is also collecting in the pelvis over here. But the urinary bladder, which is normally pear shaped, it has lost its shape and it has become like a teardrop. So teardrop deformity in the urinary bladder is suggestive of extraperitoneal bladder rupture. But sunburst appearance when the dye or contrast goes into the peritoneal cavity. Okay, the sunburst appearance on the cystogram is what is suggestive of an intraperitoneal bladder rupture. Sunburst appearance on a cystogram is what is suggestive of an intraperitoneal bladder rupture. Okay, that is important. This I have already told you, this is nothing else but a thimble bladder, and thimble bladder was usually seen on what? Thimble bladder was usually seen in a case of bladder TB. Right? Thimble bladder was seen in a case of bladder TB. Next, if I talk about this one, this image, what is this? This is nothing but a Foley's catheter. Okay, this is a Foley's urinary catheter. Okay, it has a balloon which is used for fixation. Okay, it has this cuff. Okay, so you can see this port which is there. This port is used for inflating the balloon, and from this port definitely the urine will come out. This Foley's which is there, it is available in various sizes, and these sizes are known as French. The green one that you can see, it is definitely used for adult females and it is 14 French. The orange one that you can see, it is used for adult males, which is definitely a, okay, the orange one that you can see, it is 16 French, which is used for adult males. Okay, for pediatric population, we can use the black or the white ones, which are around 8 to 10 French. Okay, that is important. And these can be 3 ways as well. 3 way bhi ho sakte hain to aspirate blood from one of the ports. Now talking about urethral rupture, a very classical question of your exam, Sarkari question. Please remember, if I talk about urethral rupture now, please remember, I hope all of you are quite aware that, for example, this is your urinary bladder. Okay, So this urinary bladder, this is the bladder neck over here. This continues into the urethra. The urethra in males is longer, it is around 20 centimeters in length, around 6 to 8 mm in diameter. But urethra in females is shorter, it is around 4 centimeters in length definitely, and 4 to 6 mm in diameter. If I talk about the male urethra which is there, it is divided into 4 parts, but the broad classification is only 2. The broad classification is only 2 parts, and what is the 2 parts? One is called as the anterior urethra, the other is known as the posterior urethra. So anterior urethra is further subdivided into 2 parts. Anterior urethra के दो हिस्से होते हैं. The first one that you can see, the part of the urethra in the penis, this is called as the penile urethra. This is the penile urethra. Next, the part of the urethra in the perineum, this is called as the perineal or the bulbar urethra. This is known as the perineal or the bulbar urethra. Okay? Next one, these ones that you can see over here. Posterior urethra also has 2 parts. The posterior urethra has 2 parts. The one part which is close to the bladder is called as the prostatic urethra. The part which is close to the bladder is called as prostatic urethra because it is surrounded by the prostate gland. It is surrounded by the prostate gland. Whereas this part, okay, the next part, the second part which is there is known as the membranous urethra. It is known as the membranous urethra. Now you know posterior urethra has 2 parts. One is called as the prostatic urethra and second is called as the membranous urethra. Whereas anterior urethra has 2 parts. One is called as the perineal or bulbar urethra and second is called as the penile urethra. If I talk about the rupture now, if I talk about the urethral rupture, either it can be an anterior urethral rupture or it can be a posterior urethral rupture. More common definitely. You can see which part of the urethra is exposed. Definitely the part which is lying outside is more exposed. So it is the anterior urethra which is more exposed. And if the anterior urethra is more exposed, there will be high chances of injury to the anterior urethra. So more commonly the anterior urethra is at a high risk of injury. Okay, the anterior urethra, it has a high risk of injury. More commonly it is the anterior urethra which is ruptured. Please remember that. Okay. If I talk about the most common site usually in anterior, whether it is the penile urethra or it is the perineal urethra. So please remember it is the perineal urethra which is more commonly injured. Okay, overall also the most common site is the perineal urethra which is most commonly injured. सरकारी question है, बहुत बार repeat हो रहा है. Next is this posterior urethra. If I talk about posterior urethra, either it is the prostatic urethra or it is the membranous urethra. Among this, which is more common? Among this, definitely the more common is the membranous urethra. Okay, that's important. Then what is the most common cause? So the most common cause of anterior urethral rupture is usually a trauma like this. Okay, it is usually a trauma like this. You are walking on the street and then you are watching a girl, and due to that you suddenly step on a manhole cover. This manhole cover was loose and then it hit you like this in the perineum. It hits you like this in the perineum and that causes the anterior urethral rupture or mainly the perineal urethral rupture. Okay? This is called as loose manhole cover injury. Or the second type of trauma can be you are riding a bicycle which has this rod in between. You are riding a bicycle which has this rod in between and then you suddenly applied a brake and you slipped. And due to that, definitely the beach wala rod which was there, the central rod, it hit your perineum again. Okay? So that is important. Please remember, the most common cause is definitely a perineal trauma. The most common cause is usually a perineal trauma. And the perineal trauma, as I've told you, it is either the loose manhole covers or it is a bicycle accident. Whereas in posterior urethral rupture, what is the most common cause? We know that the posterior urethra lies in the pelvic cavity. So if the posterior urethra lies in the pelvic cavity, the most common cause for it will also be a pelvic trauma, like a pelvic fracture. The most common cause for its rupture will also be a pelvic trauma or a pelvic fracture. What is the classical triad? Now please remember, the triad that I'm telling you, the 2 parts of this triad or the 2 features of this triad are common to both anterior as well as posterior urethral rupture. दो चीजें जो है common है anterior और posterior urethral rupture में. What are these 2 things? First, the patient will not be able to pass the urine, therefore there will be retention of urine. There will be retention of urine which is seen in anterior as well as posterior urethral rupture. Next, definitely what will happen? The patient will have blood at the tip of external urethral meatus. Okay, there will be blood at the tip of external urethral meatus which will be seen. So these are the common features between anterior as well as posterior urethral rupture. So what is that feature which differentiates both of these? So the third part of the triad is usually a hematoma. So if there is a rupture, there will be collection of blood also, and that is what is called as hematoma. Important is the anterior urethral rupture Where was the injury? In anterior urethral rupture, the injury was to the perineum. So the hematoma will also be formed in the perineum. So if there is a perineal hematoma, it is suggestive of an anterior urethral rupture. But if there is a pelvic hematoma, that is what is suggestive of a posterior urethral rupture. No issues with this, anybody? That's important. And the anterior urethral rupture mein, the perineal hematoma that we see, you can see it is having a classical shape. It looks like a butterfly. Okay, so the anterior urethral rupture mein, the perineal hematoma which is formed, it has a classical shape. It is known as a butterfly shaped hematoma. Investigation of choice, if they ask you, for both the condition, both of these are urethral ruptures. Therefore, the investigation of choice for both of them is a contrast study done for your urethra, and that is called as RGU. We will inject a dye or contrast in the urethra and then take a X-ray. That is called as RGU, that is retrograde uretrogram. If I talk about treatment of choice, definitely in both the conditions, the treatment of choice is same. Just insert a Foley's catheter in the patient, okay, or just go for a SPC, suprapubic catheterization, so that the urethra gets time to heal. Yes, the urethra will repair itself, okay, but just give the time to heal. And just like for drainage of urine, insert either a Foley's catheter or a suprapubic catheterization should be done. Okay. Next important is this one. Please tell me, this is a case, this investigation is a cystogram, because we can see the dye inside the urinary bladder. So this is a cystogram. Now on this cystogram, you can see a classical appearance or a classical shape of your urinary bladder. So please tell me, what is this appearance called as, and which is the condition in which this classical appearance of urinary bladder is seen? Okay, let me know in the comment section below. Moving further, will you answer? Here we have a case which says a neonate. Okay, here we have a case which says a neonate was brought. Okay, Foley's, it has to be skilled. Okay, only a skilled surgeon should insert the Foley's, otherwise that can cause more trauma. Not interns. Okay, interns are not allowed to insert Foley's in a case of urethral rupture. Okay, so it is usually a skilled surgeon who should insert Foley. Very good. Chalo, let's finish it off and then move further. This is a classical Christmas tree appearance. It is a classical Christmas tree or the fir tree appearance. So Christmas tree or the fir tree appearance of urinary bladder is seen on a cystogram, and that is suggestive of which kind of a bladder? That is suggestive of a neurogenic bladder or an atonic bladder. That is suggestive of a neurogenic or an atonic bladder, when the tone of the bladder muscles have been lost. And which are the bladder muscles? The detrusor group of muscles. Okay? So the tone of the bladder muscles have been lost. Very good. So here we have a question. It says a neonate was brought to the emergency room with urinary retention, and the child was diagnosed with complete PUV. What is PUV? Posterior urethral valve with a micturating cystourethrogram. What is the emergency or definitive management? Now if I talk about PUV, what is PUV, guys? As I've told you, PUV is nothing but posterior urethral valve. And if a patient is having a posterior urethral valve, that means what? C. So this is the prostatic urethra. In the prostatic urethra, definitely, here you are having a one-way valve. In the prostatic urethra, you are having a one-way valve. Either it can be a complete valve or it can be a partial valve. That depends. Uski वजह से क्या हो रहा है? The urine is not able to pass outside. Okay, so there is a valve which is there, either a complete or a partial valve, due to which the urine is not able to pass outside. As the urine is not able to pass outside, the patient is having urinary retention. Therefore, the bladder is having a lot of urine inside it. Okay, so that is what is usually seen in this child. So if I talk about posterior urethral valve, it is only seen in male children. It is only seen in male child. Okay, apart from that, here, as I've told you, there can be two scenarios. Either it can be a complete valve or it can be a partial valve. Please remember, if it is a complete valve, the patient will be brought to me in the emergency, and the patient is usually a neonate. Okay, if it is a complete valve, the patient is brought to me in the emergency and it is usually a neonate. And what is the complaint? Urinary retention is the complaint. Okay, so that is what is the complaint over here. Urinary retention, definitely. If I talk about the other condition where there is a partial valve, in partial valve, definitely the child will not be brought to me in the neonatal period. The child will be brought to me in the childhood, usually around preschool or school age. Okay, and here, as I've told you, The patient is only having a partial valve. Therefore, the child is able to pass the urine. The child is able to pass the urine. But what happens? The child is not able to pass the urine completely and freely. That's the reason why a lot of urine stays back in the urinary bladder. A lot of urine stays back in the urinary bladder. And if urine stays back in the urinary bladder for a longer period of time, there will be high risk of infection. Therefore, the child has recurrent infection. So the child over here presents to me with a recurrent UTI. Okay, so that is the thing. Now, if I talk about investigation of choice, so investigation of choice in this condition is a MCU. What is the MCU? I have told you, a contrast study where the patient is asked to micturate or urinate. So you will inject a dye or a contrast via his urethra into his urinary bladder. You will make his urinary bladder full with the dye, and then you will ask the patient to urinate, and then you will take the x-rays, okay, or a video. That is what is a micturating cystourethrogram. On that micturating cystourethrogram, you will be able to see that definitely the contrast is not able to move out, or the contrast is not able to freely come out. That is what makes a diagnosis of posterior urethral valve usually. Okay? What is the treatment in this condition? If I talk about the treatment in a case of posterior urethral valve, usually I will only go for emergency mein I need to relieve the complaint of the patient. And what is the complaint of the patient? The child is having urinary retention. So I will just insert a Foley's catheter. So you will say, so will Foley's catheter go? Because it is a valve. And what did I tell you? It is a unidirectional valve. That means it will not allow the urine to come out. But if we insert anything from outside, like a Foley's catheter, that can easily go inside. Okay? So this can easily go inside. Therefore, in emergency, definitely I'll go for a catheterization. That can be either a Foley's catheter, and if that is not possible, then you can go for a SPC. Usually it is possible. And definitive management, if they ask you, then definitely answer should be TURF. And what is TURF? Transurethral resection or fulgration of the valve. You will take a laser along with you and you will burn this valve. Okay. So transurethral resection or fulgration of the valves has to be done. Okay. So moving further, talking about the next one. Here we have a neonate. Okay, a neonate who was delivered preterm, usually before 37 weeks of gestation, or sometimes they will give before 36 or 34 weeks of gestation. That is a premature baby also. On examination, the scrotal sac was empty. Ultrasound performed which reveals that the right-sided testis is in the inguinal canal, but the left one is lying in the iliac fossa. What is the diagnosis? Please tell me both ones. Okay. So right-sided testis का diagnosis क्या बनेगा और left one का क्या बनेगा? Please let me know the diagnosis for both the ones. Then if I talk about, in the meanwhile, when you are answering, I will talk about UDT. And what is UDT, guys? So please remember, UDT is nothing but undescended testis. UDT is nothing but undescended testis. Now what happens? I hope all of you are quite aware that the testes are not formed in the scrotal sacs, right? Testes are formed in the abdomen. But then usually before birth, between 7 to 9 months of intrauterine life, these testes come down or they descend down into the scrotal sacs, okay, via the inguinal canal usually, along with the processus vaginalis, which is nothing but a part of peritoneum itself. Important is, if the testes are not able to come down till the scrotal sac, if testes are not able to come down till the scrotal sac, definitely the diagnosis is undescended testis. So where will the testis be? Usually the testis will be in the inguinal canal. In most of the conditions, the testes are usually lying in the inguinal canal. Okay, so please remember, if the testis cannot come down into the scrotal sac, if there is arrest in the normal descent of testis, so usually they will lie in the inguinal canal, and that is called as undescended testis. It is usually seen when a child is born preterm or premature. Most common cause is usually idiopathic. Most common cause is usually idiopathic. Okay. Now important is, okay. So important is, please remember, you can message me after the class, okay, at my Instagram channels for any other subject you need an answer for. Okay, no issues with that. So right-sided testis in the inguinal canal. So if inguinal canal mein or along the normal path, if the testis is present, then that is definitely an undescended testis. So please remember, right-sided testis is definitely undescended. But left one, is it present in the inguinal canal? Is it present in the abdomen? No. So please remember, the left one is ectopic. The left one is not lying in the normal path of descent. Okay, रास्ते में नहीं है वो. Okay, therefore the left one should be ectopic. So that is the diagnosis over here. The right side is an undescended testis, whereas the left one is an ectopic testis. The left one is an ectopic testis. Thrice it has been repeated in your exam since August 2020. This is a very important question. Okay. Now, if a child comes to you with undescended testis, the mother usually says that the scrotal sacs are empty. Okay. So usually, what is the investigation of choice for this? So please remember, the investigation of choice is usually a ultrasound. Okay. So the investigation of choice is the ultrasound, not only ultrasound of scrotum, but also the ultrasound of abdomen, because we need to find now if testis is not present in the scrotum, where it is present then. Okay. That's the important thing. Best investigation, if they ask you, it is a diagnostic laparoscopy. Okay. Best investigation is a diagnostic laparoscopy. What did I tell you? Do we perform laparoscopy to make a diagnosis? No. So it is more theoretical. Please remember. Okay. Usually we will go for a diagnostic laparoscopy. Treatment of choice, if I talk about. Okay. Treatment of choice, if I talk about. Usually, what should be the treatment? I will bring down the testis and I will fix them in the scrotal sacs. So fixation of testis will be called as orchidopexy. Fixation of testis will be called as orchidopexy. Okay. Important is if there is a bilateral undescended testis, that is called as what? So bilateral undescended testis, यहाँ पे दोनों testis hidden है, and hidden is called as crypto. Therefore, this is called as cryptorchidism. This is what is known as cryptorchidism. So hidden testis or bilateral undescended testis is known as cryptorchidism. Okay, thank you so much. So yeah. Please remember, yes, orchidopexy is usually done after 6 months of age, usually till 12 months of age. So usually you wait till a span of 4 to 5 months or maximum till a span of 6 months. Okay, so you usually wait till a span of 4 to 6 months, because in most of the patients, so usually if a child is born preterm or premature, okay, so definitely in this child, the testis will come down on its own, but just wait and watch for a while. Usually till a span of 4 to 6 months, we wait and watch, and then after that, definitely within a span of 12 months, you perform a orchidopexy in the patient. Okay, so that's the important thing. No issues with this, anybody? Then next, talking about these two conditions. What is this? In the first condition, the patient is not able to retract the foreskin or the prepuce. So this skin which is there over the glans penis is what is called as prepuce or foreskin. In the first condition, is not able to retract the prepuce or the foreskin from the glans penis. This condition is known as phimosis. This condition is known as phimosis. This phimosis is physiological. This phimosis is physiological. Normally, it is seen in children up to 6 years of age. It is physiological up to 6 years of age. If it is not physiological, if a patient is having phimosis even after 6 years of age, then definitely it is considered pathological. Okay? And why it is more important? Because if the patient is not able to retract the skin, he will not be able to clean the glans penis or the prepuce properly, and there will be poor hygiene, and poor hygiene is an important risk factor for penile cancer. That's the important risk. Okay, so usually what is the treatment for this condition? If the patient is symptomatic, then definitely for all symptomatic patients, you will go for circumcision. Okay, you will go for a circumcision, that is cutting the foreskin or the prepuce. That is known as circumcision. Whereas in the other condition, what is seen over here, the patient retracted the foreskin. उसने skin तो पीछे खींच ली. Okay, the patient retracted the foreskin or the prepuce, but he is not able to bring it back again. He is not able to bring it back again. Why? Because there was a swelling which was there. There was a swelling which is there, which is constricting the penis. There's a swelling on the penis which is constricting the penis. Therefore, he is not able to bring back the foreskin onto the glans penis. That is called as paraphimosis. Usually in this condition, we insert a Foley's catheter. Okay, we insert a Foley's catheter because as the penis is compressed, patient is not able to urinate. Therefore, we insert a Foley's and then we apply some lignocaine jelly and we try to reduce. Okay, we apply some lignocaine jelly and we try to reduce. If that also fails, then we give a small cut over here. That is called as a dorsal slit operation, and then we pull the skin ahead. That is known as a dorsal slit operation. Okay. Moving further, talking about this condition. This is the most common congenital anomaly. This is the most common congenital anomaly of male urethra. So if they say which is the most common congenital anomaly of a male urethra, your answer you need to remember is definitely what? It is definitely a hypospadias. Okay, so what is hypospadias? I hope all of you are quite aware. Usually the urethra opens at the front of the penis. Okay, urethra usually opens at the front of the penis. But if the urethra opens in the ventral aspect of the penis, okay, if the urethra opens on the downward portion or in the ventral aspect of the penis, That is what is called as hypospadias. If it opens above is known as epispadias, but that is very rare. Okay, so more common, and definitely the more common one is hypospadias. What will be the complaint of the patient? The patient will say, I am having a weak urinary stream. That means the urine falls on my feet or on my shoes itself. Okay, the urine of the patient will fall on his shoes itself. Now there are various types of hypospadias you need to remember. The most common type of hypospadias is when the urethra opens on the glans penis. Okay, so it is known as granular. Okay, so granular is the most common type of hypospadias. Granular is the most common type of hypospadias, and here the patient will not even have any problem. So it is the least severe type. But if I talk about the next one over here, this one, when the urethra opens onto the perineum of the patient, when the urethra opens between scrotum and the anal canal in the perineum of the patient, this, please remember, is considered as the least common variety, and it is also the most severe variety. Least common and the most severe variety. That's important. Okay. What is the treatment for hypospadias in the patient? If I talk about the treatment of hypospadias, a lot of patients of hypospadias will have this curvature. Okay, a lot of patients of hypospadias will have this curvature, and this downward curvature of the penis. Okay, it is not only seen when the penis is erect, it is also seen when the penis is flaccid. So the curvature is usually seen in a flaccid or erect penis both. This is what is called as chordae. So this chordae is also seen usually in a case of hypospadias. So treatment will be what? Treatment is usually we need to perform a orthoplasty, that is the chordae correction. Then I need to perform a urethroplasty as well. I need to prepare a new urethra. Then granuloplasty has to be done. Granuloplasty. Okay? And then definitely we need to prepare a skin cover as well. Now important is this new urethra which is prepared, or the urethra that we are repairing. Okay, we need to lengthen the urethra now. So this urethra is lengthened, or the new urethra which is prepared with the help of the foreskin itself. So if the foreskin is cut, can the patient be treated for hypospadias? No. So that's the reason why. Please remember, what is contraindicated in a case of hypospadias? Circumcision is contraindicated in a case of hypospadias because we need that foreskin, or we need that prepuce for reconstruction of the urethra or repair of the urethra. That's the important thing. Chalo. Okay, but the next one, here also we have the curvature of a penis. Okay, it can be upward or downward. It is usually towards the side of this fibrous plaque. So what is present in the penis? I hope all of you are quite aware there is corpora cavernosa and corpora spongiosa in the penis. So usually in the corpora cavernosa, if such fibrous plaque is present, so towards the direction of the fibrous plaque, the penis will be having a curvature. Important is, here the flaccid penis is absolutely normal. Here when the penis is not erected, it is absolutely normal. It appears straight. But a erect penis is having a curvature. Okay, the erect penis will be curved. Okay, so the patient will get a curved erection. Normally the penis is absolutely fine, but the patient is getting a curved erection. This condition, when a fibrous plaque is formed in the penis, is known as Peyronie's disease. This is what is called as Peyronie's disease. And important is, in cases of Peyronie's disease, what is the treatment? Usually we don't go for any treatment. Yes, reassurance is the treatment. Why? Because this is a self-limiting condition. It will resolve on its own. अपने आप चला जाएगा 3 से 5 साल में. So reassurance should be done. Because it is a self-limiting condition, it will resolve on its own within a span of 3 to 5 years. But if it does not go, then definitely we need to go for an operation, and that is called as a Nesbit's operation. That was a previous year question. We go for a Nesbit's operation. And what is done in Nesbit's operation? In the opposite sided cavernosa, we will place a non-absorbable suture. In the opposite sided cavernosa, we will place a non-absorbable suture so that the penis gets straight. Next is, what is priapism? What is priapism? Priapism is nothing but painful, persistent penile erection. Priapism is nothing but painful, persistent penile erection, which is lasting for how much? Which is lasting for more than 4 hours. So painful, persistent penile erection, which is lasting for more than 4 hours, is called as priapism. Most common cause of priapism overall is idiopathic. Most common cause of priapism overall is unknown or idiopathic. But it can occur secondary to some conditions. And what are those conditions? It commonly occurs secondary to a trauma. So in an over-enthusiastic or a violent sexual intercourse, there can be chances of priapism as well. Okay. Apart from that, it can occur secondary to overdose of sildenafil as well, which is a phosphodiesterase 5 inhibitor. Okay, so due to overdose of sildenafil, or when we get an injection of papaverine, that can also cause priapism, or it can be seen in cases of spinal cord diseases or malignancies as well. But if they ask you the most common cause of priapism in children, now important is to remember, you might have studied it in pediatrics as well. The most common cause of priapism in children is usually sickle cell anemia or leukemias. It is usually sickle cell anemia or leukemia. Why? Because the penile vessels are usually obstructed by these sickle cell RBCs. Therefore, all the blood remains in the penile vessels, and that causes penile erection in this patient for a longer duration of time. This is called as a vaso-occlusive crisis in a case of sickle cell anemia that you see. Okay? So, sickle cell anemia or leukemias definitely. If I talk about treatment, what should be done for treatment? We try to aspirate. Why there is an erection? Because there is a lot of blood inside the penis. So try to aspirate that blood. Okay, blood nikalo usme se. So aspiration of blood should be done from corpora cavernosa. Aspiration of blood should be done from corpora cavernosa. Okay, that has to be done. Aspiration of blood from corpora cavernosa has to be done definitely. Okay, if that fails, definitely you will go for a shunt operation. Next, if I talk about penile cancer in the patient, guys. If I talk about penile cancer, please remember, penile cancer, what is the most common site of penile cancer? So usually, penile cancer, the most common site is usually the glans penis or the prepuce. If both of them are in the same option, that's the best answer. So glans penis and prepuce have equal chances of penile cancer definitely. Okay, please remember, here usually how the patient is going to present to you. Okay, so please remember, the most common cause for it, as I've already told you, the most common cause for it is nothing but poor hygiene. The most common cause for it is nothing else but poor hygiene. Okay, important. And how the patient is going to present to you? The patient will present to me with a ulceroproliferative growth. Okay, there is a ulceration, and as well as will be a somewhat mass. There will be a ulceroproliferative growth on the penis, with which the patient is going to present to us usually. Okay, so here you can see the ulceroproliferative growth is seen over the penis. Okay, so you have retracted the foreskin and you can see this growth over here. This is the case of penile cancer. Important is, what is the investigation of choice? You can see definitely, okay, the growth or the ulceration, the patient is having pain, or there can be sometimes bleeding also. That is all evident. The cancer is outside the body. Investigation of choice is a direct biopsy. Investigation of choice is a direct biopsy. Important is, if there is involvement of the lymph nodes. If there is involvement of the lymph nodes, what should be done? So if the lymph nodes are enlarged, if the lymph nodes are palpable, definitely I can go for lymph node clearance. If the lymph nodes are palpable, I can definitely go for a lymph node clearance. But in a case of penile cancer, if the lymph nodes are not palpable, then what should be done? Then a surgeon came known as Cabana. This Cabana, he thought, though the lymph nodes are not palpable in a case of penile cancer, there is a high chance that these lymph nodes can be involved with cancer. Therefore, he performed a procedure called as sentinel lymph node biopsy. And sentinel lymph node biopsy was first time done for penile cancer. And nowadays, it is known as Cabana's procedure. Okay, therefore, please remember, sentinel lymph node biopsy is known as Cabana's procedure. That's the reason for it. Okay, and the sentinel lymph nodes are nothing but the first draining lymph nodes of a cancer. Okay, it is the first draining lymph nodes of a cancer. Usually in penile cancer, it is the inguinal group of lymph nodes. Moving further, now talking about the staging investigation of choice. For staging investigation of choice, we'll go for a MRI. Staging investigation of choice is usually a MRI. What will be the most common cause of death in a patient? The most common cause of death in a case of penile cancer is usually torrential hemorrhage. What do I mean by torrential hemorrhage? Excessive hemorrhage. Why? Because this cancer will damage the femoral vessels and the iliac vessels, and that will cause excessive hemorrhage that can lead to death of the patient as well. Treatment of choice is what? Definitely cancer has to be removed. But please remember, if this is the penis, if this is the cancer over here, so if I take a 2 centimeter margin usually, okay, if I take a 1 to 2 centimeter margin, then after removal of the penis, if more than 2 centimeter penis would be left behind, then I will only go for a partial penectomy. If more than 2 centimeter penis can be left behind, if more than 2 centimeter penis or a stump is left behind, then definitely I will only go for a partial penectomy. But please remember, if the cancer is somewhere over here, If the cancer is somewhere over here, can you leave behind 2 centimeters of penis? No. So there is no use of keeping such a small penis. If less than 2 centimeters of stump will be left behind, better is remove the whole penis itself. That is total penectomy. Better is do a total penectomy. And where will be the urethra placed? Now the urethra will be placed in the perineum. So you will go for a urethroplasty in the perineum. Okay, there will be a perineal urethroplasty. A new urethra will be placed in the perineum. That's important. Chalo. Now talking about this condition. What is this? You can see a child has been brought to us with a complaint of scrotal swelling or scrotal enlargement. Okay. And when we flash a torch light, it will definitely glow or it will illuminate. This is a trans illumination test. And you can see the trans illumination test turns out to be positive. Okay. Scrotal swelling and the trans illumination test is positive. It is a case of hydrocele. It is a case of hydrocele. What is hydro? Liquid. So there is fluid which is filled in the cavity. And what is that cavity? Nothing but the scrotum. So there is fluid which is filled inside the scrotal sac. That is what is called as hydrocele. Now hydrocele can be of various types, guys. Hydrocele can be of various types. So please remember, usually the fluid is present in this processus vaginalis. This fluid is present in the processus vaginalis. Please remember that. Okay? So if the fluid is only limited to the scrotum, if the fluid is only or the swelling is only limited to the scrotum, this is called as the most common type of hydrocele known as vaginal hydrocele. So the most common type of hydrocele is known as vaginal hydrocele, where the swelling is only present in the scrotum. But the patient is also having swelling in the scrotum, along with the swelling is also reaching up to the inguinal canal. Okay, the patient has swelling in the scrotum as well as the inguinal canal. That means the patient is having a inguino-scrotal swelling. Not only a scrotal, but a inguino-scrotal swelling. That means definitely this is a case of an infantile hydrocele. This is a case of infantile hydrocele. Next one. Here you can see the processus vaginalis is completely open and therefore it is communicating with the abdominal cavity. So there is a communication of the scrotal sac with the abdominal cavity. Okay, and there is a continuation. There is a continuity which is between the scrotal sac and the abdominal cavity. And this is a case of a congenital hydrocele. This is a case of a congenital hydrocele. And the last one is nothing but an encysted hydrocele, which is very rare. Encysted hydrocele. Important is what should be the treatment. If it is a case of congenital hydrocele, the treatment is different. Because please remember, here in congenital hydrocele, we will just open up the scrotal and we will drain all the fluid. Okay, we will drain all the fluid. That is what is done. And that is same procedure which is also done for congenital hernia. Therefore, for congenital hydrocele, the treatment which is performed is known as herniotomy. Okay, the treatment which is performed is known as herniotomy. Okay? If I talk about the investigation, as I've told you, definitely the patient either comes to you with a case of scrotal swelling or a inguino-scrotal swelling. Okay, and the trans elimination test will be classically positive. Okay, investigation of choice if they ask you. I told you which investigation is a friend of a fluid. Definitely an ultrasound. So definitely you go for an ultrasound scrotum in this patient, and on that you can see a lot of fluid present inside the scrotal sac. Okay, that makes your diagnosis. In cases of hydrocele, vaginal or infantile hydrocele, what should be the treatment now? So if I talk about the treatment, important is, please remember, as I've told you, congenital hydrocele treated by herniotomy. But for other hydroceles, you need to see whether it is a small hydrocele or a large hydrocele. If it is a small hydrocele, see, I will just open up, I'll make an incision of the scrotum, I'll drain all the fluid, and then I'll just plicate this. Okay, I will just suture these margins over here on the side of the scrotum of the testis. Okay, I'll just suture these margins on the sides of the testis. This is called as the Lord's plication surgery. In a case of small hydrocele, I will only go for a Lord's plication surgery. But if it is a large hydrocele, I will open up the scrotal sac, or I will make an incision of the scrotum. I'll drain all the fluid and then I'll evert the edges. I'll drain all the fluid and I'll evert the edges, and then I'll suture them back. This is what is called as the Jaboulet's procedure. This is what is known as the Jaboulet's procedure. Okay, where we will do a eversion of the sac. That is important. Okay. Moving further. Next, if I talk about varicocele. What is a varicocele, guys? So please remember, varicose, I have already told you, varicose or varices is nothing but abnormally dilated and tortuous vein. जब vessels बहुत ज़्यादा dilate हो जाती है और tortuous हो जाती है, आड़ी टेढ़ी हो जाती है, that is what is varicose. So varicocele is nothing but a cavity which contains varicose veins over here. And what is that cavity now? This time the cavity is the scrotum. So varicose vein is nothing but abnormal dilatation. It is nothing but abnormal dilatation and tortuosity. It is nothing but abnormal dilatation and tortuosity of veins. Which veins? Testicular veins. And which is the specific testicular veins? So it is the pampiniform plexus of testicular veins. It is the pampiniform plexus of the testicular veins. It is the pampiniform plexus of testicular veins which is there. Okay, pampiniform plexus of testicular veins which is commonly involved in a case of varicocele. What is the most common cause of varicocele? So usually, please remember, most common cause of varicocele is again idiopathic. Yes, it is again idiopathic, but it can occur due to various other conditions. Whenever there will be increased intra-abdominal pressure, like if there is an abdominal tumor or a pelvic tumor, these veins are not able to drain, and that is the reason why there will be a lot of blood collection in these veins. These veins will undergo dilatation and tortuosity, and that causes varicocele. Okay? So most common cause is idiopathic. Investigation of choice, if I talk about, here we need to see the vessels, and if we need to see the vessels, definitely the investigation of choice should be a color Doppler. The investigation of choice is a color Doppler. Okay, as I've told you yesterday. And if I try to palpate this, if I try to palpate the scrotosac of this patient, I'll feel that there is a sac which contains a lot of earthworms. What are the कीड़े अंदर? Okay, so that is what is called as a bag of worm feel. And that is a keyword to diagnose your question. A bag of worm feel will be there. Okay, usually. What should be the treatment of choice? So treatment of choice usually can be embolization. We can just embolize the artery, main vein, or we can go for a varicocelectomy. What is a varicocelectomy? That is removal of the veins which have undergone abnormal dilatation and tortuosity. Okay? Next is this question. Now let me know the diagnosis if you have not slept. Okay. So what is the diagnosis over here? A 15-year-old male, that is a young adolescent or a teenager male is there, who presents to me with sudden severe scrotal and abdominal pain. Sudden severe scrotal as well as abdominal pain. On elevating the scrotum, his pain is not relieved. Okay, तुमने scrotum उठाई, support दिया, then also the pain is not relieved. What is the diagnosis? What is the diagnosis? Sorry. What is the diagnosis in this condition, guys? So please remember the diagnosis in this condition. It is a case of testicular torsion. It is a case of testicular torsion. What is a testicular torsion? So please remember here. Okay, the testis. Here, what has happened? The testis is hanging like this. The testis is hanging like this. Okay. Now, usually, what did I tell you always? The layer which is there, it is supporting the testis like this, no? Testis is always, it should be like this. But when the tunica vaginalis which is there, na, it is not till the base of the testis. It is only till the top of the testis. What can happen? There can be twisting of the testis or twisting of the spermatic cord. This is what is called as testicular torsion. When there is a twisting or malrotation of the testis, this is what is called as testicular torsion. Please remember, that is what is known as testicular torsion. Okay, so testicular torsion is usually seen in this kind of a condition. And what is this? As I've told you, when the tunica vaginalis is only till the top of the testis. This is known as which deformity? This is classically known as the bell clapper deformity. Okay, so testis hangs like a clapper of a bell. Okay, घंटे की जैसा लटकता रहता है. That is what is a bell clapper deformity. You need to remember. That will increase the risk of testicular torsion. Testicular torsion is generally commonly seen in younger males, usually between 15 to 25 years of age or 15 to 30 years of age maximum. Okay, so it is more common in younger or adolescent males, and important is usually how to differentiate it, because here also the patient will have a sudden severe abdominal and a scrotal pain. The patient can also have sometimes a low grade fever. There will be redness, there will be swelling of the scrotum. These are all the signs which are also seen in the infection of testis. And what is that infection of testis and epididymis called as? That infection of testis and epididymis is called as epididymoorchitis. Okay, so you need to differentiate between epididymoorchitis and testicular torsion. Okay, So to differentiate between epididymoarthritis and testicular torsion, the test that we use is known as the French test. The test that we use is known as the French test. What is done in the French test? Please remember, we will try to support the testis. Okay, we will try to support the scrotal sac. We will try to elevate the scrotal sac. When we elevate the scrotal sac or we will support the scrotal sac, pain will be relieved. Then the diagnosis is epididymoarthritis. Agar pain relieve hota hai, then it is a case of epididymoarthritis. Because it was the inflamed testis, it was hanging, so it was paining. So as soon as we have supported, the pain is relieved, it is a case of epididymoarthritis. But even after supporting the testis or even after supporting the scrotum, the pain is not relieved, then that is the case of testicular torsion. Okay. Now, what is the investigation of choice for diagnosis? So usually it is a clinical diagnosis which is done. Please remember, it is a clinical diagnosis. But if you need an investigation to see whether the testis has undergone a necrosis or not. Why the testis will undergo necrosis? Because I have told you that the spermatic cord is undergoing twisting. And the spermatic cord contains the testicular artery and the testicular vein. The vessels of the testis are present in the spermatic cord. That's the reason why there will be decreased blood supply to testis and there can be chances of testicular necrosis as well. That is the reason why you need to go for an ultrasound and you need to see that whether the testis has undergone any necrosis or not. If the testis is normal, if the testis has not undergone any necrosis, then definitely it is considered as a viable testis. And if it is a viable testis, please remember, that means alive testis. Viable ka matlab hota hai jinda, alive. Okay, no necrosis is there. So if it is a case of alive testis definitely or viable testis, we will go for what? We will go for derotation. We will go for derotation and fixation of the testis. And fixation is called as orchidopexy. Okay, so derotation and orchidopexy has to be done. But if it is a non-viable testis, that means the testis has undergone necrosis already. So no use of keeping the testis over there. We will go for orchidectomy. Okay, we'll go for the orchidectomy. In both the conditions, as the patient is having a bell clapper deformity, ऐसा तो नहीं होगा ना कि एक ही scrotum में bell clapper है. The patient will be having bell clapper in both the scrotum. Therefore, either you go for orchidopexy or orchidectomy. Always go for a contralateral orchidopexy as well. Okay, in the same setting or in the same surgery, also fix the opposite sided testis. Otherwise, the patient can come to you after a few days with the complaints of another sided testicular torsion. Here you can see this is a necrosed testis which is seen. That is important. Now talking about testicular tumor. If I talk about the testicular tumor, important is which is the most common testicular tumor. Okay, the most common testicular tumor in children usually, it is called as a yolk sac tumor. The most common testicular tumor in children is a yolk sac tumor. The most common testicular tumor in adults, we know overall also it is the most common testicular tumor and it is more common in younger males. That is known as seminoma. Most common testicular tumor overall in adults is known as seminoma. If that is not an option, the second most common is a teratoma. And I hope all of you are quite aware from gynae. Teratoma is nothing but a tumor which arises from all the three germ layers. There's derivatives of all the three germ layers, ectoderm, endoderm, mesoderm. It can form anything. Okay, in the ovaries also or in the testis also, there can be a teratoma. Elderly patient mein the most common testicular tumor is a lymphoma. Okay, and if they ask you which is the most common bilateral testicular tumor, answer is lymphoma. Which is the most common bilateral testicular tumor, answer is a lymphoma. Okay? Important is usually what are the tumor markers for testicular tumor. Please remember the classical seminomas which are there. They will never be positive for alpha fetoprotein. A lot of misconception is there that classical seminomas test positive for alpha fetoprotein. No. Non-classical seminomas are positive for alpha fetoprotein. Non-classical ones, not the classical variety. Please remember. Or we can use LDH. Yes, LDH is the variety. LDH is the tumor marker for classical seminoma. LDH is the best tumor marker for classical seminoma. Okay? And the third one, which is used for yolk sac tumor or embryonal tumor, usually it is the beta SCG. Okay, so it is the SCG which is there. Okay, it is the SCG which is there. No issues with this, anybody? Treatment is always and always high inguinal orchidectomy. Treatment is always a high inguinal orchidectomy. Okay, so removal of the testis has to be done. High inguinal orchidectomy has to be done. Investigation of choice, if I talk about, please remember, investigation of choice is never a biopsy. Okay, investigation of choice for a testicular tumor is never a biopsy. Usually, please remember, it is the ultrasound that we do. And as testicular tumor can metastasize to the pre-aortic and the para-aortic lymph nodes, we sometimes also need to do a CCT of the abdomen as well, because it metastasizes to the pre-aortic and para-aortic lymph nodes. That's the important thing. Okay. Now talking about the last topic of urology, and that is what is BPH and prostate cancer. So if I talk about prostate gland, I hope all of you are quite aware it is at 20 grams in size. It usually has 5 lobes, 5 anatomical lobes, anterior, posterior. Okay, there is anterior, posterior, medial, or the central one, and there are 2 lateral lobes. There are 3 McNeil surgical zones. The beach wala is known as central zone. Then we have the transitional zone, and last is the peripheral zone. Now there are 2 important conditions in prostate. Both of them usually occur in elderly patients, elderly males, usually beyond 50 years of age. One is called as BPH, benign prostatic hyperplasia. What is hyperplasia? Increase in the number of cells. So in the prostate also there is increase in the number of cells, due to which the size of the prostate increases. The size of the prostate increases. Here there is no cancer. Therefore it is called as a benign condition. Okay? Important is BPH is very common in elderly patients. Now what will happen? What was passing in between the prostate? The prostatic urethra. Now as the prostate is increasing in size, what will happen? As the prostate is increasing in size, definitely it will compress the prostatic urethra. As it is increasing in size, it compresses the prostatic urethra, and if the urethra is compressed, will the patient be able to pass urine? No. So the patient will have a lot of urinary complaints. Patient will not be able to pass urine. Okay, there will be nocturia in the patient, there will be hesitancy, there will be intermittency. Okay, so all of these, there will be urinary retention. Okay, all of these features will be there. Overflow incontinence or urge incontinence can be there. So all of these urinary symptoms will be there. So BPH, the most common age group, as I've told you, it is more common in males who are more than 50 years of age. Most common site usually for a BPH is which zone of the prostate, that has been asked a lot of times. So for BPH, the most common site is the transitional zone of the prostate. Okay, it is the transitional zone or the medial and the lateral lobes. Okay, if they ask you if a patient is having, what will be the symptoms? So the clinical features, as I've told you, it will be LUTS. What is LUTS? Lower urinary tract symptoms. The patient will have a lower urinary tract symptom. The stream of the urine will be very weak. Okay, poor flow of urine will be there. That is, okay, the patient will say, Doctor Saab, patli dhar aa rahi hai. That is what is decreased stream of urine will be there, and a lot of other complaints. Okay, so that will always occur because, as I've told you, the urethra is compressed due to the enlarged prostate. Okay, the enlarged prostate is compressing the urethra. Lower urinary tract symptoms. Now, what is the investigation? Usually, for investigation of choice, I'll perform a ultrasound. For investigation of choice, I'll perform a ultrasound, and on that ultrasound, it is a ultrasound kidney, ureter, bladder, and prostate, KUBP. So on that ultrasound, definitely, what I'll ask the patient, I'll perform the ultrasound before the patient urinates and after the patient urinates. Even after urination, if the bladder is having more than 100 ml of urine, even after urination, पेशाब करने के बावजूद 100 ml से ज़्यादा की urine है, that means the patient was not able to urinate properly, and that is what is a diagnostic of BPH in a patient. If they ask you what is the first line management, we will not go for surgical management as the first line. The first line management is always the medical management, and here it is drug of choice. The drug of choice is what? The drug of choice is usually a selective alpha 1A blocker, and that selective alpha 1A blocker that we have is known as tamsulosin. Okay, it is known as tamsulosin. So if a patient does not have hypertension, please remember, in that patient we only give a selective alpha 1A blocker like tamsulosin or silodosin. But if a patient is having BPH along with hypertension, then we can prefer a alpha 1 blocker like prazosin. Otherwise it is tamsulosin. Along with tamsulosin, we will give another drug which will help decreasing the size of prostate. But that is not the drug of choice. Why? Because here the main complaint of the patient is urinary problems. If you give another drug which will decrease the size of prostate, that will take 3 months to act. Okay, so till that time the patient will have the problem. Therefore, you will give another drug which is a 5-alpha reductase inhibitor known as finasteride. That should be given. But if this medical management fails, then you need to go for a surgical management. And what is that? That is called as TURP. What is TURP? Transurethral resection of prostate. Okay, nowadays you usually use a laser. Either a Nd:YAG laser is used or a holmium laser is used. Okay, so either you prefer using a Nd:YAG laser or a holmium laser. You will go via the urethra of this patient till the prostatic urethra, and you will burn the excess amount of prostate tissue. That is what is called as TURP, transurethral resection of prostate. Important is, there is an important complication of TURP, And the complication of TURP which is there, please remember, it is known as a TURP syndrome or a water intoxication syndrome. It is known as TURP syndrome or a water intoxication syndrome. What happens if we use hypotonic fluids? What is hypotonic? Low concentrated fluids like 5% dextrose or distilled water for irrigation during surgery. What will happen? A lot of water will go inside the blood vessel of this patient. And if a lot of water goes inside the blood vessel of this patient, patient will have dilutional hyponatremia. Due to that, patient will suffer from altered sensorium or even seizures can occur in the patient as well. Okay? So that is the problem in cases of water intoxication or TURP syndrome. So therefore, important is what should be done for prevention. So for prevention, definitely we need to use a better fluid which does not have higher concentration or a lower concentration. That is called as isotonic glycine. So isotonic glycine is the best fluid to be used to prevent TURP syndrome or water intoxication syndrome after transurethral resection of prostate in a patient. No issues with this, anybody? That's important. Next, if I talk about is prostate cancer. If I talk about prostate cancer, guys, the most common site of prostate cancer, it is which zone of the prostate now? So here it is the PPP, you need to remember. That is, prostate cancer is more common in the peripheral zone and in the posterior lobe. Okay? So here it is the peripheral zone of the prostate which is commonly seen in cancer. So that's the reason why they commonly ask you, because the sites are different in prostate cancer and BPH. Here also it is more common in patients more than 50 years of age. Okay, and so that is the reason why a lot of elderly male patients should undergo screening of prostate cancer. Okay, and for screening, two things are done. One, we will go for a digital rectal examination. When we perform a digital rectal examination, we will feel that the size of prostate is enlarged, okay, anteriorly. Along with that, we will check for the tumor marker, and that tumor marker for prostate cancer is serum PSA, prostate specific antigen. Okay, prostate specific antigen. Normally it is between 0 to 4 nanograms per ml. Then important is, here what are the sentinel lymph nodes? The first draining lymph nodes of a prostate cancer are the same as bladder cancer. And what were those? Obturator lymph nodes. Okay, it is the obturator lymph nodes. So those can also be enlarged at times. Important is, what is the investigation of choice? So investigation of choice for a prostate cancer. Okay, so the investigation of choice for a prostate cancer is usually a truss guided biopsy. What is a truss guided biopsy? It is nothing but a transrectal ultrasound guided biopsy. So we will insert a ultrasound probe via the rectum of this patient and then we'll take a biopsy. Transrectal ultrasound guided biopsy. Now, once we have made the diagnosis of prostate cancer, if the disease is localized in the prostate, if the disease is only localized in the prostate, then definitely what should be the treatment? Then I will only go for a radical prostatectomy. That means only remove the prostate along with lymph nodes. But if the disease is advanced, that means the disease has spread outside the prostate, distant metastasis has occurred, then definitely I will mostly go for a palliative care in this patient. I'll go for a palliative care. Important is, what is the most common site of metastasis? So as you can see in this picture also, as I've discussed in breast cancer yesterday, I've told you that prostate cancer is the one, apart from breast cancer, which can be treated with hormonal therapy, because here, what is the problem? In breast cancer, excess of estrogen was causing prostate cancer. Here, excess of testosterone is causing prostate cancer. So we can give testosterone antagonist or GnRH analogs in a continuous fashion in a case of prostate cancer. So hormonal therapy can be used over here. Now, if they ask you what is the most common site of distant metastasis in a case of prostate cancer, I told you everything is same. That means here also the more common route of spread is hematogenous. The most common site will be the bones, and which are the bones? Usually it is the lumbar vertebra. Okay, it is the lumbar vertebra definitely. Okay, as you can see, the only thing which differs is the spread occurs via the Batterson's plexus of veins only. The only thing which differs in breast cancer, there was a osteolytic metastasis which was more common. That is bone todne wala or bone breaking metastasis which was more common. Here you can see it is a bone forming metastasis or an osteoblastic metastasis which is more common. Rather, if they ask you which is the most common cancer in the body which can have this osteoblastic metastasis, answer should be prostate cancer. Okay? So here, if a patient, elderly patient coming to you with low backache, only low backache, think in terms of multiple myeloma. But if a elderly patient is coming to you with low backache along with urinary symptoms, then think in terms of metastatic prostate cancer. Okay? Last topic for today and for whole surgery will be your hernia. If I talk about hernia, guys, definitely, please remember hernia is nothing but what? if some organ is coming out from somewhere, that is what is a hernia. For example, what is the definition of hernia? It is protrusion of a viscous or a part of a viscous through the wall containing it. What do I mean by this? That means what is present inside the abdomen? The intestines are present inside the abdomen. These are called as your viscous or visceral organs. Okay? So if the intestine is coming out via the abdominal wall, if the intestine is coming out via the abdominal wall, that is what is a hernia. That is what is a hernia. No issues with this. So if the organ which is present inside the cavity comes out, that is what is a hernia. If I ask you which is the most common hernia overall, the most common hernia overall is the indirect inguinal hernia. It is the indirect inguinal hernia. Okay, I'll talk about the direct and indirect, don't worry. Next, which is the most common hernia in elderly patient? Which is the most common hernia in elderly patient? Please remember, it is the direct inguinal hernia. Okay, it is the direct inguinal hernia. And just answer this question of mine, which is the most common hernia in females? Which is the most common hernia in females? Please answer that question in the chat box. Till that time, I'll explain to you what is the basic difference between a indirect and a direct inguinal hernia. If I talk about a direct and indirect inguinal hernia, the basic difference I want to explain will be, just a minute. So this is what is your inguinal canal. Okay, this is what is your inguinal canal. You can see over here. This is the deep ring of your inguinal canal, which is circular in shape, and the triangular one is the superficial ring of your inguinal canal. Deep inguinal ring is nothing but a defect in the fascia transversalis, whereas superficial inguinal ring is nothing but a defect in the external oblique aponeurosis. And in between both these rings, the yellow color structure that you can see is nothing but your inguinal canal. And via this inguinal canal, please remember, usually if the hernia comes out, okay, if the hernia is coming out via the deep inguinal ring, if the intestines or the hernial sac is coming out via this deep inguinal ring, and then it is going into the inguinal canal, sometimes it will also go into the scrotum. This is a case of indirect inguinal hernia. It is a case of indirect inguinal hernia. That's important. Please remember, if a hernia passes via the deep inguinal ring, it is a case of indirect inguinal hernia. Whereas over here, we have a weak site, and that weak site is what is called as the Hasselbalch's triangle. This is known as the Hasselbalch's triangle. So if the hernia comes out directly via the abdominal wall from the Hasselbalch's triangle, this is what is called as the direct inguinal hernia. Okay? So please remember the basic difference between a direct and an indirect inguinal hernia. Indirect usually is more common in young population, but direct inguinal hernia is more common in the elderly population. Why? Because the abdominal wall of the elderly people, it becomes weak, it becomes lax. Okay, बहुत ज़्यादा weak हो जाती है, इसलिए क्या होता है, hernia directly बाहर आता है. It passes via, as I've told you, indirect inguinal hernia passes via the deep inguinal ring. Okay, it should pass via the deep inguinal ring, but direct hernia directly comes out from the abdominal wall and from that weak area. And what was that weak area called as? It is known as the Hasselbalch's triangle. Direction of hernia. Please remember, the direction of inguinal hernia, it is forwards, it is medially. Okay, so it is forwards, it is medially, and it is inwards as well. Whereas direct inguinal hernia, it is only forwards. It will only come forwards. It will not go medially. Okay, it will only come out forwards. Then if I talk about relation with the inferior epigastric vessel, okay, so for example, this is your inguinal canal. Okay, this is your indirect inguinal hernia over here. Okay, and this is your Hasselbalch's triangle, and from that you have this direct inguinal hernia coming out. In between both of them, you have this inferior epigastric artery and the inferior epigastric vein. Okay, so these are the inferior epigastric vessel. So you can see if the hernia lies lateral to the inferior epigastric vessel, it is the indirect inguinal hernia. But if the hernia lies medial to the inferior epigastric vessel, it is the direct inguinal hernia. That's the basic idea. Okay, so please remember, the landmark to differentiate a direct and indirect are the inferior epigastric vessels. Scrotal extension. Usually which hernia goes till the scrotum? I told you. Usually it is the indirect inguinal hernia which commonly goes till the scrotum, whereas scrotal extension is very rare in the direct one. Please remember that. Okay. Now if I talk about the other types of ventral hernias. What are ventral hernias? The hernias which come from the abdominal wall, anterior abdominal wall, are called as ventral hernias. This, if it arises from the epigastric region, it is known as the epigastric hernia. If it arises in the umbilicus, at the umbilicus, it is known as umbilical hernia. If it arises around the umbilicus, then it is called as a paraumbilical hernia. It is known as paraumbilical hernia. Then if it is along the lateral border of the rectus abdominis muscle, if it is along the lateral border of rectus abdominis, it is known as the Spigelian hernia. If it arises from a previous scar or a previous incision, then it is called as the incisional hernia. Okay, and these are the inguinal and femoral hernia. Important is how to differentiate a inguinal from a femoral hernia. So please remember, femoral hernia will be somewhere over here. Important is, okay, it will be somewhere over here. Okay, यहाँ पे होगा. Important is the differentiating landmark is the pubic tubercle. Okay, it is the pubic tubercle. So please remember to differentiate between a femoral hernia and a inguinal hernia. We have the pubic tubercle. How to differentiate? If the hernia is above, and medial to the pubic tubercle, if it is above and medial to the pubic tubercle, it is an inguinal hernia. But if the hernia is below, and lateral to the pubic tubercle, it is a femoral hernia. If the hernia is below and lateral to the pubic tubercle, it is the femoral hernia. Please remember that. No issues with this, anybody? That's important usually. Okay. So these are the various types of ventral hernias. Very good. Some people are right, some people are wrong. Please remember, femoral hernia is not the most common in females. Please remember, in females also the most common type of hernia is the indirect inguinal hernia. Females also the most common type of hernia is the indirect inguinal hernia. What does the book says? The book says that femoral hernia is more common. Femoral hernia is more common, not most common. Femoral hernia is more common in females as compared to males. It is 4 times more common in females as compared to males. It is not the most common. Most common type of hernia in females is also the indirect inguinal hernia itself. Okay, so that's the important thing. Now if I talk about the various types of inguinal hernia, usually the indirect inguinal hernia. So these are the different types of indirect inguinal hernia. So please remember, if the hernial sac is only till the inguinal canal, it is called as a bubonocele. If the hernial sac is till the top of the scrotum, then it is called as a funicular hernia. When the hernial sac is till the base of the scrotum, when the hernial sac is coming till the base of the scrotum, it is a complete inguinal hernia. No issues with this, anybody? That's important. Then when a patient of hernia comes to me, how I am going to examine the patient? I am going to examine the patient in 2 positions. First is the standing position. I will try to check the shape, the size, the consistency of the hernia. What is the content of the hernia? Okay? Apart from that, I will also check the cuff impulse. If cuff impulse is present or not. Why? Because if cuff impulse is not present, that is what is suggestive of an emergency in hernia. And what is that? Either it is a strangulated hernia. What is strangulation? Decreased blood supply. Either it is a case of a strangulated hernia or it is a case of obstructed hernia. Okay, either of it can be there. So if cuff impulse is absent, please remember, it can be a risk. There can be a risk of obstructed or strangulated hernia in the patient. That's important. Okay, so that you need to remember properly. So first is cuff impulse. On examination, I need to check the cuff impulse of the patient and standing position. Then when the patient lies down in supine position, what I need to check? When the patient lies down, I need to check the reducibility. What is reducibility? I will try to push back the hernial contents. Okay, I will try to push back the hernial sac. Okay, if I am able to push back the hernial sac, अगर मैं पीछे ढकेल सकता हूँ पूरी hernial sac को, that means the hernia is reducible. But if the hernial sac could not be reduced, that is called as an irreducible hernia. So that is important. Okay, if it is reducible hernia and if the cuff impulse is present, no issues. But if the cuff impulse is absent or it is an irreducible hernia, that is either suggestive of a strangulated hernia or it is suggestive of an obstructed hernia. Why there is a strangulated or obstructed hernia? Because the neck of the hernial sac is very narrow, and due to this narrow neck, the blood supply can be cut off or the hernial sac can be obstructed. So in these conditions, we need to consider it as emergency. These conditions are emergency. Which hernias can commonly strangulate? Femoral hernia, incisional hernia, and the Spigelian hernia. These are the 3 important hernias which commonly strangulate. If I talk about the ventral hernias, okay, that is your abdominal wall hernias. The treatment will be what? If it is a small defect, guys, if it is a small defect, I will go for a Mayo's repair. What is a Mayo's repair? I will push back the hernial contents. And I'll suture back the defect. Okay, I'll suture back the walls. That is what is called as a Mayo's repair or a herniorrhaphy. But if it is a large defect, guys, If it is a large defect, then I need to use a mesh. Okay, then I need to use a prosthetic patch, or I need to use a mesh definitely. Okay, then definitely a prosthetic patch or a mesh has to be used. So will be a prosthetic patch repair, not just a suturing, a prosthetic patch repair. That was about your abdominal hernias or your ventral hernias. But if I talk about your inguinal hernias, definitely please remember, before that, I'll just tell you the names of your femoral hernia surgeries. Femoral hernia surgeries, just remember the name. It is also same over there. You will reduce the contents and you will place a mesh or a barrier. These are usually called as the Lockwood's repair. It is known as Lockwood's repair. It is called as a McEvidy's repair, or it is known as the Lotheson's repair. These are the femoral hernia surgeries which are commonly done. Okay. Then if I talk about the inguinal hernia, either it can be an open surgery for the inguinal hernia or a laparoscopic surgery. If I talk about the open surgery, please remember, if I talk about the open surgery for an inguinal hernia, okay, the one thing that you need to remember over here, it is called as a proline mesh hernioplasty. Open surgery for a hernia is called as proline mesh hernioplasty. What is hernioplasty? Plasty का मतलब होता है repair. So we are repairing a hernia. How? We are pushing back the hernial sac and then we are closing the hernial defect. But why? But how? Usually by placing a proline mesh. Okay, by placing a proline mesh. And this is what is the proline mesh looks like. This is what is the proline mesh. Okay. So there will be lesser chances of hernia or lesser chances of recurrence if you have placed the proline mesh now. Okay. This proline mesh hernioplasty can be of various types, but it can be Bassini's repair, Scholdi's repair. But the most common one or the better one that is used nowadays is known as a tension-free. It is known as a tension-free Lichtenstein repair. It is known as a tension-free Lichtenstein repair. Okay? That is the best hernioplasty, open mesh hernioplasty which is done nowadays. Laparoscopic surgery can be of two types. Either it is a TAP. What is TAP? Transabdominal preperitoneal repair. It is a transabdominal preperitoneal repair. Or it is a TEP. What is TEP? Total extraperitoneal repair. Total extraperitoneal repair. Okay. And congenital hernia, as I've already told you, congenital hydrocele and congenital hernia are both treated by the same ones, that is herniotomy. Okay, just push back the hernial contents and suture back. That is herniotomy. Now a question which is Sarkari nowadays very commonly asked. Which is the most common nerve injury in a open surgery or a proline mesh hernioplasty? The most common nerve injured in an open hernioplasty. That was a recent NEET PG question. Okay, so please remember, it is what is ilioinguinal nerve. The most common nerve injury in a open hernioplasty is definitely the ilioinguinal nerve. And the most common nerve injury in a laparoscopic hernioplasty. The most common nerve injury in a laparoscopic hernioplasty. Okay, it is the ilioinguinal nerve over here. Whereas over here in laparoscopic surgery, it is the lateral cutaneous nerve of thigh. It is the lateral cutaneous nerve of thigh. And if the lateral cutaneous nerve of thigh is injured, there will be loss of sensations in the lateral part of thigh called as myalgia paresthetica. Okay. So with that, I conclude surgery. Thank you so much. And thank you for being there and for having the patience. It was nice having a session with all of you. If you like the video, please like, share, and share it with your friends so that your friends get benefit of the session. Please keep on revising. Now you have got a lot of time in your hands. So a lot of times it will happen that you will miss out. Okay. You will be distracted. Definitely ho jata hai. If you have a lot of time now, you get distracted, you get off track. Please don't do that. Okay. Maybe study for at least 6 hours, 8 hours a day. Don't study for 10 to 12 hours. Nobody is expecting that from you. But at least be that perseverant. Okay. Be persistent throughout your preparations. That's what is required. Because in last time also, when the exam was postponed for 1 month or 1.5 months, a lot of people who have studied well for the last 4 to 5 months, they lost the track. And that's the reason why they could not be able, they were not able to clear it. So please remember, don't lose the track now. Okay, at least study for 6 to 7 hours a day, and definitely you will be on the other side of the fence very soon. You will all pass with flying colors. Okay, just revise all the content properly in time. Solve a lot of MCQs. Okay, once you have done a lot of theory, the problem is a lot of people are not practicing MCQs. So please keep on practicing your MCQs. As I always say, MCQ solving is an art that you learn with practice and time. So please give enough time to MCQ solving. Read the explanation. Don't only solve. Number of MCQs does not matter. It can be 80 to 100, but the explanations will matter definitely. Okay, so read the explanations and try to understand. how to solve a MCQ definitely, okay, how to approach a MCQ. So all of that definitely matters. Thank you so much, and nice having a session with you. Take care, good night, and all the very best for your examination. So most of the questions I have covered over here. Please remember, head and neck is usually covered in ENT, and from head and neck, usually oral cavity is important, and parotid gland is important. Parotid gland is important. Nothing they ask more in detail, so don't worry about that. Solve the previous year topics and the questions. 55 to 60 slides, it will cover most of the questions. As you can see, if you compare it with your main notes, definitely for proper understanding and conceptual understanding, reading your notes and attending classes is the best one, definitely. Okay, regular classes, definitely. I have this main notes. These are huge. Okay, they are almost 180 slides, but definitely, yeah, 55 to 60 slides. I've tried to cover most of the things over here. So it will cover a lot of things. Just keep on revising, solving a lot of MCQ.